Hello, my dear friend. A very good morning to all of you in this NEET PG marathon series. We are going to start revision of all the topics starting from biostats part. You already know about central tendency, mean, median, mode. Mean is the average, median is the middle number, and mode is the most commonly repeated number. The question which they create from this part is that if there is a big number given in the question, like let's say they gave the BP of 6-7%, and the BP they had given is suppose 110, 120, 130, and 110, 120, 130, 110, 120, like that, and then suddenly 200, and they will ask which central tendency is better to measure in this case. So if there is a big number at the end, mean has this problem that mean get deviated towards big number, average goes towards big number. So in such cases with big number, we always use median. Median is best here because median remain in the center. If you arrange it, median will be in the center. And if you will arrange this distribution, 110, 110 will be here, 120, 120 is 2 times, 130 and 200 is here. So which one will be the median? There is no single number which is median, but these two number in the center is 120. So median will be 120. But if this two number is suppose different, suppose it is 120 and 124, then we will have to take average of these two number. That will become the median. Like, है ना? So either the middle number is median or the average of middle number is median. And I hope you know. Second question they ask from here is, if 200 is wrongly written and I replace 200 with suppose 110. So on changing big number with a small number, what will be the effect on mean? What will be the effect on median? So if you change big number to small, mean will decrease because average will become less, but median remains same. Okay. So while changing the number, mean will only decrease, median will remain same. Next point, which is very important to discuss, is measure of dispersion. Right now in INI-CET exam, they have asked that all this thing like quartile or outlier or percentile, what does this thing tell about? Does quartile, outlier, percentile tell about the dispersion of data? Do they tell about central tendency? Do they tell about position of data? So these three things, they tell about position of data. Because if it is quartile, it means it is at 25%. If it is percentile, if you divide 100 into each part, it is percentile. Like NEET PG result itself is in percentile. And outliers are extreme value, which we detect by box and whisker plot. So when we draw a box and whisker plot, any number which is extremely out, this extremely big number is known as outlier. And this box is between 25% to 75%. So this 25% is known as first quartile. So of course, this box and whisker plot detected this outlier, and all these things tell about position of data, not about dispersion or central tendency. Central tendency is detected by mean, median, mode, and dispersion is detected by 5 things: range, mean deviation, variance, standard deviation, and standard error. So what are these 5 things? Very easy to understand, and they keep asking question. Range means highest minus lowest. So if I want to know that in a party how much drink you will, I need to arrange, and you said, sir, maximum we can drink is 3 liter, minimum we can drink is 100 ml. So that will be the range. But range is not giving us any idea how much drink I have to arrange for all of you. If I arrange 3 liter for all of you, there will be lot of wastage of drink. If I arrange 100 ml for you, you will beat me very badly. कि मोटे औकात नहीं थी तो बुलाया क्यों, है ना? If you don't have money, why you called? So because range is not giving me any idea, what I can do is I can choose any 3 people from your batch, and I can take data from the sample, and then I will apply it on the whole class. So from this part, one thing you have to remember, what are the 5 measure of dispersion, and then you have to know 2 more things. One is what is the formula relationship between standard deviation and variance? So standard deviation is under root of variance. And second thing they ask is to identify the correct formula of standard deviation. So in the correct formula of standard deviation, we first write in the correct formula the we will write about mean, and a standard deviation correct formula is, it is of course under root of variance, but other thing is we write mean as x bar and we subtract our number from it. Number can be written as mu and we divide it by sample size minus 1. Sample size is written as n and we subtract 1 from it. So it is n minus 1 in the denominator. Why we subtract 1? This is degree of freedom. And let's say if I ask how much finger I can choose from 5, I cannot choose all the 5 finger. If I choose 1, 2, 3, 4, then the last finger remain. I don't have any degree of freedom of selection. So that's why we subtract 1 till sample size is 30. Because till 30, subtracting 1 matter. After 30, even if you remove 1, it doesn't matter. So standard deviation formula for sample size less than 30. What will be the formula for sample size less than 30? Which they will ask you to identify in the exam. This will, in this formula, there will be mean minus number. You will add all this mean minus number. This is sign of summation. And you will do square. If you don't do square, minus plus sign will cancel each other. So we are doing a square to get the correct answer. And then why we are doing under root? We are doing under root to remove this square sign. Okay. So do remember in the formula, there are 3 steps of standard deviation formula. First, there is mean minus number square to remove minus sign. Second point, we do under root to remove square sign. Third point, we do n minus 1 till 30 sample size. If sample size is more than 30, in case of more than 30, standard deviation formula will become under root mean minus number whole square by n and we sum it, not n minus 1. That's the only difference. Okay. So do remember to identify the formula. Plus, of course, they can ask it from the standard error. They can give you small numerical also. Standard error has 2 formula. First formula is standard error is standard deviation by under root of sample size. And second formula is standard error is under root PQ by n. So why this 2 different formula? Because if the data is of disease like obesity, hypertension, diabetes, all this disease data always come in percentage or proportion. Like I can say 5% of the class are anemic. So when I say 5%, 5% means 5 out of 100. 5 out of 100 is proportion. And disease data is in percentage proportion. We call such data as qualitative data. Because we cannot measure disease, we can only categorize it into various category. Like you cannot measure my obesity, you can only say कि मोटा तो थोड़ा मोटा है, बहुत मोटा है, फटने वाला है ना, mild, moderate, severe you can say, but you cannot say you are 3.2 obese. So because we are not measuring it, we are just dividing it into category, it's categorical. And do remember in qualitative or categorical data, this median and mode, they are used in this qualitative or categorical data. We use median mode. And if there is 2 or more group of qualitative or categorical data, then here we apply chi-square test. So in your exam, if they give a question to identify which test to apply and they have used the word disease, median, mode, percentage, proportion, and there is 2 or more than 2 group, you can directly answer chi-square test. Okay. But if the data is quantitative data like BP, height, weight, whatever we can measure. That's why quantitative data is also known as continuous. Then in that case, we use mean. And when we use mean, then the formula becomes standard deviation by under root of sample size. Now, let's also learn about standard normal curve and this confidence interval. So I hope you know the 3 rules of standard normal curve, very frequently asked rules. The first rule is that in a standard normal curve, mean, median, mode, all are equal to 0 because it's a standard normal. So topmost point we called as mode, middle number is median, and average is mean. All are at the center. But mainly question comes from second rule. Second rule say that standard deviation is equal to variance, and both of them are equal to area under curve, and all three of them are equal to 1. Sabka malik ek, है ना? So why standard deviation is coming equal to variance? We just read standard deviation is equal to under root of variance. So how come it is coming equal? It is coming equal because here it is 1, and if you do under root of 1, that is 1. If you do square of 1, that is 1. So only in this case, standard deviation, variance, area, all are equal to 1. Then they say that if you look at this standard normal curve, this part between -1 to +1, there will be 68% value. Between -2 to +2, 95, and between -3 to +3, 99% value will be there. So if they ask what is the area under mean +1 standard deviation, what will be the answer? Will it be 0.68, 0.34, 0.47? Here they are not asking the whole area, they are only asking this mean and +1. They are not asking plus -1, they are only asking mean +1. So they are only asking half of 68% value, and half of 68 is 34. If they say, and they have asked this question in the past, what is the area outside mean +-1 standard deviation? So if they say outside mean +-1, inside is 68%, and if you subtract 68 from 100, it will come 32. So outside will be 32%, inside will be, inside mean +-1 will be 68%, and inside mean +1 only is 34. If they say +-1, then it is 68. Next point is that what is a confidence interval and how they ask question from that. So in case of confidence interval, first thing is ki the range within which answer lies is confidence interval, and the smaller the range of value, more precise is the data. So if the range of confidence interval is bigger, it means data is less significant. There is one good question which come on this topic also. I will practice it just now. Do remember, if you have precise data, less confidence interval, that is more significant. If you have bigger range, that is less significant. And how can you decrease the range of confidence interval? We can decrease the range of confidence interval by increasing sample size. Both this question have already been asked in NEET exam previously. So let me explain these 2 points with example, otherwise it can be confusing under exam pressure. Suppose I am asking this question from a batch student of your batch. Let's say I'm asking it from an intern or a post intern, ki how much marks you will get in your NEET exam. So this out of let's say 200 question which are coming, how much question you will get corrected, how much marks you will come. So out of 200, the post intern can say, sir, I will get between 140 to 160 marks. So this is the answer of final year student. He is saying, I will get between 150 ±10. And if I ask how much sure you are, you will get between 150 plus. He said 95% sure. So this student, 95% he is confident that he will get between 150 ±10. Now, if I ask the same question from a first year student who just landed in MBBS college, and I ask how much marks you will get, he will say, sir, I am 99% sure that I will get between 0 to 200. So 0 to 200 means 100 plus minus 100. And this is a very big confidence interval. Which data is more meaningful? Of course, final year data is more meaningful because it is giving clear idea that he will pass. But first year data is so big that it becomes useless. So that's why I have written, the bigger the range of confidence interval, data become useless, less significant if it is big. Now the second point is why final year student is so sure about the range, because he have solved various mock test paper, GTs, previous year question paper, and again he is getting around 70-75% marks. So this post intern is done various practice. Done various practice means he have increased his sample size. So by increasing sample size, by increasing observation, we become sure, we become precise that this much the data will belong. Okay, so always remember, when you increase sample size, data become precise, confidence interval become narrow, and narrow confidence interval is better confidence interval. Okay, chalo, next point is कि this two formula, very simple thing based on a standard normal curve. On this, a lot of numerical can come. 68% confidence interval, mean plus minus 1. 95% confidence interval, mean plus minus 2. So, do remember these two formula. But there is one problem here, that sometime they use the word population. So, if you found that in the question population word is given, in that case, what you have to do is, you can use 68% confidence interval is equal to mean plus minus 1 standard deviation. But standard deviation is something which we use for sample. And when we talk about the whole class, the whole population, we use standard error. So here the formula will become 1 plus minus 1 standard error, not standard deviation. And similarly, 95% confidence interval can be mean plus minus 2 standard error. And in place of standard error, we can replace the formula standard deviation by under root of sample size. Sometimes they give the question in percentage proportion. Then we can use this as prevalence, because there is no mean, there will be prevalence given. Prevalence of disease is 10%, like that. Under root 2 into standard error. So in place of a standard error, this time you will write under root PQ by N. I am not doing anything extra. I am just telling you and revising the two formula of standard error. One formula was a standard deviation by under root sample size. Second formula of a standard error is under root PQ by N. So if population word is given, then you have to use this formula. If population word not given, you have to use this formula. And 95% time they use this simple formula only. But anything can come. Moreover, one more type of question, interesting question come is that in a class, suppose mean weight they had given, mean weight of class is 70 kg and standard deviation is equal to 10 kg. So they will ask 5% student will weight below what level? 5% student का weight कितने से कम होगा? So option A they will give is 50, B they will give 47, C they will give 53, and D they can give anything like, let's say 90. So 5% student will weight where? So in this type of question, when they are asking 5%, first step is find 95% confidence interval. And they have not given the sample size, they have not used the word population. So which formula you will use? You will use the formula mean plus minus 2 into standard deviation. And here mean is 70 kg. Standard deviation is how much? 10 kg. So 70 plus minus 2 into 10. It will come 50 to 90. So between 50 to 90, you can see between 50 to 90, there are 95% student between 50 to 90. This is the 95% confidence interval. Where will 5% student will lie? This is the question. 5% बच्चे कहाँ होंगे? So many students they directly answer 50. But you can see here between 50 to 90, 95% are there. And if you remove 95 from 100, 5% are left. So those 5%, 2.5% will be on this side, 2.5% only will be on this side. That means below 50, there is not 5% student. Below 50, only 2.5% student are there. And they are asking about 5%. So we can get 5% student if we get a bit inside from 50. Suppose I came till 53. So when you will come till 53, there is a probability that you can find 2.5% extra student between 53 and 50. So now how many students are below 53 total? Below 53 total student will become 2.5 plus 2.5, 5%. So simple thing you have to do is find 95% confidence interval. After finding confidence interval, 5% student or 5% value will be just above minus 2 standard deviation. If minus 2 standard deviation is coming 50, just above whatever is the answer, like 53, that will become the answer. So remember, 5% value is just above -2 standard deviation. By this method, we can find 5%. If it is not clear, do feel free to let me know in the chat box. Now we have to understand correlation and regression, coefficient of correlation, coefficient of determination. These all confusing things, very easy to understand. First of all, in any question, if they ask direction of association, or if they use the word relationship, suppose they ask that I want to know relationship between height and weight. So which test I will use? If there is relationship word, the relationship is expressed by correlation. And height and weight both are quantitative data which we can measure. So in case of height and weight relationship, you can see also that whenever the height will increase, weight will also increase. So they are going linearly. And such linear relationship between any two quantitative data is expressed by Pearson correlation. And we will discuss it in short also, that there are two type of test, parametric and non-parametric, from which NEET question also come. So whenever we talk about parametric test, Pearson correlation is the one which tell relationship between two quantitative variable, and this Pearson correlation is the thing which we use for parametric test. So P for Pearson, P for parametric. When do we apply parametric test? We apply parametric test when data is normally distributed. Suppose I am taking a weight of 200 students. Some will have less weight, some will have more weight. Majority will have weight in the center. So this type of normal distribution come when the sample size is very large. And parametric test, as I said, it is for quantitative data. So under parametric test, there are 4 tests you can say. One is pair t-test. And to identify pair t-test is very easy. In any question, if you found the word pre, post, before, after written or match data written, then pre, post, before, after or match data written, it's simply the answer will go pair t-test if data is quantitative. Like if you are taking weight of 2 group of people before giving medicine, after giving medicine. So which test you will apply? Pair t-test. And if there is 2 group of people, but you are not measuring their weight before, after, then it is unpaired t-test. 2 group but not before, after. And you are measuring weight. Weight is quantitative data. Then it is unpaired. Unpaired is also known as student t-test. And if it is 3 or more than 3 group, and you are not measuring weight before, after, just you are measuring weight after 6 months, in one group where you gave drug, one group where you did exercise, one group where you gave old drug. So if there is 3 group or more than 3 group, then we apply ANOVA. So I hope this part you should definitely understand and remember how to differentiate paired, unpaired, ANOVA. Okay, pre, post, before, after written paired, 2 group unpaired, 3 or more group ANOVA. And all these are parametric test. And in parametric test, we apply Pearson correlation. Parametric is normally distributed. When we talk about non-parametric test, non-parametric are the one which are applied on skewed data. Skewed, positive skewed or negative skewed data. And in the non-parametric test, which type of variable we use? Qualitative variable. Qualitative variable, I already discussed, it include all the disease under it. Hypertension, diabetes, anemia, all of these are qualitative data. So on qualitative data, we apply non-parametric test. And I said you already that in the disease section, if you found disease, median, mode, percentage, proportion, you will apply chi-square test. So one non-parametric test is chi-square. And there are many other non-parametric tests like Friedman test is a non-parametric test. Crucial-Wallis test is non-parametric. Wilcoxon rank sum test is non-parametric. So they have asked only one question from this time, this part, which one is a non-parametric test? So if you know all the tests which are parametric, paired, unpaired, ANOVA, and there is unpaired, sometimes we call unpaired as jet test also. So paired, unpaired, ANOVA, jet test, these are parametric, rest all will be non-parametric. Okay. So parametric, non-parametric, I hope it is clear. And whenever they talk about relationship, Relationship word means correlation. And in parametric, we apply Pearson correlation. In non-parametric, we apply Spearman correlation. है ना? Spearman correlation is for non-parametric. चलो, now, if you want to know direction of association between two variable, like I said, height and weight both go in the same direction, so it is positive correlation. If they are going in the opposite direction, negative correlation. And this plot which is here, which is telling us about correlation, this plot is known as scatter plot. So which plot tell about correlation? Scatter plot, छितराया हुआ plot, है ना? This is simple thing. Correlation tell us direction and scatter plot represent correlation. Now, what is coefficient of correlation? Coefficient of correlation tell us ki how strongly two things are associated. Okay, height and weight are linear, but if you change height, how much weight will change? So you want to know the strength, then you use correlation coefficient. And this correlation coefficient cannot go less than -1, more than +1. If you found correlation coefficient 0.1 to 0.3, it is weak correlation. 0.4 to 0.7, moderate correlation. 0.8 to 1, very strong correlation. And if somewhere it is written +1.2 correlation, 1.2 correlation, +2.4 correlation, -2.4 correlation, all of these are wrong data, because value of R cannot be less than -1, cannot be more than +1. Second thing they can give you is, they can give you graphs and they can ask which graph is showing strong correlation. In the first graph, they can give you dots which are far away. So if the dots are far away, I told you the data which is dispersed, which is spread, is not a good quality data. We want to the point data. So because this is dispersed, correlation coefficient will be less, someone around 0.05. But if the data is concentrated to the point, then the value of R will be bigger, somewhere around 0.8. But if all the data is in exactly perfect center line, then the value of R will be maximum, equal to 1. So this is there. Now, after correlation, we also have to know about determination and regression. What are those things? So coefficient of correlation is represented by R. If you do R square is known as coefficient of determination. And this coefficient of determination, what does it tell about? It tell about percentage variation. That if you change one variable, how much other will change? Percentage variation. For example, let's say after listening to this revision session, when you went to your room or to meet your friend, you found in your friend room there is fog in this rainy season, and light is dim, laptop is open, and he is watching something there with a joint in his hand, and you have found that your friend has increased the number of joint per day. Previously it was only 1 per day, now he is smoking 6 per day. So with more joint, of course, if someone is smoking 6 joint per day, marks will definitely decrease. So which type of association is here? Negative correlation, negative relationship. And the value of R can be, let's say, suppose it is -0.8. So it is showing a strong negative correlation. But if you do R square will become 0.8 square. 0.8 square will become 64, 0.64 or 64%. So this is coefficient of determination. It is telling us that by changing the joint number, marks can increase by 64%. So suppose you try to help your friend and said to him that don't smoke too much. If you decrease joint, marks can increase 64%, and there is a strong negative correlation. So what your friend will do? He will take one more puff, throw the cloud on your face, and he will say ki, bro, you are not at my level to talk. I am flying somewhere here and you are on the ground. Come to my level, take a puff, then we will talk. He will not understand. So then you can use the final arrow in your control, that is coefficient of regression. What does, and your room partner your friend can say, ki don't talk in this percentage bullshit. Directly tell me that if I decrease my joint from 6 to 1, will I be able to get 50% marks or not? Will I be able to pass or not? So if someone want to know exact variation, exact variation between two variable, then we need a mathematical formula for that. And regression has the mathematical formula y is equal to bx plus c. What is y? Y is the marks. What is x? X is the number of joint. What is c? C is this constant. And what is b? B is this angle which is made by y and x. So this angle is known as, b is known as coefficient of regression. So I hope you will remember it, that if somebody asks you in the exam that y is given, we want to know x, one variable given, we want to know other variable, then which coefficient we use? If one is given and you want to know other, you use coefficient of regression. Okay, this question has already been asked in NEET exam. One is given, how can you detect other? By coefficient of regression. And percentage variation is by coefficient of determination. And what does correlation coefficient tell us? Correlation coefficient tell us how strongly two things are related. Strength of association is by correlation coefficient. Okay, so these are the three coefficient: correlation coefficient, determination, and regression. I hope you will remember them separately and not confuse there. Now let's revise this small concept of p-value, alpha beta error, null hypothesis. So whenever you do any study, the first step is we give null hypothesis, which is written as HO. Null hypothesis simply say that my new drug is null, is lull, is useless. It is not significantly different than previous drug. Okay, so if you are saying not different than previous drug, that is null hypothesis. And of course, no two things are same in the universe. So you can say that if any difference came, this is just by chance. If any difference came between new drug and old drug, it is just by chance. So this is null hypothesis. Now, as a researcher, scientist, do you want to accept null hypothesis or reject it? See, if null hypothesis is correct, it means your drug is useless. So researcher usually want to reject null hypothesis. You can very easily understand it with a very simple example, that suppose, let's say, a boy proposed to a girl and the girl said that you are not, I have not seen you from that angle. You are not significantly different than my other friend. So what the girl gave to the boy? Null hypothesis, that you are null, you are not different than other. Now, will the boy accept null hypothesis or will he try to show the other angle? Of course, he will not accept it. He will try to reject null hypothesis and he will say, what about all those chante which we used to do, a lot of chat in night and all. So what the girl can say? That this chat I used to do with other boy also. You took it seriously. I did it just as a time pass, as a chance. As a friend, I messaged you. You took it seriously. So this is what two things in null hypothesis. There is no significant difference, and if any difference came, it is just by chance. So in the beginning, scientists tell it to look unbiased. Then he start and pre-decide what all mistake we can do. Because whether it's exam, life or research, there will be two type of mistakes. What are the two type of mistakes which we do? First type of mistake is when in the exam, you go and you tick question thinking it is correct, but you are wrong. So this is false positive. Like we pick a lot of question and it become wrong later on. You think it is positive, but it is false actually. So in these questions, you overestimate yourself. That is alpha error type 1 error. Alpha error type 1 error means saying non-significant as significant. बेकार की चीज को काम का कहना. Saying non-significant as significant. Saying useless thing as useful. This is alpha error. Like the answer which you are thinking was wrong, non-significant. You thought it is significant and you ticked it. So that is one way to understand. Second way is, you can take an example like in Baba Ramdev study of coronil drug in 2020. He took all the patients without fever, asymptomatic. He have written it. And then in the end, Baba Ramdev said, coronil drug can treat corona fever. So if every patient was asymptomatic, how can you say that it can treat corona fever? And so what he was doing, he was overestimating coronil drug. He was saying non-significant coronil drug as significant. So that is alpha error. Now what is beta error? Beta error is just opposite of that. Beta error, simply you have to remember one word, false negative. False negative. False negative means usually if you are giving NEET or INI-CET mainly, we pre-plan that I will attempt 80% question, I will leave 20%. So those 20% which you are leaving, in those 20% question, you are underestimating yourself that I can't do it. And maybe you can do it, but you left it. So whenever you underestimate yourself, whenever you say significant as non-significant and a useful thing as not useful thing, whenever you underestimate yourself, that is beta error. Significant as non-significant is beta error. False negative is beta error. You can understand it with that lover boy example also. When he got null hypothesis, he came back to the hostel and now he is doing an interview how to propose the girl. If anyone come back from the date, he asks how was the date. So first a senior went on the date, he was unable to express the feeling. But now in the hostel, junior is asking how was the date. So what senior will say? My date was significant, we did this and that also. So what senior is trying to act? He is trying to act as alpha male. He is saying a non-significant date where he unable to express his feeling as significant. He is giving false positive report for his date. And now suppose a batchmate came back from the date. So when the batchmate went on the date, he said his feeling and the girl said, why you did not express it earlier? I was waiting for 2 years. And the girl gave a kiss also on the cheek of the boy. So the date was significant. But he coming back to the hostel and batchmate is asking how was the date. He cannot tell him the reality, otherwise they all will shout bhabhi bhabhi in the college campus. They will shout the girl name and their love story can sink before starting. So the batchmate will say nothing happened. The date was normal. You know how shy I am. So what the batchmate is doing, he is saying significant date as non-significant. He is giving a negative report for the date wrongly. He is underestimating the date. So if you remember this example, alpha beta will stick in your mind, and it is very important to remember because alpha error is the same thing as p-value. Alpha error and p-value are the same thing. Only difference is alpha error we are calculating in second step, p-value we will calculate after conducting a study, but their meaning is same. So after deciding the mistake, we start conducting a study which can be RCT cohort case control, and from all this study we collect data, and on the data we apply all this test. What are the tests? Chi-square on disease qualitative data, pair t-test if it is pre-post before after, unpaired for 2 group quantitative, ANOVA for 3 or more group quantitative. So when you apply the test, result come in the form of p-value, confidence interval and mean relative risk, mean odds ratio. So in the final step, based on p-value, we decide whether our data is significant or not significant. So the one last thing which you have to remember from this part is that what is this p-value? This p-value, as I said, it is same thing as alpha error meaning wise. Only difference is alpha error is pre-decided, p-value is calculated. So p-value also means false positive. Okay. P-value definition is probability of getting significant result by chance. So you are getting significant result by chance. It means it is false positive. Like for example, I remember on my very first day of counseling in MBBS, there was a girl, Monica, who looked at me and I felt that she is in love with me. So what I did in that day, I took her by chance look as significant. And I think positive, but it was false positive. So you can understand on that day, taking one look as significant, by chance thing as significant was a mistake. So p-value is a mistake. Anyway, it is false positive. And mistakes should be minimum. So whenever p-value or mistake is less than or equal to 0.05, whenever p-value is less than 5%, it means mistake is very less. And if mistake is this less, then we can think that study is significant. And if study is significant, it means null hypothesis should be rejected, because null hypothesis tell us that study is useless. And here we are finding study is useful. So whenever p-value is less than or equal to 0.5, we say study is good and we reject null hypothesis. So they can give a small question on this topic also, like this question, that if the p-value is 0.023 or 2.3%, then which is correct? So if it is 0.023, what do you think? Which is correct? First thing is 0.03, 2.3%, that means it's very less error. And if there is so less error, study is definitely useful, significant. So answer can be either A or B, study is significant. And whenever a study is significant, we reject null hypothesis. So answer become B. But in the same question, if p value is equal to 0.23, 0.23 means 23% mistake. Now there is too much mistake. If there is this much mistake, it definitely means that study is useless. Study is non-significant because there is too much mistake. And whenever a study is non-significant, this is the same thing which null hypothesis also say, that study is null, useless. So whenever a study is non-significant, we just accept null hypothesis. So C will be correct if p value is 0.23 and B if it is only 2.3. Next question is that if in a study p value is 0.05, but in reality the drug is not significantly different from the previous drug, which error is done in this study? So scientist is saying researcher is forcefully getting p value 0.05. That means researcher say drug is significant. Researcher is saying that drug is significant. But in reality, what is happening in reality? In reality, drug is not significant. So what is happening here? Here, we are thinking that drug is useful. Researcher is saying that drug is useful, but actually drug is useless. So he's doing the same mistake which Baba Ramdev did in coronal trial. He was the researcher, Baba Ramdev researchers, they said that drug is significant, it can treat corona fever. But because no one in the study group was having fever, so that means actually coronal was not significant in treating fever. So this is Baba Ramdev error, alpha error, false positive. When you say something as significant, but it is actually not significant. So this is type 1 error, alpha error. Okay. And there is two small things we have to know: confidence of study and power of study. Confidence, so do remember, I hope this is clear. Whenever you say significant, but in reality it is non-significant, this is alpha error. It means you are saying a useless thing as significant, non-significant as significant. This is alpha error. You can understand it like this, that suppose my dear friend Siva Prasad came to me and said that, sir, you are pregnant. To me, he didn't make me pregnant, just gave it the report. So what Dr. Siva Prasad is doing with me? He is saying that my stomach is significant, but in reality it is non-significant. There is no children here. So which type of report he gave? He gave a false positive report, and false positive report he gave, so it is alpha error, so it is p value. P value and alpha error both means false positive. Okay, and I hope this concept is clear. If not, do let me know. Next is, yes, very good. Nishchay has written that example also in the chat box. Next thing is that there is two more things we have to understand here: confidence and power of study. Confidence of study is 1 minus alpha error, and power of study is 1 minus beta error. And like, it's very simple thing. If I ask how much trust do you have on your friend, क्या आपका दोस्त भरोसे वाला है या भरोसे वाला नहीं है ना? So it all depends how much lie your friends tell, है ना? निर्भर करता है कि आपका दोस्त फेंकता कितना है. If your friend tell a lot of lie means alpha error. It means you will have less confidence on your friend, है ना? So alpha error and confidence is inversely proportional. Similarly, beta error, if it is more, if we underestimate ourselves more, then our power will become less. So never say it from your mind that I have weak memory, I have not interested in reading and all those wrong things from your conscious mind, because then you will underestimate yourself and your power will decrease. So do remember these two things, confidence and power also. And we already have summarized this point that there are two types of data: quantitative data, example is BP, height, weight, HB. These all things we can measure, and all the things which we can measure like cholesterol also, they are quantitative. But if you, can you measure depression? No. Can you measure obesity? No. You can measure BMI and weight, but not obesity. So all the disease is qualitative, and in the qualitative data it can be nominal or ordinal scale. Again and again they ask this question that APGAR score, glass glaucoma scale, Kuppuswamy socioeconomic scale, depression scale, they are example of which thing? So if they use the word scale or score, all scale are ordinal. Score and scales are ordinal. Nominal are like sex, religion, blood group, which cannot be arranged. They are just two categories, they are nominal. And what is interval ratio? Interval is the one where the variable exists at 0. Like many of you must have experienced 0 degree Celsius in your life. So temperature exists at 0. It's not that at 0 degree temperature goes away. So interval example is only thing temperature. And rest all thing which we can measure in which variables are absent at 0. Like if you are measuring BP of a patient, your senior asked, what is the BP? You said, sir, BP is 0. What it means? It means patient has flied away. So 0 BP no one exists, 0 HB no one can have, 0 weight, 0 figure bolte hain. Is it possible to have 0 figure? No. It's actually some waist circumference will be there. There is nothing like 0 figure. 0 figure can be only in people like me. That is 0 figure. But that is also not 0. You understand the point? So except temperature, all the things which we can measure mostly goes in ratio. So how to remember this under exam pressure? Very simple. Before Corona, all the vacations which we get in school time is summer vacation or winter vacation. So that means due to temperature fluctuation, we get intervals of our life. So who gave us interval of our life? Temperature gave us interval. So temperature gave us vacation interval, rest are ratio. Like that you can remember. Okay. And then we have already discussed this point that if in any question they have qualitative data, then you will apply chi-square. If we have quantitative pre-post written, we will before after written match data written, we apply pair t-test. If it is 2 group of participant, we do unpaired or a student t-test. And if it is 3 or more than 3 group, we apply ANOVA. So this part is already being revised. Do revise it again, because I am expecting one more question on this topic again. So let's do a question on this topic which will make it more clear. If I ask effect of yoga on infection level or percentage of infection on infection among JR SR intern can be compared by. So we are comparing infection or percentage of infection. Infection is a disease. You can only say mild, moderate, severe infection into 3 categories. You cannot say that this patient is 2.8 infected. So infection we cannot measure, it is just categorical. And whenever it is just categorical, disease is written, which test we apply? chi-square. But if I say effect of yoga on CRP level, which we can measure, and we give 2 group JR-SR, it become unpaired t-test. If I say effect of yoga on CRP level of JR-SR in turn 3 group, it become ANOVA. If I say effect of yoga on CRP level before and after doing yoga, that's paired t-test. So it's simple to differentiate. It's not a tough topic. Now you can practice it. It will be easy to differentiate. Now there is one student in the group who asked me, Dr. Siva Prasad, who made me pregnant also. He want to know, I think he did not understand that confidence interval question. Okay. Confidence interval is not clear, or which is not clear, Siva, please tell me. But let me give you one more example of that question. Suppose they gave in any question that mean HB is equal to 12.6 and standard deviation is equal to 2. How many female, 5% female will have hemoglobin below what level? This question suppose they ask that 5% female will have HB below what level? Okay. So if this is the question and the option they have given is 8.6, 8.9, 10.6, 8.3, what will be your answer? So to find the answer, as I said, first step is find 95% confidence interval. 95% confidence interval is very simple to find, mean plus minus 2 standard deviation. Here standard deviation is 2. So 2 into 2 will be 4 and mean is 10.6. So 10.6 plus minus 4 will be the 95% confidence interval. Sorry, 12.6 is the mean. So 12.6 plus minus 4 will be the confidence interval. And what is 12.6 minus 4? 8.6. What is 12.6 minus 4? 16.6. So 8.6 to 16.6 will be the range in which 95% of female will lie. So if here is 8.6, here is 16.6, between this 95% female are there. So if 95% are inside, how many are outside? Only 2.5% are on this side, 2.5% here. Because remaining 5% will go 2.5, 2.5 on both sides. But that's why 8.6 will not be the answer, because it is 2.5 people only outside. And they are asking 5% female will go where. So to find 5%, we have to get 2.5% more female. And if we go towards 8.3, it is much lesser. Below 8.3, there will be hardly 1% female. We want to find 2.5, so we will go a bit inside. If you go a bit inside till 8.9, there is a chance that between 8.9 and 8.6, you can find 2.5% extra female. So then adding this 2.5 will become 5%. So where will be the 5%? 5%, as I said earlier, 5% value is just above minus 2 standard deviation. So first you have to find minus 2 standard deviation, and just above 8.9 is given. So that will be the answer. Okay. Chalo. So this is the point which we have to know. Coefficient of determination we have already discussed. R square. Regression we have already discussed. Regression help us to find exact variation. Y is equal to bx plus c is the formula for simple linear regression. Okay. And then we could have practiced this 1-2 question from that topic. If one variable is given, can you answer this question in the chat box, please? And Siva Prasad is saying, clear, sir. Thank you. Very good. Just like B Siva, and keep asking if you have any doubt in any session. Okay. Yeah. So follow this question. Answer this question. You got one variable, and you want to know other variable. Which variable, which coefficient will help us? Coefficient of variance, regression, correlation, determination. Please reply. I will be waiting. But before going ahead, you should know about coefficient of variance. 2 questions in NEET has came from here. Coefficient of variance is the thing which tell about 2 things. Coefficient of variance help us to compare quality of data, that which data set is better, and it also compare dispersion of data. So 2 things it compare, quality and dispersion of data, and these 2 questions has come. Some small numerical can also come from coefficient of variance. The formula of coefficient of variance is, it is standard deviation by mean. You can multiply by 100 if you want to get answer in percentage. And do remember that coefficient of variance is same thing like confidence interval. Coefficient of variance, if it is smaller coefficient of variance, it means it is more significant data. Okay. So see, we like big things in life, but 2 things which start with C should be small. What are those 2 things which C should be small? Confidence interval, coefficient of variance. 2 things with C which should be small, smaller, more significant. So what is coefficient of variance? How it compare quality and dispersion? Let's understand with a simple example. Suppose you are sitting in my OPD and 2 patients came to you, and you ask from both of them, when does it wake up? Which OPD you are sitting? My OPD in sex and marriage counseling OPD. And in names, while I was doing MD in PSM, they used to make us sit in 3 months for sex and marriage counseling. So I'm asking history of penile erection. When does it wake up? So suppose first patient said 4 a.m., 5 a.m., 6 a.m. When neighbor cock wake up, my also wake up, like that. And patient 2 said, sir, sometime 2 p.m. in night, sometime 6 a.m., sometime 10. So these 2 answers came. Now, with the help of coefficient of variance, we can compare the quality of data, that which one has better quality. And what is coefficient of variance? It is standard deviation by mean. So in 4, 5, 6, it is symmetrical data distribution. Every number is equally away. If every number is equally away, middle number become mean. So mean is 5. Without calculation, we can tell. Like here, 6 is the mean. And what is the standard deviation? It's a very simple thing. Standard deviation means how far is each number from the mean. Like how far is 6 from 5? 1. How far is 4 from 5? 1. So standard deviation is 1. In this case, what will be the standard deviation? How far is 6 from 2? 4. How far is 6 from 10? 4. So standard deviation is 4. Okay. So in this case, coefficient of variance is 1 by 5. 1 by 5 is 0.2. In this case, coefficient of variance is 4 by 6. 4 by 6 is 0.66. So definitely in second case, coefficient of variance is big. And because it is big, so it is poor quality data. Because here coefficient of variance is smaller, and because it is smaller, so it means this data is more significant. Patient 1 data is better quality because it is to the point. He is telling the lie. Patient 2 is actually not telling the lie. And it cannot be 2 p.m., 6 a.m. and 10 a.m. I'm not talking about mood. I'm talking about penis erection. So correct is the one which is to the point data. Okay. Now coming back to the question, most of you must have replied it. Yes, B. Very good. If one is given, other can be known by regression, because the formula is only in regression. So if we know the X, we can tell the Y. What was correlation telling? Correlation was telling us how strongly two things are related, strength of association. And what was determination telling us? Determination was telling us percentage variation. So do remember this one question and revise all the 4 coefficient, because it can be confusing, but if you understand it with concept, you will not do mistake here. So next question is not from biostat. Now we have finished the biostat part revision. Let's talk about epidemiological study. In the epidemiological study, in just last year INI-CET, they asked question from classification, which is very easy to understand. If we are giving some medicine, some drug from our side, आपने कुछ उंगली करी, you did some fingering, some experiment, then this part is interventional or experimental. We call it RCT. And if you do RCT on patient, they are in clinic, we call it clinical trial. RCT on healthy people, they are in field, so field trial. And RCT on whole community, we call it community trial. But the other type of study is observational. We call it Dhritarashtra study. And Dhritarashtra was a blind character in Mahabharata who just keep used to asking, "Ye kya ho raha hai? Ye kya ho raha hai? What is happening? What is happening?" And he don't used to intervene. He don't used to do anything. So similarly, in observational study, you just have to observe, not do anything. Now, when you observe, you can describe a situation, that is descriptive, or you can get some data, and along with description, you can also analyze. So that is analytic. When you use the data to do mathematical calculation, it becomes analytic. When you only describe, descriptive. So when you are describing a story of one patient who is in the hospital, suppose you found a patient with penile fracture in your surgery emergency. So you write about the whole hospital story of that one patient. It will become case study, and whole hospital story, not just that this patient came, but what history was given, how penile fracture occur. Then you will do Doppler or some scanning, that is the investigation. You will do some treatment also, and then you will say go slow, and you will let the patient go. So this is case study, one patient. But case series is when you do again hospital story, but this time the hospital story should be of one or more than one group of patient. So suppose that patient of penile fracture which you managed, you publish that article in Nature Journal, and when you publish case study, you can publish it under care study. Care means case report. So care is used for case study. Okay. And what is case series? If your Nature article got famous, and now you are repairing 3 penile fracture in Delhi, 2 penile fracture in Dubai, Al Habibi. So in this case, and you are writing all the 5 patient story, this is case series, because now the hospital story is of 2 group of patient, one or more than one group in Dubai, one group in Delhi, and you are writing the complete detail. This is case series. Okay. Then what is cross-sectional study? Cross-sectional study, we call it as prevalence study. And other name of cross-sectional is snapshot study. In cross-sectional, we simply ask some question from everyone. Like I can ask how many of you are using Tinder? And suppose 5 out of 100 said, yes, I am using Tinder. So prevalence of using Tinder is 5 out of 100. And why we call it a snapshot? A snapshot means taking picture. Can you take picture in future or past? No. Picture can only be taken in present moment. I am asking how many have Tinder in your phone right now. I'm not talking about past experience or future, will you keep Tinder or not. So cross-sectional is only done in present moment. I think you know case control goes in past, cohort goes in future. But cross-sectional is present moment. Two name you have to know, prevalence is snapshot. But the problem in cross-sectional study is known as apprehension bias. When I ask how many of you use Tinder, prevalence was 5 out of 100. But do actually only 5 people use Tinder or dating app out of 100? No. This 5 prevalence came very low because many of you did not said yes. Why you did not said yes? Because you started thinking what other people will think and your answer changed. So this is apprehension when we think about other people. And a very good example of apprehension bias is white coat hypertension. As soon as patient see doctor in white apron, BP of patient rises. Not because the doctor is hot. Doctor can be hot. But BP is rising because patient is thinking now where this doctor will put his finger in my body, which disease will come out. And so patient become apprehensive. That's why the BP will fluctuate. So this is example of apprehension bias which occur in which study? Cross-sectional study. So after cross-sectional study, next type of study is ecological study, which is known as correlational study. So they keep asking this question again and again, which study is done on population? So on population, we do only one study. On population, we only do correlational study. Rest all study are done on individual, but this is done on whole population. And why we call it correlational? Because in ecological study, what we do is we correlate the hospital data with population data. This is what we are doing. We are correlating hospital and population data. So this example can come in the exam also, that cases of breast cancer increased in USA with increase in fatty diet. This is example of which type of study? So breast cancer is hospital data, fatty diet is population data. You are just correlating it, not asking it from individual, but collecting fatty diet of whole US population. So this is one example of correlation study. Other example, like you must have heard in 2021, corona cases increased in West Bengal and Tamil Nadu after government did a lot of election rally. So election rally is which type of data? Population data. COVID case is which type of data? Hospital data. So this newspaper headline itself is example of correlational or ecological study. But what is the problem with correlational study? The problem is known as ecological fallacy. Whatever we say for the whole population is not correct for the individual. When I am saying that COVID case increased in Tamil Nadu, West Bengal due to election rally, do everyone develop it due to election rally? No. When I say fatty diet increased cancer in America, does everyone who develop cancer develop it due to fatty diet? No. So whenever we say things about whole population, we are wrong. This is ecological fallacy, problem of ecological study. Now, after discussing ecological and cross-sectional case study and case series which are descriptive, now we have to discuss the analytic study which are case control cohort. But in analytical, there is cross-sectional ecological also. Why? Because in cross-sectional ecological, we get data also, story also. So you can put it in descriptive also, analytic also. Okay. And what is case control cohort? I hope you all know. Let's understand how to find out which study is case control, which study is cohort. And before that, let's do this question. The question is, case series is an example of which type of study? Where will you put case series? Is it interventional observation? No, because interventional will become RCT. So it cannot be interventional observation. Is it analytic descriptive? Analytic descriptive is no study. The main classification is either observational or interventional. So no study can be analytic descriptive. This is gone. And it is definitely observational. But in observational, case series is under descriptive part. So it is observational descriptive. If they would have asked about case control or cohort, then answer is observational analytic. Okay. So this was the question in INI-CET exam, that which of the following is longitudinal observational analytic study. So observational and analytic, they are saying this is correct for case control also, cohort also. Both are observational analytic. But longitudinal is the other word of cohort study. So answer is cohort. Longitudinal, in PARC they have written, longitudinal means multiple cross-sectional study on fixed population, again and again at fixed interval of time, on same population at a time gap. Let me explain. At a gap of time, at a gap, with a gap, with a gap, with a gap of time, at a gap of time, like, let me explain. An example will make it clear. Suppose you took surgery, two of you took surgery, and let's say it is Dr. Nishchay and Dr. Tasmina both took surgery, and now Dr. Nishchay think that this mesh repair which we are doing is unnecessary, causing money to the patient. Even without mesh, if you repair it, open abdominal hernia properly, the outcome will be same. So what Nishchay and Dr. Tasmina did was, they took 100 patient. Dr. Tasmina did mesh repair, Nishchay did without mesh repair of abdominal hernia, and then they asked all the patients that we will call you after 1 month, every 1 month, and we will ask that did your hernia reoccurred or not. So what you are doing? You are doing again and again cross-sectional study on those 200 patients every month. Every month you are asking them once that did your hernia reappeared or not. So you are following them in future. But in this follow-up, every 1 month you are doing cross-sectional study on the same group of patient. At fixed time gap of 1 month, you are asking from both the group of the patient that what is the prevalence of reoccurrence of hernia. Did hernia reoccurred or not? So you are collecting prevalence data, but you are collecting it in a follow-up way in future. So because it is follow-up in future, you are doing, that's why longitudinal is the other name of cohort study. Okay. So therefore it is cohort study here. Now let's read about case control also a bit, and let's also read about cohort after that. So one of the question in asked in NEET exam already is, what are the steps of doing case control study? A step is, first step, we recruit the people. Case and control. Case are those which are disease. And we usually say this word to our friend, yeah, you are a case. You are a case man means you have something abnormal. And control means nothing abnormal, non-disease. Control means you are in control, man. Control means you are normal. So after taking disease, non-disease as case control, second step, we match them. For example, if you want to know the reason of anxiety in MBBS student, you cannot take one group as final year student and other group as first year, because final year, first year will have different reason of anxiety. So if you want to do a good study, you have to take case also final year student who have anxiety, control also final year student who don't have anxiety. This is matching. Matching means same people in the two group. So second step is matching. Third step is we take past history. And then in the fourth step, we calculate odds ratio, which is also known as cross product ratio. So do remember, they ask this question, in which study we find cross product ratio? And people answer that we find it in cross sectional, thinking it is cross. No, cross product is in odds ratio. Formula is AD by BC. We will understand it with example. But in case control, if they ask a step, this is the step. But in RCT, if they ask a step, what are the steps in RCT? In RCT, first step is again recruitment. You will take the people inside. But after recruitment, you will ask them to divide into two groups by random allocation. So it is randomization you will do in the second step. After randomization, you will do intervention in one group, medicine in one group, and placebo in other group. That means you will do the trial, and then you will analyze the data. So always understand this type of question of writing step is very simple. Always the first step is recruitment, whether it's RCT, cohort, case control, and always the last step is analysis of data. So recruitment analysis is same in case control, cohort, RCT, everywhere. In between, in case control we do matching and past history. In RCT we do randomization, and then we do the intervention and placebo in the two groups. Okay, so only the middle part differ. And I hope you all know the case control studies very well. But let's, sometime they can give a small numerical also from this topic. Suppose you are doing a case control study on corona patients, that in 2020 you are doing it, and you want to know why COVID is occurring in some people, not in other people. So you took two group of people, one who are COVID positive and one who are COVID negative. And then you ask from both of them that did you had contact with any person in last 5 days? So people who say that yes, I have contact, they are the one who are exposed. Exposed का मतलब होता है जो लोग कुछ गलत कर रहे हैं या कुछ ऐसा कर रहे हैं जिससे बीमारी हो सकती है. Exposed are those who are having the risk factor or who are doing something which can cause the disease. So contact is exposed, and people who are having no contact history, they are the one who are non-exposed because they are not doing the dangerous work. Okay. Now, when you ask it from people who are corona positive, before you ask, did you came in contact, till the time they got the result of positive, they are still they are thinking by themselves that who was that rascal who spread it to me. So before you ask the question, they are ready with answer. And 99% of them out of 100, 99 will tell that yes, I came in contact. Actually, all 100 came in contact. But one person went to such a place which he can't tell to you. So one person hide the history, 99 told it. Now, when you ask the same history from people who are COVID negative, do you think they will stress on their memory to take out the past history? Not at all, because they are negative. So they need not to worry. And they will say, contact, who come in contact? I was in my room, then in bathroom. Even if I give kiss to my girlfriend this day, I only give flying kiss and no touching. So they will not emphasize, they will forget the past history. This will cause recall bias. One group will remember it. Other group will say, let's say out of this second group, suppose 50 said, yes, I have the past history. Or let's say 60 said, yes, I have the past history. And 40 said, no, I did not came in contact. So we usually write this part A, this B, this C, this D. And if this type of result has came, then through this result, we can find odds ratio. What is odds ratio? Chance of disease out of exposed. Which are the people who are exposed? A and B are exposed. And out of A and B, who are having disease? COVID is only in A, na? B is not having COVID. So chance of disease is in A. And how many are exposed? A and B are exposed. So when we write chance of disease out of exposed, we write A by B. And when we write chance of disease out of non-exposed are C and D. Out of which who have the disease? C have the disease. So chance of disease out of non-exposed means C by D. So it is A by B divided by C by D. So in the next step, C by D can go above. And I hope you know, whenever someone comes from below to up, it turns upside down. So finally, it will be A by B multiplied by D by C, which is AD by BC. And you can see here very well that A is here, D is here, B is here, C is here. So you are doing cross multiplication. That is why odds ratio, which is AD by BC, is known as cross product ratio. Okay. And what is the main problem in case control study? One group who are diseased, they remember past history. Other group who are not diseased, they forget it. कांडी लोगों को याद रहता है कि क्या हुआ था, नॉन कांडी भूल जाते हैं ना. People who have some disease or incidents, they remember. Control forget. That lead to recall bias. Recall bias means cases remember past history, control forget about it, leading to wrong result. And this is why case control study is not trustworthy, because anyone can remember, anyone can forget. Due to recall bias, it is not good. And what are the other name of case control? Very simple to study. We go backward, we go retrospective. But main thing you have to understand, one thing which you can never forget, we always start with disease and go to risk factor. We start with effect, go to cause. We start with outcome, go to exposure. So start with disease, go to risk factor, outcome to exposure. This is one thing which you can afford to forget. Okay. Now, let's talk about cohort study in a very simple way. Suppose you want to know that which group will have more accident, alcoholic or non-alcoholic. So in the alcoholic group, you took 100 people. In the non-alcoholic also, you took 100 people. So in the cohort study, we are not starting with disease. We are not starting with accident. We are starting with exposure, alcohol. So this is the main difference. Cohort start with exposure. Case control start with disease, non-disease. This is the way to find out the answer in many questions in exam. I will give you some practice question also. So here 100 alcoholic were there, 100 non-alcoholic was there. Out of this 100 alcoholic, suppose 20 have accident, suppose. And out of this 100 non-alcoholic, suppose only 5 have accident. Okay. So 20 have accident here, 5 have accident here. First thing which they can calculate from cohort study is relative risk. What is relative risk? Relative risk means incidence of disease in exposed by incidence of disease in non-exposed. How many did accident in the alcoholic group? 20. How many did accident in the non-alcoholic group? 5. So relative risk will be simply 20 by 5, 4. But sometime they give a numerical question on this by giving you a table also. So let's understand again this concept also with the help of table. Very simple to understand. We are talking about accident as disease. So accident, no accident. And alcohol is the exposer. So alcohol and no alcohol. When we talk about alcohol, this is the one which are exposed. They are exposed. So exposed are A and B. A plus B are the one who are drinking alcohol. And which are non-exposed? Non-exposed are non-alcoholic people. They are C and D. C plus D. Now here A plus B is also 100. C plus D is also 100. 100 were alcoholic driver, 100 were non-alcoholic. And when we talk about accident, in the alcohol group 20 had accident, in the no alcohol group 5 have accident. So in the exam, if they ask you calculation of relative risk and both exposed non-exposed are equal, both are 100, then you just have to focus on this part of the table A and C, because then the formula of relative risk will become A by C. When it will become A by C? If exposed non-exposed are equal. But if sometime they can confuse you by giving unequal number of exposed non-exposed. Suppose one group are 100 alcoholic, one group are 200 non-alcoholic. Then the formula will be different. Let me explain that part. What is happening here, what I am telling you is ki incidence of disease in exposed. So how many are exposed? You can see exposed are A plus B. And out of A plus B, how many have the accident? A have accident or B have accident? A have accident. So A by A plus B will be incidence of accident in alcoholic. Now how many are non-exposed? Non-exposed were C plus D. And out of C plus D, how many develop disease? How many develop accident out of C plus D? Only C. So disease is C. C by C plus D. So when it comes to the formula of relative risk original formula is A by A plus B divided by C by C plus D. But in this example, A plus B and C plus D are equal, both are 100. So they will cancel out and final formula will become A by C, 20 by 5. And 20 by 5 is 4. That means if the relative risk is coming 4, it means chance of accident is how many times more? 4 times more. So relative risk always talk directly that if you drink, accident is 4 times more. So it is talking directly. That is why, do remember, relative risk is best measure of strength of association. If you want to know whether two things are correlated, associated or not, then the best measure of strength of association is relative risk, because it talks directly. And because it is the best measure, so all the people in the clinic, they used relative risk. They talk directly. Like if you go after smoking to a senior OPD, senior will smell it because he have also smoked in his time, and he will say, don't smoke. Smoking increases the risk of cancer 10 times. So he is talking in terms of relative risk. Whenever you use the word time, 10 times, 4 times, it is either relative risk or odds ratio. But relative risk is better because odds ratio come from case control study which has recall bias. So better is relative risk, which tells strength of association. So one thing you know, relative risk. The second thing is attributable risk and population attributable risk. What are those things? Let me explain with a very simple method. If I ask you, why are you successful in your life? And let me tell you, my dear friend, all of you are successful, whether cleared NEET or not, whether clear MCI or not, because you already are doctor, and 85%, 80% of Indians, they dream of becoming doctor. So you are already living your dream. So you are living the dream of 80% of Indian. Plus being a doctor, in future you will get respect, money, freedom to work under the people you want to work, and you can help people without spending money and get true happiness by helping also. So it's a very good thing that you are working as a doctor. This profession is good. You are stuck right now, but your future is very bright, secure, and full of money and happiness. Why I am telling it to you? Because if you are happy and study, your 2-hour study will have 6 hours of outcome. So I want you to be happy while preparing. Outcome will be better. In any area, outcome will be better. So let's talk about attributable risk. When I say whom you attribute your success to, you can say my success is due to my father, due to my mother. In one class, a girl said due to me, I success. So attributable means आप किसी को जिम्मेदार ठहरा रहे हो कि इसकी वजह से हुआ. इसकी वजह से मीन्स ड्यू टू, है ना. Attributable means you are giving the responsibility to someone. So whenever we talk about attributable risk, we use the word due to. And in this attributable risk, if I ask you in this example, how many 20 accident happened here, 20 in alcoholic, and 5 accident happened in non-alcoholic in our data, 20 and 5. So if I ask how many accident is due to alcohol, out of this 20, how many is due to drinking? Does all 20 accident is due to drinking? No, because 5 people can do accident even if they are not drinking. So not all 20 can be due to alcohol. 5 can be due to other reason also. So only 15 can be due to alcohol. You understand my point? So how you found the answer that 15 is due to alcohol? When you subtract 20 with 5, then you got that, okay, 15 can be blamed on alcohol, 5 can be due to any reason. So in attributable risk, what you are doing 20 minus 5. And what is 20? 20 is the people who have accident in alcoholic group, incidence in exposed. And you are subtracting it from incidence in non-exposed. So you are finding that if you want to know how many accident can be blamed on alcohol, then you have to subtract 20 with 5. You will get 15. And 15 is how much of 20? 15 is 75% of 20. So this is the attributable risk which came out. Let me explain this thing in Hindi also. आपको ये पता लगाना है कि कितने एक्सीडेंट हुए हैं दारू की वजह से. तो 5 लोग तो बिना दारू पिए भी ठोक सकते हैं. तो सारे 20 एक्सीडेंट का इल्जाम दारू पर नहीं लगाया जा सकता है. केवल 15 एक्सीडेंट 20 में से दारू की वजह से हुए. 15-20 में से दारू की वजह से हुए हैं. ये कैसे निकला? जब आपने पहले 20 से 5 को माइनस किया, एक्सपोज को नॉन एक्सपोज से माइनस किया, और फिर इसको टोटल 20 एक्सीडेंट से कंपेयर कर दिया. ओके, तो इसी को कहते हैं एट्रीब्यूटेबल रिस्क. एक्सपोज माइनस नॉन एक्सपोज बाय एक्सपोज्ड. व्हाट आई वाज सेइंग इन हिंदी वाज दैट नॉट ऑल 20 कैन बी ब्लेम्ड ऑन अल्कोहल, only 15 can be blamed on it because 5 can occur due to other reason, and 15 out of 20 accident is due to alcohol. So you are comparing this 15 exposed minus non-exposed, 20 minus 5, 15. You are comparing it with total 20 accident which occur in alcoholic group. So this is the way how you get attributable risk. Its simple formula is A minus C by A into 100 or 20 minus 5 by 20 into 100, which will come 15 by 20 into 100 or 75%. So you can say that in this story, 75% accident is due to alcohol. Due to drink and drive, 75% accident is occurring. So whenever you will use the word due to, this is attributable risk. And this small formula is the one on which mostly numerical come. But if exposed, non-exposed are not equal, then we can have to use the big formula. Big formula is A by A plus B, which is incidence in exposed, minus C by C plus D, which is incidence in non-exposed, divided by A plus B, multiplied by 100. But usually they don't give numerical on this big formula. Only A and C you have to focus, and A minus C by A into 100, attributable risk will come out. So attributable risk is 75%. Now, government can ask this question from state authority or you that, okay, alcohol is causing 75% accident in alcoholic group, in exposed group. But tell me, if we put breath analyzer on all the roads of India and we stop drink and drive completely, how much accident can decrease by? This we detect in population attributable risk. So what is population attributable risk? Population attributable risk means if all the people stop drinking, how much accident will decrease by. So definitely, if all the people will stop drinking, this all 20 accident will go away, because now there is no alcoholic driver. So all this 20 will go away. And how much was the total accident? How much was the total incidence of accident in population? In the total population, total accident which was occurring was 25. 25 accident was occurring total. And if you subtract the accident which is occurring in non-alcoholic, incidence in non-exposed, if you subtract 5 from 25, then you will get 20. So if you want to know कि अगर आप ये जानना चाहते हैं कि पूरी जनता दारू पीना छोड़ दे तो एक्सीडेंट कितना कम होगा, तो जब पूरी जनता दारू पिएगी नहीं तो ये पूरे 20 लोग 20 एक्सीडेंट गायब हो जाएगा. अब ये 20 एक्सीडेंट कैसे गायब हुआ, कैसे आया 20? जब हमने पूरे पॉपुलेशन में से नॉन एक्सपोज को माइनस किया. पूरे पॉपुलेशन में 25 एक्सीडेंट था, उसमें से 5 को माइनस कर दिया तो 20 आ गया. So what I was telling in Hindi is, if you want to know population attributable risk, first you have to know how much is the total accident in the population. Then you have to subtract how many people are doing accident even without drinking in the non-exposed. So formula of PAR is incidence in population by incidence in non-exposed divided by incidence in population multiplied by 100. In 2 of the NEET exam, they only ask you to identify the correct formula of PAR. And formula is very easy to identify. What you just have to remember is AR and PAR have almost same thing as formula. Only difference is wherever we are using the word exposed in AR, if you change the word exposed with population, then AR become PAR. That means exposed minus non-exposed by exposed is AR. Population minus non-exposed by population is PAR. Okay. So do remember this definition and do remember the formulas we have discussed. Exposed minus non-exposed by exposed is AR. Population minus non-exposed by population is PAR. Okay. So this is AR PAR thing which we have calculated here also. But this 33% is not correct calculation because our data was different, 20 and 5. Original data was 10 and 5. So if the data is 10 and 5, it will come 2. But our data was 20 and 5. So relative risk was coming 4. And our attributable risk was coming how much? 75%. We have calculated it. Population attributable risk we can calculate, but usually they don't give calculation on PAR. So we can leave that part. If you want, we can do that, but no numerical can come on PAR. And one more thing you should know, what is the difference between incidence and incidence rate? Because this two things we also find in cohort study and a lot of questions are coming from this topic. So incidence, sometimes you can call incidence as cumulative incidence. Incidence or cumulative incidence means the definition is definition of incidence is that we are finding the new case and we are dividing total new case with population at risk. How many people can become disease? That we are writing below. And in the above part, we write new case. This is incidence. For example, if in your class 10 people have cough and cold today, and total population of the class is 100. 10 people have cough and cold today. 5 people develop cough and cold tomorrow. So what is the incidence of cough and cold tomorrow? New case of cough and cold tomorrow will be 5. So 5 new cases there. But out of all 100 people, 10 people were already having cough and cold. So those people who already had cough and cold, they cannot have cough and cold again. So we have to subtract those 10 people who were old case. We subtract old case from population and then we get the value of incidence. New case by population minus old case if you will do, this will give you incidence. Small numerical have already came on this topic in recent INI-CET. It can again come in NEET. New case by population minus old case you will do, then you will get incidence. And if someone is immunized, you have to subtract those person also who are immunized. Because if someone is immunized, he cannot be at risk. So you will subtract that also. Now what is incidence rate? Incidence rate means you are adding total new case but total new case added over time. So new case divided by person into time. This is incidence rate. So whenever you find the word time and new case, this is incidence rate definition. They have only asked the definition part, that total new case added over time is known as incidence rate. So new case added over time, incidence rate. Cumulative incidence is different. And when they ask prevalence, I hope you all know the formula of prevalence. Prevalence is incidence into duration of disease. Okay, that's why they ask this common question, that suppose you found a new drug for diabetes and hypertension which cannot cure the illness, but it can decrease the death. Can't cure but prevent death. So if a drug for BP sugar can't cure BP sugar but prevent death, so because it is not curing and preventing death, so people will suffer for a very long time with BP sugar problem. And when they will suffer for longer time, duration will increase. And if duration will increase, prevalence will increase. So this drug, this will increase prevalence. And I hope you all understand that no drug can prevent new case from becoming diabetic hypertensive. Diabetes hypertension is due to lifestyle changes and all. So always remember, if they talk about any drug, incidence will not be affected. Incidence is affected by social and prevention changes. It's not affected by drug. Incidence same by drug, but prevalence will increase because people are not dying, they are suffering for a long time. But if they twist the question and they ask the question that a new drug cure disease quickly, then what will happen? So if a new drug is curing disease quickly, in that case, duration will be less. Like you found a drug which can cure cancer in 1 week, some cancer, prostate cancer. So now the total burden of prostate cancer will be less. So prevalence will decrease. But the new case of prostate cancer will not be affected by drug. So prevalence will decrease, but incidence will remain same. Okay. So do remember, if drug cure quickly, prevalence will decrease. If drug do not cure, prevalence will increase. And incidence remains same in all the case. Okay. Chalo. Next is, what are the problem in cohort study? First problem is one group of people leave the study, run away before completion. This is known as attrition bias. Second problem is, if you know that you are under study, your behavior will not be natural and that will give us wrong result. Like for example, when you were at your home during vacation, in front of your parent, you are so innocent. And so if your parents are asked about their kid, they will say our kid is very innocent and very good. But when you come back to hostel after leave, then you will start smoking, you will start drinking, and you will be started abusing at teri maa ki teri behan ki de sutta de daru. So if the study is done, then the result will be wrong based on observation by your parent. The result will always be wrong because in front of your parent, you are under attention. If you light a cigarette in front of your father, the cigarette can go the wrong way. So in front of researcher, behavior is different, real behavior is different. That lead to wrong result. This is known as Hawthorne bias. So Hawthorne and attrition bias occur in cohort study, recall bias in case control, apprehension bias in cross-sectional, and ecological fallacy in ecological correlational study. Now, what are the other name of cohort? It's very simple to understand, but main thing you have to focus is incidence, new case. You will have new boyfriend, new girlfriend only in the future. So new case is only in those study where we go in future cohort study. So these are the 5 names: prospective, forward, follow-up, incidence, longitudinal, because we are going in future. But main thing you have to remember is, we always start with the reason and then go to the outcome. We start with exposure, then go to outcome, risk factor to disease. So this is the main thing to remember, that cohort start with risk factor. So whenever we talk about cohort, in the cohort, exposure is present, outcome is absent. We know the reason, like the reason can be alcohol. We don't know how many accidents occur. But when we talk about case control study, in case of case control study, exposure is absent, outcome is present. And suppose outcome was COVID. So corona has already occurred in that example which we discussed. But we don't know how many people came in contact. So outcome is present in case control and exposure is yet to be detected. Exposure is not yet detected. And you yet have to found the exposure. You cannot tell anything about exposure in case control at the beginning. You can only tell about disease at the beginning in case control. So based on this small concept, a very good confusing question came again and again, that suppose you are working as a medical officer in charge at a PHC and a villager came to you and said ki sir, in our village a lot of cancer cases occurring, and the reason of cancer cases is that the nearby factory is putting all his dirty water in our village water and that is causing pollution. So please do a case control study to prove that factory is causing it so that we can close the factory. So now you think, okay, I will do a case control study on this topic. The question they will ask is, which will be taken as control? Which you should take as control? What will be your control? So what will be control? So we all know control means they should be non-disease. And if you look at option 4 is written all village children with ALL. So if you take people with ALL, it cannot be control, it will be case. So option 4 is gone. Now tell me, what should be the control? Will you take all village exposed children, all non-exposed children of city, or will you take mixed population of children from nearby OPD without ALL? Which should be taken as control? So you can see in option A and B, before starting the study, they are already telling that all are exposed. And in a case control, we don't know about exposure at the beginning. So we can't say all are exposed or all are non-exposed. This information we collect by asking history. And in case control, remember what I discussed, in case control, exposure is not yet detected. We cannot say that all are exposed, all are non-exposed. We don't know anything about exposure in the beginning. So in a case control study, we cannot take exposed, non-exposed as control group. This is something which we have to ask. We can take mixed population of children from nearby OPD as control, because in this group, we don't know how many are exposed, how many are non-exposed. We will take the history. And based on the data, we will calculate odds ratio and then prove that whether the cancer is due to village water or not. So remember, all exposed, all non-exposed, we cannot know at the beginning. Second type of question they can give is to identify what will be the two group in a suppose cohort study. What will be the two group? Can you answer this question? The question is that we all know that if you order food online, it can cause obesity. And now you have to do a cohort study on this topic. So if you have to do cohort study, what will be the two group? Will the two group will obesity present absent, or will the two group will be online ordering present absent? What will be the two group, A or B? Please reply. Okay. Very good. Nishchay Gangwar is in really energetic mode. He is explaining also the answers. Very good. Thank you, Nishchay. Thank you, Siva Prasad, Smina, Bunny, Seetal, Sanjay Ram, for replying in this group, and a lot of other students, Neetu Pathak and all. Chandan Kumar is also replying. Thank you so much. Do answer this question. Neetu Pathak has asked a question, isn't number minus mean? Mean minus number. The formula of standard deviation is what Neetu Pathak is asking. Don't doubt this formula, dear. Standard deviation formula will also have mean minus number. Okay. And anyway, it doesn't matter whether you number minus mean or mean minus number, because you are doing square of it. So if you will do square and you subtract anything, minus sign will go away. That's why we are doing square, to remove minus sign. But in the original, all the biostat book, it is always written mean minus number. So mean we write here, then we write number. Mean minus number, and add all of them, divide them by sample size minus 1. This is the formula of standard deviation if sample size is less than 30. Okay. Chalo. Similarly, if you have any doubt, feel free to ask it. Okay. Chalo. Now, okay. So answer has came B. Very good. if it is cohort is starting with risk factor present absent. And what is the risk factor? Online food ordering. So in case of cohort, answer is B. But if they ask if it is a case control start with case who are disease, control who are non-disease. So obesity present absent will be case control and online ordering present absent will be cohort. Now next question is, let me put the question directly. The question is, okay, which of the following tell best indicator of strength of association? Best indicator of strength of association is relative risk. Relative risk tell strength best. Now let's do this type of question. Question is, they can create such confusing scenario that alcohol addiction is causing more divorce, and that to excess alcohol addiction. If you are drinking every day, alcohol can occur, divorce can occur. Then in a study, participants who are divorced, one group are divorced, are compared with participant without divorce. So if you are comparing divorce and without divorce as two group, this study is case control, cross-sectional, cohort, ecological. What is the answer? So to find answer in such a question, you have to think at the beginning, what is the starting point? Excess alcohol addiction. So this is the exposure. Yahi hai karan. This is the reason, exposure, risk factor. And in the study, if the two group are exposure present, exposure absent, like excess alcohol addiction present absent, then the answer will become cohort, because exposure present absent, excess alcohol present absent is cohort study. But what is the outcome? Outcome is divorce. And if the two group is outcome present absent, divorce present absent, then answer will become case control. And in this example, you can easily see that one group are with divorce, one group without divorce. So they are taking two group who are outcome present absent. So that means the answer will be case control. कारण है नहीं है, अगर दो ग्रुप होगा, जैसे दारू ज्यादा पी रहे हैं, ज्यादा नहीं पी रहे हैं, दो ग्रुप होगा तो कोहॉर्ट होगा. और अगर परिणाम है नहीं है, outcome present absent is the two group, like here divorce is the outcome, then and two group is divorce present absent, then the answer will be case control. So if you want to make it cohort, you will have two group, excess alcohol addiction present, excess alcohol addiction absent. Okay, so let's do one more question. Excess use of steroid is causing more diabetes. So it's clear from the beginning, excess use of steroid is the exposure, this is the reason, and diabetes is the outcome or disease, and so diabetes is the outcome. Now it's very simple to answer. Please do reply. What is the result? What is the answer of this question? I am not going to simplify for you. Just answer it by yourself. That will you make it as will you say it as cohort? Cohort is when exposure present absent is the two group, and case control is when outcome present absent is the two group, then it is case control. So what two groups are here? Is it exposure present absent or outcome present absent? The two group that they have written is, one group are taking it from quack who give excess steroid. So quack are giving excess steroid. Another group take it from PHC who don't give excessive steroid. So one group are getting excess steroid, one group are not getting excess steroid. Excess steroid present absent, that means exposure present absent. So the answer will be cohort study here, because the two group is excess steroid present absent. If the two group are diabetes present absent, then answer will be case control. Case control will be outcome present absent, diabetes present absent. So it's very simple to answer such question. You just have to focus. What is the exposure? What is the outcome? Now, if the two group are exposure present absent, cohort, outcome present absent, case control. Okay. Chalo, very good. Now let's come to this one more question. Among 10,000 mother, a questionnaire asking about smoking and after habits of smoking were distributed. Smoking and other habits. This is other habits. Smoking and other habits question. Like you are asking with 10,000 mother ki kya tum sutta piti ho, kya tum daru piti ho, tum ganja kyun nahi phukti ho, hai na? You are asking everything about smoking, alcohol from 10,000 mother. And after asking it, you are keeping that answer in the form of questionnaire. Then you did 6 months of follow-up study, and finally you compared after 6 months that which group of mother are having low birth weight children, smoking mother or non-smoking mother. And to compare that, you also use written data of questionnaire. So there is 6-month follow-up plus written data of questionnaire which you collected in the past. You are using that data also. So this is example of which type of study. Is it retrospective cohort, nested case control, cohort case control? What is the answer? Please do reply. Which answer will come here? This is a question PYQ already being asked. We have to understand this new topic also. What is the answer? So first thing is, in the question you can see the word follow up. Follow up means we are going in future. So definitely case control is gone. And retrospective cohort is also gone. Because retrospective cohort, which is also written as historical cohort, these will be the answer if only past written record is compared. For example, if in a question they are asking that workers who are working in coal tar factory and they are swiping the chimney, they have 9 times more risk of Tata's cancer, testicular cancer, as compared to those people who are working in office of coal tar factory. So office worker and coal tar factory worker, their data of last 20-year work experience is compared, and based on last 20-year work record data, it was said that coal tar chimney wiper have 9 times more risk of testicular cancer. So here you are only using past 20-year work record data, and based on that you are saying it. So this is retrospective cohort because only past record is taken. And in case control also we go in past. So how case control and retrospective is different? In case control we take personal history. In retrospective cohort we don't take personal history, we use past written record. That is retrospective or historical cohort. Okay. So answer cannot be A, cannot be D, it can be B or C. And because there is follow-up, so it can be cohort. But the problem is there is not only follow-up. Along with follow-up, there is written data of past also used. So this answer of this question is nested case control. You will answer nested case control. Nested case control has 2 more names. You call it mixed cohort, ambidextrous cohort. So whenever this answer will have follow-up, and along with follow-up, you also have past written record. Follow-up plus past written record of questionnaire, of data, anything. Then it is nested case control. And other name of nested case control is mixed cohort and ambidextrous cohort. So nested is mixed cohort also. Sometimes they can write mixed cohort. Sometimes they can write ambidextrous cohort. Now the problem is how to remember all these 5 names. This is not a problem actually. Let me tell you. You can use a simple mnemonic Rh positive man, because erythroblastosis fetalis occur only when the man is Rh positive and mother is Rh negative. So why RH? RH stand for retrospective and historical. So RH is this part, retrospective historical, where we go only in past. And you know man na, आदमी की फितरत वो आगे भी जा सकता है, पीछे भी जा सकता है. Man can go anywhere, front and back both. So when you are talking about both the thing, follow up plus past data, then you are looking at man, both the things. What is man? M stand for mixed cohort, A stand for ambidextrous. Ambidextrous because forward backward both, so ambidextrous. And N for nested case control. तो हम लोग इसको nested case control क्यों कहते हैं? क्योंकि देखो असली मेन काम है 6 महीने फॉलो अप करना, वो टफ स्टडी है. क्वेश्चनियर का डेटा तो ऑलरेडी एक दिन में इकट्ठा हो गया है, आप उसको तुरंत यूज कर लोगे. मेन काम है कोहॉर्ट, और कोहॉर्ट में पीछे केस कंट्रोल के डेटा को हमने घुसा दिया है. तो केस कंट्रोल ने घोंसला बना लिया है किसके अंदर? कोहॉर्ट के अंदर. इसलिए इसको कहते हैं नेस्टेड केस कंट्रोल. घोंसला किसने बनाया? केस कंट्रोल ने. लेकिन असली में ये कोहॉर्ट है जिसके अंदर घोंसला बना है. व्हाट आई वाज सेइंग इन हिंदी वाज that here the main tough work is to do 6 months of follow up, है ना. This is cohort is the main problem, tough study. Case control data of past questionnaire data you can collect in one day, and then you can easily put it in the cohort. So what you are doing here is, in the cohort you are inserting the data of past. So it means case control has made a nest inside cohort. That's why we call it nested case control. So remember this 3 name, and in this 3 name you will have follow-up plus past data in mixed and respective nested. Whereas in retrospective historical, only past written record will be there. And this one question I am expecting to come again in NEET exam also. So be ready for that. Chalo. Now, after discussing all this cohort, case control and different studies, let's also read about meta-analysis, systematic review, which they ask from this topic, evidence-based medicine. See, evidence-based medicine means you are taking clinical decision based on data coming from studies. And in this meta-analysis, this is the best study because we combine many studies together to make meta-analysis, systematic review. So meta-analysis is known as analysis of analysis, because first when you do RCT, you analyze the data one, and then again you are collecting all the data of RCT on one topic and you are analyzing it again. So that's why it is analysis of analysis. Second is systematic review. The only difference between meta-analysis and systematic review is, in systematic review we only collect theoretical result, not data. But in meta-analysis we compare and collect theoretical result and data both. So best type of evidence come from meta-analysis, then systematic review, then RCT, then cohort, then case control, then cross-sectional, and then case series, case study, and last evidence come from my opinion, expert opinion, because expert opinion can be biased. So don't trust on me, trust on evidence. And based on evidence, I'll let you tell one more thing. There is 2 controversy regarding ASA. One ASA is at 1000 only, and minimum education of ASA is 8th pass, not 10th pass. Why I am saying it? Because I have the evidence. It is written in 3 places in recent edition of PARC that ASA minimum qualification is 8th pass, not 10th pass, and 1 ASA is per 1000. Similarly, if they ask about USA, how much is the population norm of USA? USA is at 1000 to 2500 population. Okay. And then USA report to urban A&M. Urban A&M is at 10,000. That means in the urban area, sub-center is not available. That is why in Delhi, they opened Mohalla Clinic, and in Chennai, Jayalalitha government opened Amma Clinic, because sub-center is not there. This question has also came. Then after urban A&M, they will report to urban PHC, and they have asked in past that what is the population norm of urban PHC. One urban PHC is at 50,000 population. And then 5 urban PHC will report to 1 urban CHC. This urban CHC can be at 2.5 to 5 lakh population. And can you open urban CHC near district hospital, near medical college? Answer is yes. Because if space is not available, you can open it together also. Less serious patient will go to urban CHC, more serious patient will go to medical college or district hospital. And after this, there is medical college. But before Usha, there is MAS. MAS stands for Mahila Arogya Samiti, group of urban slum area female who will hold monthly meeting and report to Usha. So this MAS is at 2200 household, 2200 family, and one family is having 5 member. So it is 100 to 500 member or population on which MAS is there. They have already asked USA and urban PSC, they can ask MAS also. 2200 household, which means 100 to 500 population, one MAS is there. MAS, tufan utha de, one man army like that. Okay. So I hope you will trust on evidence from PARC, not on expert, because expert opinion list evidence, no matter how big expert it is, no importance. Trust on evidence, PARC. If you wish, I can send you the picture of PARC for this thing. You can always message me on my WhatsApp and I will share you with the picture of PARC, or any other question or doubt or any problem we are facing, you can message me. Chalo, now, in the evidence-based study, how they ask question? The question is, we will come to the question. The question they can ask is, yes, which study is best to compare effect and outcome or cause to effect? Is it cohort, case control, case series, cross-sectional? Anyway, we know cause to effect is the other name of cohort. But the second logic is, out of these 4, in the evidence-based medicine, cohort is above. So answer will be cohort by 2 reasons. One is cause to effect. Cause to effect is the other name of temporal association. Cause to effect is also one more name of natural history of disease. So if they ask this question, that natural history of disease is best detected by which study? People think history, so case control, but no, natural history or temporal association or cause to effect, all these three things are best told by cohort study. And this was Hill association criteria. If they ask what is the strongest Hill criteria of association, so strongest Hill criteria is temporal association. Natural history is the strongest criteria, and you will get natural history when you do follow up. When you observe someone, then you know why this person is doing accident, why this person is falling in love, why this person have breakup. Only the room partner can tell the reality, not the other batches. Why? Because room partner has followed that person, he know that person closely. So if you follow up, and follow up occur only in cohort study, so only cohort study can tell temporal association, natural history best. And this is strongest Hill criteria. Now they can ask a second question from here, which of the following is not included in Hill criteria? So Hill criteria do not include sensitivity. It do not include sensitivity, but it do include specificity. For example, only aniline dye industry worker had bladder cancer. So it means bladder cancer and aniline dye industry is specific in only those workers. So specificity is a criteria, but sensitivity is not a criteria in Hill criteria of association. Okay, chalo. So this is one type of question. Which study is strongest? Let's do this question also because it has came already. Which is correct for case control study? Done for rare disease, cause to effect, effect to cause, prevalence study. We all know prevalence study is cross sectional, so this cannot be correct. And cause to effect we all know is cohort, temporal association just now written, so this can also not be correct. Correct is either done for rare disease is effect to cause. One thing is sure, that in case control we start with outcome or disease, then we go to the reason. So effect to cause is definitely correct. Done for rare disease is not completely correct, because you can do case control even for common disease. But do remember, case control study is easy to do for rare disease. If they have given easy to do for rare disease, that will be the correct answer. But done for rare disease is not completely correct. But they can ask it again and again. Which study is easy to do for rare disease? Case control. Because in case control, you can ask history in one day and study will be done. Okay. So this is the 2-3 question which can come. But before going ahead, let's revise what is the difference in meta-analysis, systematic review. Suppose you have any question in your mind. Let's say I have a question that in honeymoon night they give kesar or turmeric flavored milk to the bride to drink, so that he will perform better. But I think they in Meenakshi Sunareswaram movie they were telling that girl also was asking that give me also, because air should be equal in both tire, then the vehicle will run fast. So of course everyone need it. But the point is, let's say I am a scientific person or you are a scientific person and it is your honeymoon night and you got this kesar flavored milk in your hand and you are about to enter in your room. Now you are thinking, if I drink milk, due to more food in stomach, blood supply will go in the stomach and not in the organ where I want it to go. So whether milk will increase performance or will make you sleep? Scientifically, it looks like it make you sleep. You don't accept what people are doing from hundreds of years. So then what you can do? You can put hand in your pocket and take out phone. And on that phone type, study on association between milk and sexual performance. If you will type it, study on association between milk and sexual performance, 4 study will come out. How I know it? Because I have done that search already. And out of that 4 studies, so what is the first step you have done? First step you have done is you have searched on PubMed, Google Scholar and various websites. You have searched for all study on one topic. And nowadays you can search on AI simply any topic you put and search all the study. After searching for all the study on one topic, first theoretical result will come. Some will say yes, it increased performance. Some will say no. So if you combine only theoretical result after searching, this is the second step, combining theoretical result. Then you call it systematic review or systemic review. So in systemic review, you are only combining whether milk will improve sex or not improve sex. But suppose along with improved sex or not improved sex, you are also combining the data that after drinking milk, testosterone increased by this much or decreased by this much. You are taking the blood parameter and comparing the data plus theory both. Then it becomes meta-analysis. Okay. And in meta-analysis, we are drawing two type of plot, forest and funnel plot. Image-based question can come from it also. So let's see forest and funnel plot. This is forest plot. So what type of question can come? They can ask from this diagram that how many study show causative association. How many studies show causative association? Causative, I hope you all know. Causative means positive. So we say causative or positive association only when relative risk or odds ratio is more than 1. So if it is more than 1, we say positive causative association. And in this forest plot, this line is showing odds ratio of 1. And I hope you all know odds ratio, whenever it comes 1, it means there is no association. For example, smoking and accident. There is no association between smoking and accident. So this is no association with odds ratio 1. And in this image, you can easily tell that out of 4 study, first study is crossing this line 1. Fourth study is also crossing this line 1. So when it crossed this line 1, it means it is 0.8 to 1.4. 0.8 is relative risk or odds ratio less than 1. And whenever relative risk or odds ratio is less than 1, I hope you all know less than 1 means negative association. Negative association is also known as protective association. Protective or negative association. So if you got this line, odds ratio 0.8, 0.8 means you drink milk and you will sleep, sexual performance will decrease. So 0.8 is negative. 1.4 is saying drink milk, sexual performance will increase. So if the same milk is sometime decreasing sex, sometime increasing it, it means milk has no effect. And I try to change the partner or try to do something else. Because sometime decreasing, sometime increasing, it means there is no association in study 1. Similarly, study 4 also crossed this line, no association. But you can simply see the image that study 2 and 3. 2 and 3 are not crossing the line. So because 2 and 3 are not crossing the line and they are more than 1. So which 2 studies show positive association? Study 2 and 3. How many studies show positive association? 2 and 3. That means total 2 studies are showing positive association. Second question which comes from this point is, sometimes they will write confidence interval in the range 0.8 to 1.4, 0.9 to 1.1, 1.1 to 1.4, 1.1 to 1.6. And they can ask out of these 4 studies, which study is most significant? Which is most significant study? This type of question are coming in INI-CET and NEET also, that they will give confidence interval and they will ask which is more significant or which is significant, which is more significant. So from this confidence interval, you can understand, I hope till now, that if it is 0.8 and 1.4 both, it means it include 1 in the range. And if 1 is in the range, 1 means no association. So if it is negative, positive both, it is non-significant. Again 0.9 and 1.1, it include 1. So this is also non-significant. So first and second study are non-significant. Now you tell me out of option C and D, which one is more significant? C is more significant or D? So I discussed it already that narrow is the range, more significant the data is. So C had a narrow range, that's why C is more significant. D has a bigger range, so less significant. So like that, if they ask the question on this topic, you can easily answer. Chalo, so this is forest plot, which help us to summarize all the data of meta-analysis, all the data on various study together. And this is funnel plot, where we can see 2 study are showing positive association and 2 study were showing no association. And on the y-axis, we have a standard error. On the x-axis, we have positive and negative association. This is funnel plot. So funnel and forest plot are drawn in which study? Meta-analysis. So now, which is the best study to detect natural history of disease? So I have already answered this question. When they write natural history, don't think case control. Natural history is done by follow-up, and follow-up is done in cohort study. So cohort is the best to know temporal association or natural history or cause precede effect. Now, Try to answer this question. This was a very good question in NEET exam. They said that there is CRP level and MI graph. If CRP level is increasing, chance of heart attack is here like this. So which statement is not correct? High risk of MI is due to high CRP. High risk of MI is associated with low risk of MI with low CRP. High CRP with higher risk, or none of the above. So first thing is, we have to remember one very strong line which Hill said in Hill criteria, that correlation does not imply causation. This question has also been asked in true false question in NEET and INI-CET both, but some time back. Correlation does not imply causation. What does it mean? It means if two things are happening together, it doesn't mean one is causing the other. For example, in 2021, Government of India said that due to more vaccination, corona cases are coming down. That's what government said. But government was totally wrong in saying that. Why? Because in the world, there were 5 countries who did 95% vaccination. Still second wave of corona came. China, Seychelles, Israel, US and UK. They vaccinated 90% people, still second wave came. It means vaccination was not causing low cases. It was maybe natural mutation in the virus, and it has been found that virus gradually become less lethal, more infective. And so it stopped killing people, and that's why we stopped registering the disease. Anyway, so the point here is, if two things are happening together, high vaccination, low case, it doesn't mean one is causing the other. So two things doesn't mean one is causing other. And here in the first statement, they have used the word due to. Heart attack is due to CRP. You cannot say that heart attack is due to CRP. Heart attack and CRP are associated. You can say that. But you cannot say one is due to, one is causing other. Correlation does not imply causation. Okay. So no, wrong statement is due to word. So next question. We are now moving to concepts of epidemiology, from which the first concept I want to discuss is Kaplan-Meier survival plot. Suppose your not so good relative or neighbor came to you and asked that my relative has been told to go through stent or angioplasty. Which is better, which I should go? So you can tell to your neighbor that by looking at your face, I feel like pissing, if you don't know the answer. And go to washroom, put hand in your pocket and take out your phone and type Kaplan-Meier survival plot between angioplasty and stent. If you will type it, this type of step ladder pattern plot will come out. This is Kaplan-Meier plot, and what is the purpose? It compares survival time of 2 or more intervention. So here in the y-axis, we don't write number of patients. In the y-axis, we write survival probability. What is the probability of survival? And we are comparing survival probability with years of survival. How many years you are surviving? And you can see it yourself here that with the stent, more survival probability is there. Stent is above, angioplasty is below. So stent has better survival. The one which is above is better survival. But it's not necessary that stent has better survival. Maybe because stent company are earning millions of rupees, so they could have in the research given stent only to young people who are 40 to 50 years, and they did angioplasty in those who are between 70 to 80 years. So 70 to 80 year people are anyway going to die. They will die, and comparatively it will come that stent is better. This type of bias is known as selection bias. When you select wrong type, unequal type of people in two groups, like young in one group, other in another, old in other group. So what I'm trying to say here is that one image-based question step ladder pattern, you can simply answer Kaplan-Meier. What is the purpose of Kaplan-Meier? Compare survival probability of 2 intervention. But we can never be sure about survival probability. Here I am writing that, let's say at 5 years, survival probability is 20% with bypass and around 80% or 70% with stent. 20%, 80% survival probability. But if a patient is doing walking and other exercise after surgery, then his survival probability can also be 90%. and if he is not doing exercise after surgery, he is bedridden, then his survival probability can be 70 also. So that means survival probability always come in a range. It is never to the point. And this range of survival probability is known as confidence band. This is known as confidence band probability. And confidence band is of 2-3 type which we use. Okay, one confidence band is known as equal precision band. And in one of the INI-CET question, they ask which is not a confidence band. Which is a confidence band, they can ask. Which is not a confidence band, they can ask. So you have to know the names of confidence band. One is equal precision, other is Hall and Wellner confidence band. Hall and Wellner confidence band. Okay. So these are, one more is simultaneous confidence band, but mainly these two names you have to remember: equal precision, Hall and Wellner. So in that INI-CET question, one option was Hall and Wellner, one option was unequal precision, and they asked which is confidence band. Unequal precision is not the band. Band is Hall and Wellner or equal precision. Okay. Plus one more question on this topic has came in INI-CET already. They gave 3 plot A, B, and C, and they ask which one is having better survival probability. So this type of plot is used in US and UK to decide survival probability of cancer patient. And they will tell the patient that, dear patient, if you did surgery only, this is the survival probability. If you did surgery plus radio, this is the probability. If you did surgery plus radio plus chemo, this is the probability. So you decide what we should do. And of course, the one which is above has higher survival probability, and the one which is below have more year of survival. So which one has better survival probability? Of course, C has better survival probability. Okay. So I hope you can do question of Kaplan-Meier plot and survival probability very well. Chalo. Now, before moving ahead, let's move ahead and discuss this concept, very simple concept asked already in NEET exam, tracking phenomena. If you look at the BP of people with age, it looks like when you measure BP at a younger age and it is low, it will remain low even at higher age. And if you measure BP at a younger age and it is high, it will remain high at older age. So it looks like BP is tracking the person. BP पीछा कर रही है. And this question came in NEET exam exactly in the same way, that a BP of a group of people was taken and it was found that person with low BP at the beginning also had low BP at the end of study. Which phenomena is this? So this is tracking phenomena. Okay. BP, if high at young age, it will remain high at older age. So we should not make our children fat. We should try to give good habit at a young age. Okay, that is tracking phenomena. Then in the rule of half, the question they have asked is, what is the innermost circle telling us? Innermost circle telling us about those treated patients who have adequate control. Because not all who get treatment have adequate control. So do remember, if they ask what is the last circle telling about adequate control. First circle is about all the adult population. Half of them have non-communicable disease, and out of the half population who have non-communicable disease, only half people know about it. And out of the people who know it, only half take the treatment. And out of the people who take treatment, only half have adequate control. So inner circle tell about adequate control. Chalo. Next is, if you look at iceberg phenomena, in the tip part, we have those patients who are going to hospital. In the base part, we have those patients who are subclinical. Subclinical means who recover without going to hospital. Recover without going hospital. They are subclinical. Okay. But in 5 cases, there is no subclinical case. In 5 cases, you cannot recover without going hospital. What are the 5 cases which you cannot recover without going hospital, which the symptom will be there? They are definitely rabies. You can remain hidden for some time, but ultimately you will go to clinic and report. So in case of rabies, measles, tetanus, mainly these 3 they ask, but there is also neonatal rubella and pertussis. these 5 cases, they have, everyone will develop symptom. But like, let's say, talk about corona. Many people, they don't have symptom. So they've never reported to hospital. Let's talk about polio. If one clinical case of polio came, it means there are 999 children in that area who already have the polio virus, but they recover without paralysis. So this is iceberg phenomena, and in these 5 disease, they can sometimes twist the question and they ask which of the following disease do not have subclinical case. So these 5 disease have no subclinical case. No one recover without symptom. So because there is no subclinical case, these 5 disease don't show iceberg phenomena because they have no hidden part. So they don't show iceberg phenomena. Okay. From this topic in NEET last year only, they asked this question, that which of the following has maximum submerged portion of iceberg. Submerged portion indicate subclinical case who recover without going hospital. And we all know in influenza, cough and cold, many people, they don't go to hospital, they recover without going hospital. So maximum subclinical case is in influenza. Okay. So next question is, of course, this is the same thing I should not have written, but anyway, you remember 5 disease, no one recover without symptom. Then a very frequently asked question is about secular trend. And we ask it, tell it about leaders also. This leader is secular, this leader is communal. So who is a secular leader? Secular leader is one who is equal to all religion, not just before election, but also after election. That means he should be equally to all religion for a long period of time. Similarly, if we are talking about secular trend, there should be constant increase or decrease in the number of cases over a prolonged period of time. Cases should be constant over a long period of time. And a very good example of this is cardiovascular disease cases. So they keep asking the example of secular trend. This is cardiovascular disease cases. Second thing they ask is, which diagram represent about secular trend? So this is any trend. When we talk about trend, trend is represented by line diagram. So who represents secular trend? Again, line diagram. Okay. So remember the example and line diagram, and tell me who is the secular leader of India. And in some of class, I asked people, say Modi, Yogi and all. I said, you are right. Modi and Yogi are secular, and I am Noora Fatehi. So now the point is, we have to know about 3 types of epidemic, from which image-based question can also come. If the epidemic is occurring within one incubation period, we call it point source, and point source has other name, common source single exposure. Main thing is time, which should be one incubation period. And for that, you should know some incubation period. Like you should know hepatitis A have incubation period 10 to 50 days. So in your hostel, if cases are occurring in 40 days of hepatitis, still it is point source. It is 40 days long, but it's still point source because incubation period is 50 days. Then they can ask about cholera. What is the cholera incubation period? 1 to 5 days. So if all cases occur in 5 days, then we call it point source. If it take more than 5 days, we call it either common source continuous or propagated. Then you should know about diphtheria. Sometimes they ask. Diphtheria incubation period is 2 to 6 days. You should know it about chicken pox and measles. Chicken pox incubation period is 10 to 21 days. And measles is 10 to 14 days. 10 to 14. Also remember, if I ask about quarantine, we have discussed it in our another sessions also, but do remember it's frequently asked thing. Quarantine is done on healthy people who are suspected of carrying infection, and quarantine is done till maximum incubation period. So in case of chicken pox, what should be the duration of quarantine? Should it be 10, 21 or 6 days? So in case of chicken pox, quarantine is 21 days. Isolation is 6 days. And isolation we do on people who are suffering from disease. And isolation is done till period of infectivity, maximum period till which you can infect other. This is the isolation period, which is 6 days in chicken pox. And in boy hostel or girls hostel where adult live, we don't need to give varicella zoster immunoglobulin in case of chicken pox. Okay, chickenpox, first priority is pregnant lady. We don't give it to adult because in adult complication do not occur, so we don't give immunoglobulin, varicella zoster immunoglobulin. So do remember, quarantine, when they ask maximum, you have to answer 21, not 10 days. So do remember these incubation periods. Why you have to remember these? Because if they, let's say, talk about cholera or measles, and all cases are occurring within 5 days in cholera, within 14 days in measles, it means this is point source or common source single exposure. For measles, also know the infectivity period. They also say period of infectivity is 3 days from catarrhal stage, 4 days before rash, 5 days after, or 3 days from catarrhal stage, in which you are having cough, cold, coryza and all. Okay. So what are the example of point source or common source single exposure? Food poisoning by Staph aureus. If all the cases are occurring in 6 hours, then you call it. Other example can be Bhopal gas tragedy, Chernobyl gas tragedy and all. Second type of epidemic is common source continuous, in which cases keep on fluctuating. And example of continuous, this example they have asked 2 times, I am expecting it again. Milkman distributing contaminated milk. So milkman is using the same source, causing the infection again and again. That's why it is common source continuous exposure. Other example can be typhoid Mary, contaminated batch of polio vaccine. The whole batch is contaminated, so infection will be continuous. And main thing in continuous is time is more than 1 incubation period. And less than 1 is point source, more than 1 is continuous. Then if sex worker like me is transmitting gonorrhea to the client, that is also common source continuous, because I am common source, I am spreading it continuously like that. Okay. Chalo. Now, this is one simple thing which they keep asking, that if your hand is visibly soiled, will you use hand sanitizer? No. You use soap and water. So sanitizer is not working on visibly soiled hand. Hand washing is an example of primary prevention, because we wash our hand when there is risk of infection to other person or to ourselves. So it's example of primary and it saves maximum life. INI-CET talk about this hygiene theory, and then he proved that doctor are killing more patient by not washing hand, and then doctor actually killed him. First they throw him in mental asylum, then they killed him. So this is very interesting story of INI-CET, you should know. But then you should also know that theory of hygiene is by Semmelweis, but sterilization is by Lister. Now, this type of epidemic, when you find a secondary wave bigger than primary wave, and at some gap there is secondary wave, then only it is propagated. Time in propagated epidemic is also much more than 1 incubation period. But main thing is secondary wave and person to person spread. So with secondary wave, what comes in your mind? Of course, corona. So all this COVID, SARS, MERS, they are example of propagated epidemic. So they can give you image-based question. I'm sure you can answer it. Let's quickly revise this confusing concept of level of prevention, which you think you know, but still we do mistake. Suppose I ask this question, that you are cleaning drainage area before rainy season. So if you are cleaning drainage area before rainy season, it means risk of dengue is yet not here, and you are doing it before the risk. So something which you do before risk, before the actual risk is there, before risk is there, or risk is in future and then you do it. This is primordial. For example, when many of you are preparing for MCI or NEET exam from first year, so that is primordial. And if you are preparing an internship or last year, that is primary, because primary is something which we do when the risk is there. And all the example of primary are better written as specific protection. So specific is the better answer. Specific protection is the better answer for all the primary prevention answers. And only one thing, primary prevention has one example, hand washing. Because hand washing we do not do for any specific disease. We do it for a lot of disease. So hand washing is only primary. But let's say I'm talking about condom. Condom is specific because it is specific prevention. And condom, you understand, now primary, like, is there anyone in the class who is listening to my class while wearing a condom? क्या कोई condom पहन करके मेरी class सुन रहा है? Of course not, है ना? No one can wear a condom while PSM class, because there is no risk of sex while listening to PSM. You cannot do sex, है ना? So this condom you wear only when you are going to do sex, only when risk is present. That's why it is primary, because primary is not before risk. Primary is done when risk present and disease absent. So you wear condom only when there is risk of becoming father at one unwanted time or risk of STDs. So risk present, then wear condom. And if someone is actually listening to my class by wearing condom, that is primordial. You are ready before doing sex, ready before risk. Okay. Now in the primary, the 2-3 controversial example they keep is minus desk. In a school health program, you all know we put minus desk so that it prevent backache. So the risk is there every day, and then we are using it. Then one controversial example is Anemia Mukt Bharat. Anemia Mukt Bharat is mainly for prevention, so it comes here. Other program usually have primary and secondary both, but in this mainly we are focusing on prevention, so it is here. Then the controversial example is isolation and quarantine both. But the confusion here is that isolation, I just told that we do it on disease people. So isolation is on disease people. And I hope you all know primordial and primary both are done pre-pathogenesis, before disease arrived. So how come isolation is primary? Isolation should be secondary because it is on disease people. But still isolation is primary because we isolate the person not for the benefit of diseased person. We are isolating someone to prevent other family member who are at risk. It never help patient. It help other people who are at risk. So why are we doing isolation? Because there are some people in which risk are present. We are trying to save them. That's why isolation is also example of primary. But in exam, if they have given isolation and option are primary, specific, secondary, which one we tick? Better answer is specific. You will tick specific. Okay. Condom they ask, specific you will tick. Hai na? So these are some example. Chemoprophylaxis will come under it. A lot of other things will come under it. Okay. If you have larvicidal drug and all, so larva has already been found in the pond. Now, if you have larvicidal drug, what are the name of larvicidal drug? They have asked Temifos, Abate, Paris Green. These are the name of larvicidal drug. They all are primary because risk is there, but they have not yet become adult. Similarly, if they ask larvicidal fish, I hope you know larvicidal fish is Gambusia and Guppy. So do remember it, Gambusia, Guppy. And do remember, if you are spraying malathion is like you are killing the mosquitoes and all. Then malathion has to be sprayed after every 3 months. And 3 months is the gap of malathion spray, and malathion is least toxic organophosphate. All this has came already, so I am asking. Now let me ask you this simple question. If I ask that the refractive error glasses which many of you are wearing, the glasses, will it be primordial, primary, secondary, tertiary? Which example is refractive error glass? So in secondary, we have early diagnosis and treatment. And our refractive error glass is not treating refractive error. Refractive error glass is making us self-dependent. So if you do anything to make you self-dependent, that is secondary, that is tertiary. And refractive error glass is making us self-dependent. So that will be, of course, tertiary. In US UK book, the concept is explained differently, but we have to answer based on Park. And Park has written this line, early diagnosis and treatment is secondary. So when you do LASIK surgery, that is treatment, it will be secondary. But refractive error glass, tertiary. Similarly, they have asked this question. They gave a patient of filariasis and they ask filariasis or leprosy patient foot care. So if you are doing foot care of any patient, that is disability limitation and that will be tertiary. Now, main question is, if you are taking BP of 10-year-old kid, 10-year kid, which level of prevention it will be? Will it be primordial, primary, secondary, tertiary? Many people, they answer primordial, primary. But remember, what is the purpose of taking BP? Purpose of taking BP is early diagnosis. So no matter in which group I am taking BP, BP taking will always come secondary. A kid can also have high BP due to horse-ship kidney or nephrotic syndrome. So we have to make it sure that whenever you are doing screening test, all screening tests are secondary. Similarly, they ask hemiparesis father taken for checkup. So if you are taking hemiparesis father for physiotherapy, that will be tertiary. But if you are taking the hemiparesis father for checkup, checkup means early diagnosis of a secondary attack in future or knowing whether the treatment of stroke is going well or not. So checkup will always come secondary. Physiotherapy, hemiparesis will go tertiary. If I took BP of 10-year kid, adult, or BPO in a health fair, all screening tests are secondary. Please do not confuse here. All screening test on anyone is secondary. Okay? And condom is primary. But if you put condom on a ultrasound probe and try to detect pregnancy which is less than 12 weeks, because after 12 weeks it come above pubic bone, then here you are doing screening for early pregnancy, screening come under secondary. So in that case, condom will be secondary. Similarly, BCG is a vaccine and we give vaccine when the risk is there. So vaccination come under primary or specific. Better answer is specific. But if I am using BCG for treatment of bladder cancer, then it becomes secondary. Okay. So this is the level of prevention question. If you have any doubt on any of the topic we are discussing, you can always post it in the group and I will be more than happy to answer it. Okay. Chalo, very good. You are with me and you are following it. Very good. Now let's discuss this one question, method of prevention, because the specific we are discussing is not level, it's method. But exam setters, they don't know this detail. So many times they think specific and primary is same thing and they put a specific as better answer of primary. And anyway, specific include all the example of primary. But they ask what is example of health promotion? Health promotion example is mother and child linkage. What is health promotion? Health promotion is when you are doing primordial, primary both. So if I am a mother, suppose, and I am breastfeeding my kid, so it is preventing my kid from future risk of diabetes. And if I am again breastfeeding my kid, I am hitting because it is biting my nipple in between. So this time my breastfeeding is preventing my kid from present risk of malnutrition. So future risk of diabetes primordial, present risk of malnutrition primary, because primordial, primary both are there. So breastfeeding and mother-child linkage will be example of health promotion. Okay. And I still remember my my sister younger daughter Riddhi. She was very heavy and all. So whenever I used to take her in my lap, she used to turn my t-shirt. And she was like, "Mama, rakhe to tum bhi wo pila nahi rahe ho. Mama, you also have the breast. You are not feeding me," like that. What I would have tell to her, nothing will come out except here. But she torn 2 of my t-shirt because of that. Anyway, so come and let's discuss this one very neglected topic which can come and which had come. Stages of disease. They ask what is the sequence of a stage. You can remember it by the mnemonic DIDH. Disease, impairment, disability, handicap. So DIDH, very simple. But the main thing is that they will ask a question like this, that where will you put hemiparesis? Hemiparesis is disease, impairment, disability or handicap. Where will you put hemiparesis? Tell me, hemiparesis. So disease is a stroke, and due to stroke, I lost power of my half body part. So whenever you lost power or lost body part, that is impairment. So hemiparesis is impairment. Disability is that due to hemiparesis, patient can't walk properly, and due to which he lost job. So handicap is always one thing, lost job, and disability means can't walk or things like that. Okay. Now, let me ask you one more thing. If after the class I went out and a truck went on my leg and both of my leg and both of my hand got amputated, only some part is left hanging, and now I am a phocomelia baby. So leg amputation, cutting my leg, will be disease, impairment, disability, handicap. Tell me. Cutting my leg will be disease, impairment, disability, handicap. Tell me. Where will you put cutting my leg? Cutting my leg amputation is not the disease. Of course, disease is road traffic accident. You cut my leg which lead to loss of body parts. So leg amputation will be impairment. Due to leg amputation and hand amputation, I can't walk, I can't write, and there are many other things which I can't do, but controlling my emotion, I can't walk like that. And because of which I lost job. So handicap means always lost job dependent on other. Disability means can't walk, can't write like that. Impairment is losing part, and diseases you can understand. With this 2 example, it's very simple, I think. Yeah, very good. Impairment, correct answer, triple R, Nishchay. Both of you gave correct answer. Next question is this part 2 question in last NEET came, PQLI and HDI. And as a student, I also used to get confused here, but it is nothing to confuse. If you just focus on the word PQLI, in the word PQLI, There is all the things written already. PYQLI. See, first thing is we can write LI as L1. So it has life expectancy at 1 year. First thing, life expectancy 1 year is in PQLI. Second thing is, if you write PQLI, I stand for infant mortality rate also, and LI stand for life expectancy at 1 year. Okay. Then I is for IMR, L is for literacy rate. So these are the three things which we measure in PQLI: literacy rate, IMR, and life expectancy at 1 year. And because PQLI is bigger, 4 letters, so the range is also big, 0 to 100. HDI is smaller, 3 letters, so the range is also small. So if you remember 3 things in PQLI, HDI you can easily answer, because HDI will have life expectancy at birth, mean year of schooling, and per capita income in form of purchasing power parities of country GDP. But it's conceptually also easy to understand. P stand for poor country. So when you have poor country, PQLI is better. And in poor country like India, you measure literacy rate now. You cannot ask literacy rate in UK. Wow, there even the child is speaking English. So in developed country, HD means highly developed. In highly developed, we measure HDI better, is a better indicator. So in highly developed, we measure schooling. India, we measure literacy rate. Now tell me, per capita income, do it matter for India, or do it matter only for developed country like Russia and all? Per capita income do not matter for India. Why? Because 2% of Indian population has 90% of India wealth. You know that. This is Oxfam report. Rest all of us, 98% Indian, are living in 10% of income of India. So if you add that 2% population in Indian 100% people, our per capita income look a bit okay. But if you remove that 2% people, suddenly our per capita income will go zoom below the ground. So when someone is saying that Gujarat per capita income is increasing, it's not Gujarat per capita income, is actually Adani Ambani per capita income which is increasing. You understand the point? So per capita do not matter for PQLI. Per capita matter for developed countries. So that's why HDI have per capita, not PQLI. So conceptually also you can remember it. For country like India, what matter is infant mortality rate. Why infant mortality rate matter for India is because this was the question in NEET 2023 also. What is the best indicator of accessibility and affordability of healthcare system? So if IMR is the best indicator of accessibility and affordability of healthcare system. Accessibility means whether healthcare is present in rural area, tribal area or not. And affordability means whether healthcare is free or not. Because if healthcare is not in rural tribal area, many infant will die. If healthcare is not free, they will not come for hospital delivery, home delivery will occur and they will die. So if IMR is high, it means healthcare is not accessible, affordable. So IMR tell about accessibility, affordability. It also tell whether ASA is working well or not. And it also tell about female condition. Because if female condition is not good, premature delivery will occur. And I hope you all know, in infant mortality rate of India, most common reason is premature delivery, low birth weight. And we call it premature if the delivery occur in less than 37-week period of gestation. If delivery is occurring, that is premature. So that is the most common reason of infant death. That's why IMR is best for poor country and PQLI measure it. And that is why if they ask what is the best socio-economic indicator, best is PQLI because it has IMR. Then we can use HDI as quality of life, but best indicator will be PQLI. In one time, they have asked you how we calculate HDI. So HDI is calculated by measuring geometric mean of 3 things. HDI is with the help of geometric mean of 3 variable, we measure it. And HDI is complementary to poverty index, complementary to human poverty index. Whatever we measure in HDI, opposite thing we measure in human poverty index. Like in HDI, we are measuring life expectancy. In human poverty index, we measure how many people died before becoming 40 years. So here we are measuring life expectancy, there we are measuring death expectancy before 40. In HDI, we are writing mean year of schooling. In human poverty index, we are writing how many are not literate, illiteracy rates. In human poverty index, we are writing here you are writing per capita income. In human poverty, we write how many people are earning less than this amount. For every country, it is different. So human poverty is just opposite to HDI. And in human poverty, there is range minimum and maximum. For example, for life expectancy, minimum is 20, maximum is 85. So how we calculate the geometric mean? For HDI, we write the actual value, like actual value of life expectancy in India is 70, minimum value is 20, maximum value of life expectancy is 85, and minimum value is 20. So we do 85 minus 20 and above part is 70 minus 20. This will give us dimension of life expectancy at birth. Similarly, we will take dimension of all three things and we will do 1 by 3 of all the three, and we will get the answer by taking geometric mean of all the three things. Okay. So this is how we calculate HDI. Now let's revise morbidity and mortality indicator, very frequently asked and very confusing area. This question came in NEET 2023. That potential year of life lost is what? Potential year of life lost means year of life lost due to premature death. For example, life expectancy of Indian is 70. If someone died at 62 years, how many potential year of life he lost? 8 years. So this is NEET 2023 question. But mostly they ask about DALY because DALY is the best morbidity indicator. Why DALY is the best morbidity indicator? Because DALY include two things. First, it include how many year you lost due to early death, potential year of life lost. Then you also measured how many year you lived with disability. So they ask the definition of DALY. Two things is there: how many year you lost due to early death, how many you lived with disability. For example, if an Indian lived till 62 years and for last 10 years he had hemiparesis, and they ask you to find DALY, how many year early he died? But expectation was 70, he died at 62, so he died 8 year early. Plus how many year he lived, not potential year, no, it's not P. We don't write in the definition of DALY, we don't write P, we only write year of life lost, and then we write year of life lived with disability. So how many he lived with disability? 10 years. So if you add 10 plus 18, these two things together will become the DALY. It is 18 years. So DALY, remember the definition: life lost plus life with disability. This is best morbidity indicator. Why we need DALY? They can ask like that. We need DALY if you want to get fund for mental health patient or hemiparesis patient, because they don't die, they suffer. And if people are suffering, their death will be less, but suffering year will be more. So that's why we are calculating suffering year by DALY. Second thing is Sullivan index. Sullivan index is year of life lived without disability. And there is a formula of Sullivan index also. Sullivan index is life expectancy minus DALY. For example, the last story which I gave was the story of my own father. When I was in second year of MBBS, he had hemiparesis. And for last 10 years, before becoming 62 years, he died at 62 years, but he suffered for 10 years. So what was the DALY in case of my father? DALY was 18 years. We already calculated it. And what is the life expectancy of my father or any Indian? 70 years. So what will be the Sullivan index which will come out for my father? 52 years. And till 52 years, my father was healthy. He died at 62. 10 years was with hemiparesis. But till 52 he was healthy now. So Sullivan index tell the same thing. Sullivan index tell how many life is without disability. My father suffered for 10 years, died at 62. But till 52 he was healthy. Sullivan index tell how many years he was healthy. So healthy was 52 years. Suffering was 10 years. And DALY was 18, because suffering plus how many years lost, that is DALY. Okay, and you can see while talking about my father death, I'm not so sad. Why? Because I realized all our parents, they mostly want only one thing from their heart, that their children should be happy. So even if he is not there, I should be happy while remembering him now. Anyway, breakup or death occur in one moment or 10 years, but remaining 52 years of good memory was also there now. So I should focus there also. Anyway, so now what is hell? Hell means whenever they write the full form, they use the word adjusted. But to get the meaning, you have to remove the word. Adjusted, adjust it. Like DALY is disability life year. Remove the word adjusted and it will meaning will be clear. So hell is healthy life expectancy. But Sullivan index also tell healthy life. Hell also tell healthy life. So what is the difference? Hell is estimated at birth. And remember, Sullivan index, we were estimating after my father death that how many years he was healthy. So Sullivan index is at death, hell is at birth. This is the difference. Chalo, next question. Acha, so we are done. But there is one question which I want to ask, and that is from the concept of QALY. QALY full form is quality life year. Simple. Adjusted, you have to adjust. So full form is quality adjusted life year, but it simply means years of life added years of quality life added due to an intervention. How many quality life is added due to intervention? For example, Park has written that dialysis add 0.5 QALY each year in life of patient. So if suppose you want to open a dialysis center in your state, let's say you are from Karnataka, you want to open dialysis center in Bangalore, okay, and you found that in Bangalore there are 1 lakh patient who need dialysis. So with this data, you can go to the Chief Minister of Bangalore. I don't know who is it, but Siddaramaiah or something maybe, है ना? But you can go to the Chief Minister and you can say that, sir, there are 1 lakh patient. If you open a dialysis center, we will gift them with 1 lakh into 0.5, 50,000 quality year. We will give to all the people. They will vote for you. Their relative will vote for you, and you might win the election. So in this way, you can get fund for opening dialysis center or some other intervention. So QALY, tell us how many year added due to intervention. Now there is a question on this topic that Japanese government are doing many intervention. Because there was a question on longevity dividend which came last year. So I want to explain that concept also with this question, longevity dividend. Japanese government are doing many intervention. Why they are doing many intervention? To give healthy aging. Okay, how to give healthy aging? By preventing illnesses and by giving them job. So this will be healthy aging and preventing illnesses in old age. Okay, illnesses in old age. So this will be example of which thing? So first thing is you are doing intervention, and whenever you do intervention to improve the quality of life, intervention to improve quality of life, this is definitely example of QALY, because you are adding quality life here in those old age patients of Japan. But at the same time, this is also example of longevity dividend. What is longevity dividend? It simply means when you give good life condition, good health condition to old age people, there will be two benefit. First benefit, the burden on health system will be less because old age are healthy, so less burden. And second main advantage is, if old age people are healthy, they can also earn money and help in the growth of the country. So it's like bonus. Dividend is the other word for bonus. When they live long and healthy, this is a bonus for the country. So this question is example of both the things, longevity dividend and QALY. I hope it is clear. Now similarly, they asked one unique question from environment also, 𝐑𝐄𝐝 criteria. And don't think that whatever has been asked cannot repeat. And things can repeat. 𝐑𝐄𝐝 criteria is the criteria to decide whether ventilation is properly occurring or not. To decide quality of ventilation using carbon dioxide concentration. How was the ventilation level? Based on which gas they have asked. It is based on carbon dioxide concentration in the air. Because if ventilation is good, 2 to 4 times air is flowing through the room, that is good ventilation, then carbon dioxide concentration will be less. Okay, so that's 𝐑𝐄𝐝 criteria. Anyway, let's now come to answer mortality death indicator. First death indicator is crude death rate. They have asked the definition and a small numerical on it. Crude death rate simply means total death by mid-year population into 1000. Into 1000. and not 100 into 1000. And for India, it is 7.2 per 1000. That means every 1000 people, 7 people die. They ask, when do we measure mid-year? So mid-year population is not measured on 7th of June or 7th of July. It is 1st of July, 6 months before July, 6 months after. So 1st July mid-year population they measure. So 7.2 Indian die. But if I ask out of your 1000 friend, how many will die in next 1 year? Then answer is only 2. Because your friend are of young age group. And in India, if you look at death between 20 to 25 year, 25 to 30 year, or 30 to 35 year, all this 5 year age group in India, if you are looking at Indian data, Indian 2 death per 1000 occur in this 5 age group. This is known as age specific mortality rate. Age specific means in any 5 year age group, how many people die. And you can see in any 5 year age group, 2 death is occurring in all this 5 year. So this is age specific death rate. And for India, Indian population, we know that how many people die in any 5 year age group. So that is why Indian population is standardized population. हम कहते हैं ना, ये बंदी बड़ी स्टैंडर्ड है या ये बंदा बड़ा स्टैंडर्ड है. क्या मतलब? अगर स्टैंडर्ड बंदी होगी या स्टैंडर्ड बंदा होगा तो हम उसके बारे में कुछ पहले से गेस कर सकते हैं कि स्टैंडर्ड बंदा होगा तो अच्छे से पढ़ेगा, अच्छे से उठेगा, अच्छे से बैठेगा, तमीज से बात करेगा, बात में हक दिया, पात दिया, मुद दिया, ऐसे नहीं बोलेगा, है ना. Standardized, whenever we say that this girl or this boy is standardized, it means we can know about that person, something we can guess. A standard boy will be educated boy, will be well behaved, है ना. He will not abuse, he will not say fart and all those things in between, है ना. So if you know about it, that is standardized. If you don't know about it, it is non-standardized. And for population of India, we know how many people die in 5 year age group. So Indian population is a standardized population because we know the age specific mortality rate of every 5 year Indian population. But when it comes to a small population like street children population or doctor population, these are, we don't know in doctors out of 20 to 25 year doctor, how many doctor die in 1 year. We don't know about doctors' death in any age group. So all this doctor population, street children population, they are non-standardized population because their age specific mortality rate is not known. Now, there is 2 things, direct and indirect standardization. This question has came already in NEET exam. Why we do direct standardization? Direct standardization is done to remove effect of different age group. Effect of different age group population in different country. So the option which was given in that question was why we do direct standardization. One option was it is done to remove effect of different age group. Yes, it is done to remove effect of different age group in different population. Let me explain how. Suppose you want to compare India death rate with Japan. And in India, we already read that crude death rate is 7.2. But in Japan, if you will Google, you will come to know crude death rate is 11.1. So if you compare crude death rate, it looks like Japan should learn from India. Japan 11 people are dying per 1000, India only 7. Is it correct thing? No. Why crude death rate is not comparable? Because Japan has only, India has only 8% people who are more than 60 years. Japan has around 25% people more than 65 years. So because they are having different age group, different population, so we cannot do comparison of crude death rate. Then what we can do? We can compare the age specific death rate of 0 to 5 year Indian, 5 to 10 year Indian, and with 0 to 5 year Japanese, 5 to 10 year Japanese, like that we can compare every 5 age group till 60 year. So if you compare age specific death rate of 0 to 60 year Indian, it will come 5 per 1000. If you compare age specific death rate of 0 to 60 year Japanese, it will come 2 per 1000. Then it will give us clear idea that India should learn from Japan because age specific death rate of Japanese population between 0 to 60 year is much less than Indian. So why we are doing direct standardization? Because Japan and India have different age group in different population. So to remove the effect of different age group, we compare them by direct standardization. And let's take this example that suppose you are in class 4th and there was a 12th class boy who was going with a girl and you said, wow, what a nice brother sister couple is going. And that 12th class boy become angry with you and said to you, meet me outside, I will make your brother sister mother sister one. तेरी माँ बहन एक करता हूँ, आजा. So now you are in 4th class, he is in 12th class. Will you fight with him directly or will you take help of your friend? You will fight indirectly with help of your friend and hit him with a stone from backside. But when you are in class 12th and you had fight with class 12th, then you can fight with him directly. So similarly, we do direct standardization if we are comparing two standardized population like Japan and India. If you are comparing 12th with 12th class, you do direct standardization. But whenever you are comparing 4th class with 12th, it is indirect. So indirect is done when we are comparing the death of a small population, non-standardized population, with expected death of large standardized population. Let me explain with a very simple example. Suppose you want to get fund for doctors, because you might be surprised to know that in Corona, for all the Supreme Court judges, government booked Ashoka Hotel and made AIIMS and Safdarjung JRSR to go and treat them in Ashoka Hotel. So why government was leaking their asses of Supreme Court judges, you know, so that they will leave them when they do some crime. But what they did for doctors, they throw some flowers by helicopter, because they know flower is useful even if doctor is alive or even if he's died. And a flower is very useful. So you want that some funds should be given for doctor prevention also, because they are the frontline fighter. So what you can do is, first you can call all the hospitals of Delhi and you can ask how many doctors die in 30 to 35 year age group population. What was the observed death in doctor population, which was a small non-standardized population. You collected this data by calling all the hospital. And suppose the observed death in doctor was 20 per 1000 doctors died between 30 to 35 years. Suppose it is 20 per 1000. Suppose, I don't know the real data because I have not observed it. Now you will compare this death of doctors with the death which is expected for normal Indian. What is the expected death of normal Indian, large Indian population? Expected death of normal Indian in 20 to 30 to 35 year, we have read that normal Indian die only 2 per 1000. So expected death is 2 and observed death is 20. So it is 20 here, 2 here. What will be the standardized mortality rate? Standardized mortality rate will come 20 by 2 into 100 or 10 into 100 or 1000. So with this data, you can go to Modi and you can ask for giving some fund so that we can save doctor's life also. So what is the role of indirect standardization? It helps us to get fund for those populations which are oppressed, which are having more death, by comparing them with the expected death of the country. So remember the formula 3 times being asked. Standardized mortality rate formula, observed death by expected death into 100. And when do we do indirect standardization? When one population is small, non-standardized, and one is standardized. When we do direct, 12th and 12th class, direct is when the age group is different in two countries. We compare their death rate by direct standardization. So I hope you will remember direct and indirect standardization. Now, you should also know about these two small formula, case fatality rate and proportional mortality rate. Numerical on both of them have already came in NEET exam in past, and they are giving 4-5 numerical. I am expecting in this NEET and MCI numericals from proportional mortality can come. Very simple. In both of them, numerator is same. In case fatality can also be called as case fatality or mortality rate, anything. So in case fatality rate, denominator is case. Remember there. In proportional mortality, denominator is total death. That's it. Remember this point. Here total death is denominator, here case is denominator. Rest part are same in both the formula. In case fatality rate also we multiply by 100. In proportional also we multiply by 100. In case fatality also in numerator we write number of death due to a specific disease, and in proportional mortality also we write the same thing, number of death due to a specific disease. So the same numerator come here, number of death due to a specific disease. And you might have heard of this question that if they ask case fatality rate for rabies, it is 100%. Why? Because if there is 100 case of rabies, out of 100 case, all the 100 will die. So case fatality rate tells about killing power. It tells about virulence of the disease, that how many will be dying due to the disease. And what is proportional mortality rate telling us? Proportional mortality rate tells us burden of that disease out of total death. Burden of disease out of total death. How? For example, the proportional mortality rate for cardiovascular disease according to the fake data by WHO is 58%. That means with cardiovascular disease, 58 people died if total death is 100. How many people die due to cardiovascular death? That is 58. So 58% is cardiovascular death. That means cardiovascular death has a high burden out of total death. So burden by proportional, virulence by case. Denominator of case is case, denominator of proportional is total death. Rest part is same, multiplied by 100 and number of death due to specific disease. To remember it. So we are done with this part. Next small part is health planning management, which is very simple to understand. Cost benefit means how much money you put, how much money you get. Money with money is cost benefit. But we are doctor and we don't just produce money. We also save life and improve quality of life. So when you are comparing money with how much life saved, how much quality of life improved or life saved, then it is cost and effectiveness. Okay. Then what is input output analysis? If you will open your own hospital, which you can open even now, input which you will put in the hospital is money. You will put your time as input and you will put some people as input. And what are the output which you will get? Output you will get is also money you will earn from the hospital, plus you will save life and you will improve quality of life. And some people said, sir, I will also earn respect. I said, don't try to earn respect, because if you will get respect from one patient, you will feel happy. And if you will get no respect from other patient, you will feel sad. So you are giving your mood control in other people's hand. Don't try to impress anyone. Don't try to get respect from other people. Otherwise, your mood will be always fluctuating. And we need to have a constant happiness rather than dependent on other people's behavior. Now, focus is, if you are comparing money with money is cost benefit. But if you are comparing money with these two things, life saved and number of life saved or quality of life improved, then this is cost effectiveness. Okay. And if you compare the whole thing together, it is input output. So I hope this thing is clear. Now suppose, let's do this very good question. Suppose you have decided to open hospital and you need 2 surgeons for that. Both are asking for 3.5 lakh starting salary. One of the surgeon is 𝐒𝐿 and other is the surgeon Dr. Siva Prasad. So both are asking the same salary. How will you decide which one is better? One thing you can do is you can take feedback from the hospital where they worked earlier. This is known as Delphi method. But the point is, if you suppose called the hospital where Dr. 𝐒𝐿 was working and a nurse or a doctor took the phone and said, don't take 𝐒𝐿, he just keep flirting with the girl. No work, focus on patient, just romanticism and sex, nothing else. So maybe the girl who took the call was already in love with 𝐒𝐿. So she don't want 𝐒𝐿 to go away. That's why he gave a wrong feedback. You can never depend on feedback from one person. You need to take feedback from consensus or group of people. This is Delphi method. And this has been asked. Delphi method is which method? Group method, by which we take feedback from group of people and then take decision. Second method to decide between 𝐒𝐿 and Siva Prasad is, you can ask them to do surgeries and you can compare who is doing surgery quicker. Let's say Siva Prasad did surgery in 30 minutes, hernia repair. And Dr. Siva did it 30 minutes. And Dr. 𝐒𝐿 did it in 5 minutes, hernia repair. So this is known as work sampling. And based on work sampling, you can choose Dr. Nishchay because he is doing surgery in 5 minutes. Because what is work sampling? You are comparing time taken to do work or how much time doctor give in patient care, how much time doctor waste. Like that, if you are comparing based on time, this is work sampling. And based on this, you should choose Nishchay because he's doing it in 5 years. But it may be not correct. Maybe Dr. Nishchay is connecting wrong wires together. And now whenever patient cough, he had an erection. है ना, जब भी खांस रहा है, patient का खड़ा हो जा रहा है. So it is not always correct to choose the one who is doing it in less minute. है ना, it may be fatal also. So this is work sampling. Now, last thing, the last method by which you can decide is, you can ask them in the interview that, okay, both of you are surgeon, but how other than surgery you can help our hospital. So let's say Dr. Nishchay said that I can find some good girls in the hospital, they will attract more patients and all. And Siva Prasad said that I will do some marketing and free camp and I will attract a patient from there. So you are comparing them based on their extracurricular work, or you are comparing them based on cost effectiveness, because the both of them are taking the same cost of 3.5 lakh, but one of them is more effective. He's helping in helping more patients. So this is known as system analysis. If you are comparing based on cost effectiveness, this is system analysis, comparing based on cost effectiveness. Okay, so all these three questions has come, and I think you should take Nishchay only, because if patient will not come for surgery, at least they will come for erectile dysfunction problem, and there will be lots of patient waiting in queue to be operated by Dr. Nishchay. So I hope this three thing will be clear in your mind, because all these three questions has came in PYQ. And one more thing which they neglect when we talk about time management, work sampling, cost benefit, cost effectiveness, all these things is quantitative, because we can measure the time, we can measure the money. So these are quantitative method. But one question which they ask is, which of the following is not a behavioral method of management? So we should also know about qualitative method of management or behavioral method of management. And qualitative or behavioral management method is 5 type, which you can easily remember by the mnemonic PCIMO. Suppose, to remember this, suppose Priyanka Chopra came one night to your room. PC came to your room. So what is good in Priyanka Chopra? P for her personality. So one method of behavioral management is personality training and personality improvement. Then C is also better in Priyanka Chopra. Now, what is C? What is C? C for communication skill. If you improve the communication skill of your employee of hospital, then also your hospital will have more earning. Then when Priyanka Chopra will come, first she will inform, देखो मैं आ गई, I am here, and she will give you the information. So I means information system. Then because Priyanka has came to your room, so she will manage you according to her objective. So M stand for management by objective. That means every hospital should have some objective. For example, Vodafone has objective happy to help. Airtel have objective zero complaints. So you can keep your hospital objective. Every patient should go with a smile. This is a good objective. So you can make personality, communication, information based on that. And O means when the Priyanka Chopra will manage you according to her choice, her objective, your whole organizational design will get disturbed. So O stand for organizational design. In your hospital, make the organizational design in such a way that even if you are not there, there are responsible people to handle different departments. So these 5 are behavioral management, and rest the things which we read till now is quantitative time management thing. Work sampling and network analysis are example of that. And under network analysis, there is 2 things, PERT and CPM. PERT means plan your time before taking action. They can give you this type of image-based question. If you are planning your time, 1 year is in construction of hospital. In that same 1 year, in the first 6 months, you should recruit staff. Next 6 months, you should give them training and buy devices. So in this way, in 1 year, your hospital is ready to run. So if you are planning your time before taking action, this is PERT. A very good example is our mother preparing food in the kitchen. Father could also prepare, and my father used to prepare food also, very good food also. But when mother usually prepare, you must have seen she put pulses or sambar first, because that will take maximum 4-5 whistle. And in the meantime, when pulses are getting ready, she prepare all vegetable, rice and other thing. So what mother is doing? She is doing put. Go and tell it to your mother. She will hit you. Put. So PERT is planning your time before taking action, image-based question. CPM means critical pathway method. The one work which take maximum time should be done first. This is CPM, and they both are example of network analysis. For example, if you are giving iron folic acid tablet to mother, most time-taking work is counseling how to take iron tablet, what are the side effects, and how to manage side effects. So you should make it sure that if the patient load is too much in a chamber, counseling of iron tablet pregnant mother is occurring by nurses or health worker, or you are doing it yourself. If you do counseling, the time-taking work will be done and the whole consumption of iron will increase. So critical is focus on time-taking work. PERT is plan your time before taking action. Both are under network analysis. Then one question which came recent in last 3 years is inventory drug store management. And when you have your own hospital and drug is getting wasted, you are losing money. If you are in government hospital and drug are getting shortage, people will blame you. So you should, when you go to any hospital or open your hospital, first day, you should make a list of those 10% drug which are always needed. And to this drug which are always needed drug, give 70% fund to them. If you gave 70% fund to them, there will be no wastage of this drug because they're always needed, and there will be no crisis of essential drug also. So this is one step which can help you in a better drug manager. Give 70% fund to always needed drug. Then give 20% fund to those drugs which are better if available, and give last only 10% fund to those drugs which are kept as control, rarely used. So ABC analysis is about fund management. Then what is VED? V stand for vital. Vital means life-saving drug, and vital should have first priority. First priority is vital and always needed. Vital and always is first priority. This is first priority. Vital and better is second priority. Vital and control is third priority. But vital should always be first priority. So vital is V, E for essential, and D for desirable. So this vital, essential, desirable help us to decide priority, and ABC help us to decide fund management. Now, this question came that you have 50,000 rupees for expenditure and 35,000 you gave to category X drug, 10,000 to category Y, and 5,000 to category Z. So which management method you are using? Are you using ABC analysis, VD analysis, cost benefit analysis, or are you using both ABC, VED? What is the answer? ABC, VED, cost benefit, or both ABC, VED? Very good. The scan wager is giving correct answer. Siva and Nishya both are enjoying it. Very good. What is the answer? Many people, they think cost benefit, but there is no benefit. We are just saying this much money invested. We are not talking about how much we earn. So cost benefit can never be correct. And what we are doing, 50,000 fund, 35,000 means 70% we are giving to one category, 10,000 means 20%, and 5,000 means 10%. So we are dividing the fund based on always needed, better, and available. It is ABC analysis only. VED will be used to decide priority. ABC will be used to decide fund. So this is ABC, not ABC VED. VED is separate, ABC is separate. Okay. Sure. Now let's discuss this, some of the concepts in, of course, the air pollution level and things about that also. Because when they ask swelling index and they ask, does it monitor only air pollution or air and soil both? It only measure air pollution. Swelling means the cloth which we hang to absorb dust particle has become dirty. So swelling index do not measure soil pollution. It measure only air pollution, not both. And mostly result come in air quality index. So if they gave this question that air quality index is, let's say, there must be some table or no. Suppose they gave the question that air quality index is 375. If it is 375, where will you place it? Is it poor, very poor, severe? Where will you put it? Poor, very poor, severe. Where will you put it? Because this question has actually come that on my birthday, November 23, NEET question, 473 is the air quality index. So which quality air is this? है ना? So tell me, if it is 375, where will you place it? Poor, very poor, severe, where will you place it? So very simple is, if it is 0 to 50, if anyone farted, you must have seen sometime that people fart, but there is no smell. It means the air quality is 0 to 50. It's a good fart. अच्छी हवा छोड़ी. So good quality air means without smell farting, quality air quality index 0 to 50. 51 to 100 means Satiswa ka factory, satisfactory air quality. Then real story start from 100. So till 100 it is 50-50, good and satisfactory. Then it is, the mnemonic is MPVS, moderate air quality, poor, very poor and severe. Okay. So when we talk about 375, this 375 is very poor. And when we talk about 473, which has already came in exam, then it is severe. 473 is severe, severe, and 375 is very poor. How can you remember it? MPVS, after 100, every 100, 100, 100. Plus, if they ask what is the best quality, best indicator of air pollution, the best chemical indicator is sulfur dioxide and best biological indicator is lichen. Okay. Now, in the greenhouse gas, which one is most common? Water vapor. Other are CO2, methane, nitrous oxide, chlorofluorocarbon and ozone. So they had a meeting in Kyoto to decrease greenhouse gas effect. And they like that free meeting and free alcohol so much that they had one more meeting in Montreal to decrease chlorofluorocarbon production. And why you want to decrease chlorofluorocarbon production? To protect ozone layer. So now the question is how to remember this confusing point. So in MBBS, to remember it separately, I used to remember क्यों छोड़ी हरी हरी gas. Q means why. Why you emit green gas? So why Kyoto green gas? Kyoto for green gas. Who emit green gas? I think Hulk might emit green gas. So Kyoto, क्यों छोड़ी green gas? Kyoto is green gas. And ozone layer protection, chlorofluorocarbon reduction is Montreal. Okay. Next is primary and secondary air pollutant. Primary are those which are formed without mixing, like volatile organic compound. It is so big name, but it is primary. And secondary are those which are formed after mixing, like ozone. It looks like such small thing, but it is formed by O2 and O free radicals, so it is secondary. And when we talk about air, we can't ignore this topic without talking about the 4 instruments which they ask again and again, including NEET 2024 also. First is Kata thermometer. Now, Kata thermometer measure 2 things: air velocity and cooling power of air. So, if they ask which one is more important or better measured, answer is air velocity. Air velocity is better measured by Kata. Okay. Similarly, they have a question from sanguarine. I hope you all know in the food adulteration part, sanguarine is the poison which got mixed. It is sanguarine is in Argemone mexicana seeds. This Argemone mexicana seeds got mixed with mustard oil, and due to this there is pitting edema and congestive heart failure. So this disease is known as epidemic dropsy. Sanguarine cause which thing? Epidemic dropsy. Okay, I hope you all know how to remember it. This all things very simple. Poison is sanguarine, and S also stands for sleeping. S for sanguarine, S for sleeping. And when you sleep with someone of your dream, suppose, there will be dropping of eyelids. So sanguarine epidemic dropsy. Plus the symptom is also pitting edema, dropping inside. So sanguarine and pitting both are there. You can remember with that. Then the question which was there, which was a really good question, I think. The question was that for sanguarine detection, which test is done? And there are two tests which are done. One is paper chromatography test and other is nitric acid test. So this time in exam they were just asking which test is done and one option was nitric acid and all. But if they ask which one is better, which one is more sensitive, always remember paper chromatography test is more sensitive and better. This is a confusing area. Even I was confused in this part once, but then I rechecked it from PARC and it has clearly written better and more sensitive is paper chromatography as compared to nitric acid test. So this is for sanguinary epidemic dropsy, and mainly we confused between epidemic dropsy and endemic ascites. So dropsy is by mustard oil, but when we talk about endemic ascites, it's very confusing, the poison name. And I remember I only used to confuse in this poison. Rest all poison are simple to remember. This is confusing, but it's also simple. In ascites, पेट फूल जाता है. There is swelling of पेट or abdomen. पेट is a Hindi word for abdomen. So ascites, there is पेट swelling, abdomen swelling. And you should know some Hindi word to handle the patients from other area also. Migrant worker will come to Tamil Nadu. So you should know every area. Now, when we talk about ascites, पेट swelling is there. And what is the poison here? Poison here is pyrazolidine. So this is the way to remember both of it. P for pyrazolidine, P for pate. So which will lead to ascites? Pyrazolidine. Ascites, pyrazolidine. So if you found endemic ascites, pyrazolidine, pet swelling, simple. So you can remember it. And what is the poison in ascites? It is a crotalaria plant which releases pyrazolidine. This is Panicum miliare, crotalaria. Okay. Other than this, let's revise the food adulterant here only. This was environment topic, but we can go in the very high yield topic. This is very high yield topic, so we should do. One thing is, if someone is eating groundnut or maize, and groundnut or maize is having Aspergillus flavus fungus. So this Aspergillus flavus fungus, I hope you all know, releases which toxin? It releases aflatoxin. And aflatoxin will cause which thing? Aflatoxin will cause hepatocellular carcinoma of liver. Remember, मूंगफली में दाना नहीं, हम तुम्हारे मामा नहीं. If groundnut they used, it is aflatoxin poison which is causing hepatocellular carcinoma. Second thing is, if they said that someone is eating jawar, this is the question which I am expecting in this exam of NEET. Jawar or wheat or rye with black color fungus, Claviceps purpurea. So this black color fungus, Claviceps purpurea, releases ergotoxin, and ergotoxin group of drug like ergotamine is used to relieve migraine pain. How it relieves migraine pain? Migraine is due to abnormal vasodilatation. Ergotamine cause vasoconstriction. So similar vasoconstriction occurring here also, which lead to cyanosis and necrosis of finger and toes. So that's why if they give ergotoxin, what will be the symptom they will be writing? Cyanosis and necrosis. And other than cyanosis and necrosis, they can also write hallucination, like the one which occur with LSD and other drug. So that hallucination can also occur with Claviceps purpurea thing. Last thing is neuroletharism, which has been asked already, but still they can ask some deep question from neuroletharism. There are two deep questions here. First thing is, we all know neuroletharism is by Khesari Sag, but it is mixed with which pulses? So Khesari is mixed with Arhar. They both look same, and Arhar pulse we commonly eat. So this is mixed with Arhar pulse. And when you mix it with Arhar pulse, Khesari will release which poison? I hope you all know the name of the poison. The poison which is released by Khesari is beta oxalyl aminoalanine BOA. And of course, the disease is neuroletharism. Now they can create a clinical picture, which they have created already, that there is a farmer from Chhattisgarh, rural area, who is eating only wheat and rice and pulses. So only rice pulses is one hint. And he had spasticity of leg. So if you found spasticity of leg, that is definitely boa, neuroatherism. Second thing is cross leg walking on toe, that is also neuroatherism. But one more thing they can ask is how to remove boa. So to remove boa, we do parboiling. Parboiling means keeping खेसारी साग overnight in lime water. चूना पानी में रख के रात भर छोड़ दो. If you put खेसारी साग in lime water overnight, that is parboiling to remove neuroatherism, to remove boa from खेसारी. That will decrease neuroatherism. And what is the treatment which we give for that? Treatment is vitamin C, 500 to 1000 milligram. Okay. So we just revised the food poisoning, but let's come back to our environment chapter instrument. We have discussed kata, air velocity, cooling power, है ना. एक शेर याद आ गया, खुली हवा के दिए कुछ कब के बुझ गए होते, कोई तो है जो इन हवाओं के पर कुतरता है ना. So there is someone who is cutting the air, na? cut the cooling power and air velocity, cutting the air and also measure cooling velocity, but main thing is air velocity. Now, kata is a Hindi word also which means thorn, and whenever there is thorn, it is long, na? Like kata laga, hai na? So kata will always be long, and globe is the one which is circular. So globe is like this. And what does globe thermometer measure? Whenever I ask in exam, in classes, people answer, it will measure humidity. No, globe thermometer do not measure humidity. Globe thermometer measure radiation temperature. Okay, this is very important area for question. Do remember radiation temperature. Then there is Ashman psychrometer. Ashman. ऐसा नहीं लग रहा है कि ये किसी के आसमान में घुस जाएगा, है ना? Doesn't it look like a proctoscope which will enter in someone's ass? So this procto-like scope-like image is Ashman psychrometer. And if you look at my name also, this is also Ashwani, है ना? So Ashman psychrometer is written, and this psychro word itself stands for humidity. So what does psychrometer measure? Psychrometer measure air humidity, of course. Whenever it is psychro, humidity. Then next is sling psychrometer. Again psychro. So psychro will measure what thing? Air humidity. But image based question has came from this topic. It can come in this NEET exam. Sling psychrometer I am expecting. So it will measure air humidity. Why they call it sling? Because this is the handle of the psychrometer. When you hold it from here, it rotates in the room like this. ऊपर नीचे, ऊपर नीचे, ऊपर नीचे, ऊपर नीचे. कुछ याद आया? हाँ. This is sling movement. ऊपर नीचे. So due to this sling movement, we call it sling psychrometer. And it had wet bulb, dry bulb thermometer. They will also measure air humidity. So do remember the 4 instrument. Now, in the light chapter, once they have asked this question, that what is the SI unit of brightness? SI unit of brightness is candela. So easy to remember. From candle, light is coming out. So brightness or luminous intensity, candela. Brightness, candela. But because they asked one question from here, so we should know the whole topic. Illuminance, SI unit is lux, and luminance, SI unit is Lambert. Now, how to remember these two other mnemonic? Very simple. You all must have seen the Lux ad in which they put Kareena Kapoor, Aishwarya Rai, Katrina Kaif, everyone in the same bathtub, and they keep bathing, and they say, this is the secret of my glowing skin. Actually, they don't wash even their toilet hand with Lux soap, but just for the ad, they say, this is secret. So you can remember it like this, that in the Lux ad, all those actresses are doing ilu ilu in the bathtub. I love you in the bathtub. Hai na? Some lesbian scene. So say Lux, add ilu ilu. Hai na? Lux, I love you. Okay. And then in Bangalore, there was a student who suggested me that, sir, we can remember the remaining part like this, like lamba lamb. Lamba lamb. Hai na? Lamb, you know, na? Child of sheep is lamb. It's very long. Lamba lamb, like that. Lamba lamb, ilu ilu in Lux ad, and candle have brightness. So with that you can remember. And the thickness of lead apron which you wear to protect your tatas, testicles, should be 0.5 mm only, not 5.5 centimeter, 0.5 mm. And the permissible radiation exposure is 5 radon per second. 5 radon per second we can easily tolerate. Okay. What is the permissible sound limit? Permissible sound limit is 85. 85 is okay. If you have sound more than 85, then auditory fatigue will occur. Whatever people will ask, you will answer eh, eh. But if there is 100 decibel or more than 100 decibel sound, then that lead to chronic exposure will lead to loss of hearing. And a chronic exposure of more than 100 will cause loss of hearing. And if there is more than 165 decibel, फट जाएंगे पर्दे कहाँ के? कान के. कहाँ के? कान के. Okay, so this is the rupture of tympanic membrane. It occur at sound level more than 165 decibel, and they can only ask the sound limit of hospital, which is 20 to 35 decibel. This is the sound when we whisper. क्या पहन क्या है? कैसा लग रहा है? Like that. So whispering is 20 to 35 decibel. This should be in the hospital. Okay. So then now this is one small thing: green belt, green corridor. Green belt means you are planting tree on both sides of road, not to decrease air pollution, but to decrease only sound pollution mainly. And for air pollution, you need large amount of trees, not just around the road. And green corridor was made during Corona also, and it is mainly made for rapid transit of ambulance so that we can promote organ donation. And which state of India is leading in organ donation? Tamil Nadu. And it has Mohan Foundation, which is coordinating a lot of organ donation. Okay. So this is all the instruments and things. Now last thing is water. When we talk about quality of water, we should remember the 4 criteria by the mnemonic PCOD. It has nothing to do with PCOD, but P means it should have free from pathological agent. C means color should be less than 15 true color unit, less than 15 TCU. And give any sample of water to your mother, she will smell it and tell whether it is okay or not, because safe water have no odor. Last thing is, safe water should have zero turbidity. Otherwise, when you wash cloth, it will fill with white flakes. So zero turbidity, color less than 15 TCU. Now suppose you got 100 ml of drinking water. In that, how much E. coli is acceptable? Is it 0? Is it 10? Is it 100 or 1000? If you are drinking water with even 1 E. coli come from human intestine. Even if there is 1 E. coli, it means you are drinking shit. Tatti pi rahe ho tum. So it is not allowed. That means that's why I am saying that there should be free from pathological agent. What is the E. coli count per 100 ml of drinking water? 0. You cannot drink. And if there is sewage, fecal matter in water, we call it sewage. If it is kitchen waste water, we call it sulage. Now let's talk about fluoride. A lot of question came already, and I am expecting this NEET 1 question from here. Fluoride. Fluoride, they asked the range already one time. What is the range? 0.5 to 0.8. If it is less than 0.5, dental caries will occur. Dental fluorosis, image-based question can come. White plaque on teeth. This will occur if fluorine is more than 1.5, dental fluorosis will occur. And if fluorine is more than 10, brittle bone or skeletal fluorosis will occur. You will be sitting in OPD, Awaji came and will say कि डॉक्टर साहब टट्टी पे बैठ रहे थे, हड्डी चटक गया. टट्टी नहीं, हड्डी. And टट्टी से उठ रहे थे, हड्डी चटक गया, है ना? I was sitting in the toilet, I had bone fracture. I was coming out from the Indian toilet, I had bone fracture. So if this type of history is coming out, it is pathological fracture due to more amount of fluorine. If it is coming out in many people of the area, it is due to high amount of fluorine more than 10. They have asked the fluorine amount more than 10 is brittle bone. Okay. And what advice will you give? Don't give advice, do it in a standing mode. And they will sit somewhere. So advice is, ask them to use a small device which can remove the fluorine. This small device add 3 things: lime, alum and bleaching powder. And if these 3 things through water passes through these 3 things, extra fluorine will go away. This is known as Nalgonda technique. So in Nalgonda technique, what is the sequence of thing we add? Simple to remember is lab. First lime, then alum, then bleaching powder. It will remove extra fluorine. And remember the concentration 0.5 to 0.8. Why it is simple to remember? Because fluorine is 0.5, 0.8 and chlorine is 0.5 to 0.7. So it's not difficult. 0.5 in both fluorine and chlorine. And they have asked in just last years that what is the residual amount of chlorine. So residual amount of chlorine is 0.5. Residual 0.5, 0.5, 0.7 chlorine, 0.5, 0.8 fluorine. But you know now in swimming pool some people do hanky-panky. So there the chlorine should be more 1. And during flood some people are so opportunistic, इतने मौका परस्त होते हैं कि देखा बहता हुआ पानी तो उसमें अपना बम भी धो लिया और कर भी दिया, है ना. By seeing flowing water they wash their bum also and do sit there also. So in flood also we need a smaller, some more amount, 0.8. But in swimming pool 1 and normal drinking 0.5, 0.7. Now in India we are doing chlorination with the help of bleaching powder which has 33% free chlorine by weight when you are freshly preparing it. But in US, UK we directly add chlorine gas using which device? Patterson Chlorono. So after my PG I went to tribal areas of Chhattisgarh, Janswa Sahyog to work. And on the very first day they introduced me to the health worker meeting and asked about chlorination. But this topic I never learned, thinking it is for the person who is supplying us water, why doctor should know it. So then they took me to the well, not to throw me into it, but to teach how to do chlorination. And they did it in 3 simple steps. First step is they took some water from the well, put it in 6 white tubes, and in those white tubes they has put some blue color liquid also. So this apparatus is known as Horrocks apparatus. A similar apparatus was in that movie क्या था, Harry Putter, है ना, Horrocks apparatus and all. So remember, what was the blue color indicator in Horrocks apparatus? Blue color indicator is starch iodine. And what they were doing by putting water in that 6, they were trying to know how much bleaching powder we need to put in the well, which will kill all the bacteria. So this is the amount of bleaching powder which water of the well is asking. That's why it is chlorine demand. So do remember this definition. What is chlorine demand? Chlorine demand means amount of chlorine or amount of bleaching powder. Amount of bleaching powder which is needed to kill all the bacteria. That is chlorine demand. And who estimate chlorine demand? Horrocks apparatus. So with this 6 white tubes, 4th change color, and based on which they calculated that this much bleaching powder we need to put. This is Horrocks apparatus chlorine demand. After they put that much amount of bleaching powder, I said now let's go to have food. They said no, wait, we will have to wait for 1 hour. This is 1 hour contact period. This was also the question in last year MC exam, that what is the contact period and what is the residual chlorine. Contact period is 1 hour. And what was the residual chlorine? Residual chlorine was 0.5. Residual chlorine is 0.5. So then we throw that amount of bleaching powder which Horrocks apparatus told us through chlorine demand, and we waited for 1 hour. After 1 hour I said now let's go to have food. They said no, wait, now again we have to take some water, and this time we have to detect residual amount of chlorine in water. And this residual amount of chlorine in water is detected by which instrument? Chloroscope. And minimum residual amount should be 0.5. And if it is less than 0.5, it means not all bacteria has been killed. So there are 3 questions which come from this chlorination. First question, what does Horrocks apparatus detect? Horrocks apparatus detect amount of bleaching powder needed to kill all bacteria, chlorine demand. Second question, in that 1 hour contact period, which ion of bleaching powder kill maximum bacteria? So the ion which kill maximum bacteria is known as HOCl minus ion, hypochlorous ion. This kill maximum bacteria. How will you remember it? The one with rust, the one with juice kill maximum bacteria. The one with one sword kill maximum bacteria. Because the second ion is hypochlorite. They think we will be confused, but no need of confusion. Don't read hypochlorite. Read only chlorus, rus, and one minus. It will kill maximum bacteria. And after killing bacteria in 1 hour contact period, we detect residual chlorine which should be 0.5 with the help of chloroscope. So this is the 3 step of chlorination. I hope you understood it. And in the chloroscope, there are 2 type of tests done. Orthotoluidine, orthotoluidine arsenide. Now the question on this part is, does orthotoluidine detect free chlorine or combined chlorine? It detects both free and combined chlorine. Then sometimes they ask, does orthotoluidine arsenide, does it detect free or combined chlorine? So orthotolidine arsenite detect both free and combined chlorine. Now you will say कि अरे पगला गया है क्या, मोटे माल फूक लिया क्या? You are telling the same thing in both sides. How? It's same but different. There is one difference. When we do orthotolidine test, it detects both free and combined chlorine together. But when we do orthotolidine arsenite test, it detects both free and combined chlorine separately. Combined chlorine means HOCl ion. And if HOCl is more, killing power is still left in the water. That is why we want to know separately how much is combined chlorine, to know the killing power is still left in the water. And anyway, orthotolidine arsenite is also not affected by nitrite and other impurity. So which test is better? The better test is orthotolidine arsenite. Anyway, extra thing is there. And remember, both of them detect both free and combined chlorine. Okay. So this is all about chlorination. Now let's talk about, after environment chapter, let's go to revise vaccination. In the vaccination, suppose a child took 5 vaccine first dose at 6 weeks and came back to you after 5-month gap. So he came back to you after 5-month gap at 6.5 months. 6.5 महीने पे वापस आया. So when he will come after 5-month gap at 6.5 months, will you restart from first dose? Answer is no. If child come back within 1 hour, within 1 year, not 1 hour, 12 महीने में वापस आ गया. If he came back in 12 months, we don't restart, we continue. So we can continue from second dose. It can be correct. But the problem is, rotavirus is something which we don't give after 6 months. Rotavirus first dose, rotavirus not given. First dose is not given after 15 weeks. And second dose is not given after 6 months. So because this child has came at 6.5 months, on the second visit, first visit we give 5 vaccine. What are the 5 vaccine? OPV rota penta, FIPV PCV, है ना? And this OPV rota penta continue at 6, 10, 14. OPV rota penta 6, 10, 14. But FIPV PCV is given at 6, 14 and 9 months. So FIPV PCV is not given at 10. At 10 we give OPV rota penta. But out of OPV rota penta, rota we don't give after 6 months. So what is the correct answer? Give second dose of OPV and penta. No need to give rota, because rota is second dose is not given after 6 months. Okay. Chalo. Next thing is the diluent of the vaccine, the route of vaccination. These are the things that they ask. So it's very simple. BCG diluent is normal saline. बच्चा जैसे ही पैदा होता है, हम उसकी जिंदगी थोड़ी नमकीन बनाने की कोशिश करते हैं. We try to make the life of child a bit salty, so we give normal saline. And BCG dose is 0.05 ml up to 1 month, not 0.1. Where we give BCG, of course, in left side. MR is also standing for mother love. And how is mother love? Mother love is like sterile water, distilled water. No matter how your mother is angry with you, just press her leg for 10 minutes, she will melt like ice cream. So you can remember MR, mother love. And JE, if you write the full form, it's Japanese in the full form. So the diluent is phosphate buffer solution. So easy to remember. Japanese, so P for phosphate. It's already written there, phosphate buffer solution. Okay. Chalo. Now, second thing which they ask is from the root diluent. I hope you will never confuse here. Then they can ask the root also. Let me see whether I have put the root part or not. Let me discuss the root of at least MR and JE, because this is very confusing and keep asking again and again. MR is mother love. Both MR and JE. JE in India we give SA 14, 14, 2. 14, 14, 2 bar. Live vaccine we give in India. In US, UK we give killed, not in India. India we give live, SA 14, 14, 2. And JEMR both are given 0.5 ml subcutaneous. They can ask which arm, which thing. MR, mother love is always right. So MR is in right arm subcutaneous. And JE is in left arm subcutaneous. Okay. So do remember the route also. And which vaccine is given by nasal route? Nasal route is one vaccine, influenza live vaccine. Other than influenza live vaccine, there is one more new vaccine, INCOVAC, which is produced by Bharat Biotech only. This can also be, which has produced Covaxin. That is also given by nasal route, but mainly they ask influenza live vaccine by nasal route. And pentavalent vaccine, in one of the INI-CET, they ask what is the composition. So it has Haemophilus influenza type B, Hep B, and DPT. Then they create clinical question from this part, that there is a patient who had gone through splenectomy, or there is a sickle cell anemia patient. All these 4 patients are immunocompromised patient. And in old age and other immunocompromised condition, most common infection is pneumonia. So in all them, which vaccine is given? Pneumococcal conjugate vaccine is given. Okay, do remember, they can create a clinical question from here. Post-splenectomy, which vaccine? PCV. And in the national immunization schedule, we also gave 2 doses of DT in pregnancy. And if a mother came in first trimester, will you give tetanus? Answer is yes, because guideline has written it can be given any time during pregnancy. So we give 2 doses of DT at a gap of 4 weeks. But if mother has taken last DT in 3 years, then we don't give 2, we only give 1 booster dose. Okay. So this is there. Plus we also give DT at 10 year and 16 year. And this was NEET 2023 question. At 10 year, which vaccine is given? DT. At 16 year, which is given? DT. And you cannot write DT or TT. 10 and 16 year, we give DT. Pregnancy, we give DT, and not TT. Okay. So, and do remember these important points. Let's talk about rabies a bit. Kutta kata injection. Suppose you already know that dog has made his mood and he will bite you. You can take 3 vaccine on day 0, 7, 21, 28. It is needed mainly for veterinary doctor, because one of the work of veterinary doctor is they make the dog to do sex. And if any dog don't like the partner whom they will bite, the doctor only. So they will take pre-exposure prophylaxis 0, 7, 21 or 28. But suppose you had injection after dog bite and dog bite you again after some time gap, then you take only 2 doses, 0 and 3. So post-vaccination 0, 3, pre-vaccination 0, 7, 21, 28. Then remember one point, key in the guideline of vaccination, intradermal intramuscular regime, we all know intradermal is given on 0, 3, 7, 28 and intramuscular on 0, 3, 7, 14, 28. But they will ask which one is a better regime, intradermal or intramuscular. So intradermal is better regime because the total dose in intradermal is only 0.8, but total dose in intramuscular is 2.5. So that's why in all the government hospital, we only do apply intradermal dose of rabies vaccine. And this 28 day we don't give if the dog is alive after 10 days. Because if the dog is alive after 10 days, it means dog was not rabies. And if dog is not rabied, why to give it? But the main question which come is, suppose you must have seen it on many Instagram poster also, a girl or a boy is smooching with a dog, है ना, lip to lip kiss, लपा के कुत्ते ने पप्पी ले लिया चुम्मा एकदम, है ना. So if dog is giving you lip to lip kiss, which category it is? Category 1, 2, 3. Should you take rabies immunoglobulin, human immunoglobulin also? Answer is yes, because it is leaking on mucosa. It is category 3. So kiss any dog like human, but don't kiss dog. Okay, lip to lip at least. Don't smooch there. Second thing is, if dog came and scratch your face without bleeding, no bleeding, not even 1 drop of bleeding, just while playing scratched it. So will you take human immunoglobulin? Is it category 3? Answer is yes. Scratch on face is category 3. Leaking on mucosa is category 3. Now suppose dog came and scratched by armed and only 1 drop fell from it. Only 1 drop. Will you take immunoglobulin? Answer is yes. If there is any bleeding, it is considered as category 3. Plus last thing in category 3 is bat bite chamgadad kata. So there are 4 things in category 3. Do remember, bite with bleeding, even 1 drop, licking on mucosa, scratch on face or fruit bite. All this category 3 will get vaccine plus immunoglobulin. If it is a scratch without bleeding written, only then you will stop at vaccine. And if it is licking not on mucosa but in other places, then you can category 1 only wash. Chalo. So this is the thing, but they can create a question that there is a pet dog and the neighbor pet dog scratch your hand with 1 drop of blood coming out, and the neighbor said he is completely vaccinated. So then what to do? Answer is do the same management category 3. Dog is vaccinated or not, it doesn't matter. Because everyone say my dog is vaccinated. How will you check it? And plus we don't know the dog vaccination schedule. So always remember, whether vaccinated or not, pet dog or local dog, doesn't matter. Management will remain same. And when we give rabies immunoglobulin, they ask the dose of human immunoglobulin, that is 20 international unit per kg. Human immunoglobulin not repeated lifelong. If you took one time human immunoglobulin, you need not to repeat it. Okay. And remember the dose 20 international. So if a 100 kg man took it, it is 20 into 100, 2000. Out of which 1000 you will give around wound, 1000 you will give IM. But if the bite is on, let's say, finger and where you cannot give IM, then you give full dose IM. Remember the dose 20 international unit per kg. Okay, horse immunoglobulin is 40, but we don't use it. Rotavirus, we already discussed it. We don't give first dose after 15, don't give second dose after 6 months. And there are 4 vaccines which we don't give after 1 year. BCG, Rota, Penta and FIPV, we don't give after 1 year. BCG, Rota, Penta and FIPV, we don't give after 1 year. Chalo. So these are some of the points, but of course, there is a lot of topic and a lot of point which I can keep on discussing. The time is always limited, and I am forced to stop it now because there is other teachers classes also after this session. So do tell me if there is any topic, any question which you found difficult. This is exam time, and in exam time I reply WhatsApp messages with more precaution because one question can affect your life. So you can post your doubt. I will definitely reply it within 1 day. From this day till your NEET exam, till your FMGE exam, I will be highly attentive and I will reply everything. Plus you can post your doubt on PW Meded app also. Sankalp batch is also there, and you can download this app. You can go through the Telegram group and you can reply, ask question there also. You Nishchay want a list of important topic. Why not, dear? Your wish is my command. First, very important topic is diphtheria. I have discussed it in various sessions, but let's discuss it here again. How will you manage the cases of diphtheria and how will you manage the contact? This is different. But I am expecting the management of cases in this exam. If the cases is mild, in mild management, we give 20,000 to 40,000 diphtheria antitoxin. And if it is nasopharyngeal, nasopharyngeal will be more infective or oropharyngeal? Nasopharyngeal will be more infective. So nasopharyngeal is always moderate because with one sneeze, you can infect many people. So in that case, we give 40 to 60,000 international unit of diphtheria antitoxin. But if it is severe case, in severe case, we give 80,000 to 1 lakh. There is no one who receives 60 to 80, and it's 80 to 1 lakh. And along with 80 to 1 lakh antitoxin, we also add antibiotic. Antibiotic is something which we not only add in severe, antibiotic we add in every 3. So cases always get antitoxin plus antibiotic. And if they ask, what is the drug of choice, antibiotic or antitoxin? Antitoxin is drug of choice. But if they talk about antibiotic, that which antibiotic is choice in case of children and in case of adult? So antibiotic which you give in children is azithromycin, and antibiotic which you give in adult is erythromycin. And the good news is this erythro and azithro which we are reading in diphtheria, this is the same management which you also do in pertussis. So pertussis also, this was the NEET 2023 question. Pertussis drug of choice for children, azithromycin. Pertussis drug of choice for adult, erythromycin. Okay, so this is how we manage case. In all this, we give antitoxin, but we always give antibiotic with antitoxin for case. Now, when it comes to contact, if contact came with last diphtheria injection, DT or DPT or Penta in 5 years, then in this case, we don't do anything, nothing needed. And this was the question in last NEET exam, which two of the teacher also gave wrong answer. The question was that there is a 5-year boy, he developed diphtheria, and in the home there is a 2-year-old brother who is fully vaccinated till his age. So when this 2-year brother is brought to you in the hospital, what will you do? So this is fully vaccinated child. It means he received DT, DPT, pentavalent in last 5 years. So then we don't need to do anything because the contact is 2 years and he is fully vaccinated. So no need to do anything. So in last 5 year unknown come, nothing needed. Second thing is, if someone took DT or diphtheria toxin or pentavalent more than 5 years. So in case of more than 5 years, we give diphtheria antitoxin, give DT. And अगर कोई आ जाए भूला, I don't remember, forgotten history or not taken, forgotten or no history of DT. So if there is no history, then only we add antibiotic. So here we give DT, diphtheria antitoxin plus antibiotic. Okay. So antibiotic is added only if it is forgotten history. If it is not forgotten history, then we don't give antibiotic. Okay. Diphtheria antitoxin. It's not written as DT. DT is the toxoid and it's antitoxin. So I hope you will remember. Plus DT. DT is the same thing. DT is written in PARC that we give DT in contact only if last vaccine was more than 5 years or forgotten. And in case of forgotten, we add antibiotic. But if last vaccine is taken within 5 years, in contact, we don't do anything. So contact and case management is one important topic which I taught itself. Second topic is definitely for management of tetanus. Because we have read rabies, so also let's learn about tetanus. Very simple. If there is less than 5 year history of tetanus, less than 5 years, then no matter which type of wound it is there, we do nothing. Only wash and let it go. So even if it is dirty wound, in surgery they might teach you wrong that if it is dirty wound, we always give tetanus. We give tetanus in practical. But this is not practical exam. This is theory. And you have to answer based on guideline. And always when it comes to guideline, you have to answer based on national guideline given in PARC. So please trust it here. It is written in PARC. Less than 5 years, nothing. Don't trust surgeon here. They will force their expertise on you. And remember, we have discussed expert opinion has least importance. Main importance is evidence. Okay, if I teach anything in gynae, I can be wrong. But if someone is teaching national guideline, then you have to trust PSM. Second thing is, if someone took last vaccine in 5 to 10 years, in case of 5 to 10 years, we will give DT. No matter, or DT or TT, whatever you can give. No matter whether it is clean or dirty, this management is same. Main management occur if it is more than 10 years back. So if it is more than 10 years back and it is clean wound in less than 6 hours, then we continue giving DT or TT. No change. So if someone came at 12 years with clean wound, only DT. 7 years with clean wound, only DT. 10 years with clean wound, only DT. All these three questions had come. 7 years, 10 years, 12 years with clean wound, DT. But 7 years with dirty wound is also DT. Now, 10 years with dirty wound is also DT. Because it is more than 10 years, not 10 years. More than 10 years only then in case of other wound. Other wound means not clean or more than 6 hours. Other wound, along with DT-TT, we add tetanus immunoglobulin. Okay. Then the last is, if someone is coming with forgotten history, भूला, forgotten history, तो इस बार इतना भोकेंगे कि फिर ना भूले, छेद कर देंगे, 5 टेटनस देंगे. Forgotten history, we give full course of DT, full course, है ना, 5 vaccine actually, so that he don't forget next time. Full course we give if it is clean wound, full course without immunoglobulin. But forgotten history and other wound is there, then along with full course of tetanus, we will also add tetanus immunoglobulin. So do remember this very simple thing, that tetanus immunoglobulin we add only in case of other category and only if it is more than 10 year or forgotten. Otherwise, tetanus immunoglobulin is not given. So remember, for tetanus immunoglobulin, and you will not be doing mistake. Tetanus immunoglobulin only in case of more than 10 year and forgotten. More than 10 year forgotten, and only in case of other wound. Okay. So this is the one more topic which you should know, which you already discussed. Then one topic which you should know from vaccination part itself is the classification of vaccine. Why? Because they create question in two ways. First question they will create is, there is an immunocompromised patient like nephrotic syndrome child on steroid or pregnant female or HIV patient. So in immunocompromised patient, you know, live vaccine is not given. Second type of question they are creating is, in a ice-lined refrigerator, which vaccine are kept at base? So they are live vaccine because base will have less temperature fluctuation. So at base we keep live vaccine. So they will create immunocompromised patient or base of our ice-lined refrigerator. So immunocompromised patient, don't give live vaccine. And don't give live vaccine. And base of ILR, you have to keep live vaccine at base. So that means in both of these question, base of ILR, for answering this question, you should know what are live vaccine. And to answer this question, that nephrotic syndrome child on steroid, which vaccine is not given, you should know live vaccine. So you should have clarity of live vaccine in your mind. And don't make big mnemonic of 11. Otherwise, you have to decode mnemonic first, then write, and it can be confusing. Mainly, when they talk about live vaccine, they talk about first 6, which is very simple to remember. BCG is a live vaccine, you all know. It goes in bone, it can cause osteomyelitis or lymphadenitis. MR is a live vaccine, you all know. Then all the oral vaccine is live. So rotavirus will definitely be live, and typho oral will also be live, and of course oral polio will also be live. Then there is yellow fever vaccine. I hope you all know yellow fever give immunity for 10 years. No, a yellow fever give immunity from 10 day to lifelong. 10 day to lifelong immunity. Previously it was till 35 year and all, but now this is lifelong immunity. And yellow fever is the only vaccine which is not contraindicated in pregnancy. We can still give it in pregnancy. So yellow. Last thing you have to know is varicella. Varicella have 𝐒𝐿 strain. So you must have seen that performance also by Shakira. Savila, villa, savila, villa. It's time to Africa, wakka, ayo. So that's same. 𝐒𝐿 strain, varicella. What type of performance was it? Live performance. So it's live. So if you remember this 6, mostly answer you can do. But other 5 in live category is CP pe IJO. In our time, CP means cannot place or center point in Aligarh. If someone says CP pe IJO, it's an invitation for date. So why this mnemonic I have made? Because there are 5 vaccine which are live also, killed also. So if you remember this together, you will not only remember all the live, but you will also remember all the killed easily. Cholera, plague, polio, influenza, JE. Okay, so this is CP pe IJO. And in this CP pe IJO, if you remember CP pe IJO and then BCG, MR, rotavirus, typhoid, yellow, varicella. So these are the vaccine which are kept at base. And these are the vaccine which are not given in immunocompromised patient. So then we can also revise what are the killed vaccine. Very simple. Just remember 2 names, Hep A and rabies. Just 2 names. Actually there are 7, but 5 you have already remembered: CP pe IJO, cholera, plague, polio, influenza, JE. So total becomes 7. Then protein vaccine is very simple to remember because P for protein, P for pertussis. Protein vaccine is pertussis. And if you give pertussis in pentavalent or DPT, there can be 3 problems due to pertussis component. First problem is fever which is high grade, and a high grade fever. Second problem is convulsions. So one is high grade fever, second problem is convulsion, third problem is unconsolable cry or screaming of child for more than 3 hours. So the question which came from this part is, if a child develop any of these complications in the next visit, what we will give? First option, don't give anything which is in pentavalent. Second option, give DT. Third option, continue pentavalent, don't worry about side effect, let the child die. And actually 1-2 coaching and 1-2 places they write continue, don't worry. So Park has clearly written that pertussis component is causing this problem, and if any of this problem occurred, don't give pertussis component. So what you can do, if this problem occur, if such side effect occur, next visit give only DT. Next visit give DT. Because pertussis is causing problem, diphtheria tetanus is not the problem, so give DT. Okay, protein vaccine is pertussis. P for. And when we talk about toxoid is diphtheria and tetanus. When we call about recombinant vaccine is only one, hepatitis B. And in case of hepatitis B, they ask the question that in the vaccine, which component is there? HBs C or E? HBs AG is here. Okay, recombinant. Last is cell wall vaccine, and in the cell wall vaccine, you can remember 3 names: pneumococcal, meningococcal, and VI polysaccharide. So when you give meningococcal, in meningococcal we use ACY-W135 subunit. So they ask which subunit is not present in meningococcal vaccine. Beta subunit is not present in meningococcal vaccine. Beta not present. Then after meningococcal, next is pneumococcal, and after this, next is after pneumococcal, next is VI polysaccharide. This VI polysaccharide is for typhoid. So this is the whole vaccine classification, from which even INI-CET have asked which one is toxoid, and diphtheria was one of the answer. So all the classification is important, plus we have covered many questions in that classification part. I hope you will remember. So in vaccination, these things are important because micro PS, and one more, cervical cancer vaccine is very important. So remember, if you found E6, E7 subunit in blood of any mother, this suggests high risk of cervical cancer. Okay. So if you found this in the blood as marker, it's a danger sign. Second thing, which subunit we use in cervical cancer vaccine? Lamba subunit or short? So we use L1 and L2 subunit when we give cancer vaccine, cervical cancer vaccine. Okay, lamba. Third thing they asked, which 2 strain are most common? So 2 most common strain is HPV16 and HPV18. These are most common strain. Last thing they ask is, do we allow cervical cancer vaccine in India? Yes, government has allowed. 9 to 14 year girls only in India allowed. In different developed country, we give it to boy also. But India, 9 to 14 year girls, 1 dose is allowed. Okay, so these 4 question has come, do remember. But when it comes to remembering important topic, I never teach in my life important topic. Why? Because if I teach these topics are important and question came from other topics, I will be blamed that I make you not read those topics by diverting you into more other topics. So only this question do not ask from any faculty, because whatever come in last 5 to 7 years, I think 7 years is better. Last 7 years of NEET PYQ, if you are doing with topic, you know all the questions which are important. So what are the important topic which came in 7 years of NEET? They are important topic. And if you have done 7 years of NEET, then please, I am sure out of 100 students who are listening, hardly 20 people had done 7 years of NEET. And most of the people, they do 3 years, 4 years, and they say we have done. No, you have to do 7 years. In the remaining days, do PYQ practice every day 200 question. Because if you can't do 200 in room, how can you do 200 in the exam? And if you have done 7 years, increase your knowledge by doing at least 2 years of MCI also, because MCI question and numerical specifically, another new question do repeat in NEET. So do 2 year of MCI plus do 5 year of INI-CET also, because think from an examiner mindset. If I am a professor who is preparing question, will I purchase Marrow, Prep, PW, any app and take questions from the app? No, I don't have money to purchase those things. Will I take time from my personal life and create new question? Very few professors will do it. Most of the professors, what they will do is, whatever has come in previous years, they can get it easily. They will turn it and they will ask it. That is why all the topics are very important to learn, because they will not, if 30% question are directly repeated in every exam, but more than that, 40-45% question are created by them by twisting it. So if you do previous year question of last 7 year, 90% question will be from last 7 year of PYQ topics. So please do this PYQ every day, 200, and whatever topic you got there, they are important topic. Plus, if you ask important topic, I can tell, but it's a huge list of important topic and it's very difficult to tell. Always remember, whenever you are reading demographic cycle and demographic indicator are very important topic. Then, of course, this dependency ratio and demographic dividend, demographic bonus, demographic burden, they are also important topic. There is a top YouTube video on my YouTube channel on this topics, 5-10 minutes, and you can understand. Plus, I hope you have read this topic, very important. Then the next topics which are important is definitely all the contraceptives, because gynae, PSM both ask, especially the um, side effects, absolute contraindications are very important. And when to put IUCD, what is the ideal time to put IUCD, very important. Then MTP Act and of course the prenatal diagnosis of pregnancy, that those two things are very important. Then uh, if you move to other part, it is the in the in the international health, work of different organization is very important, and along with work of different organization, SDG and bioterrorism agent is something which they are asking again and again. So these are some of the topics. I cannot list all the topics, but do not go without doing these topics and the topics which we discussed, plus all the topics which came in last 7 year of NEET, last 5 year of INI-CET, and last 2 year of MCI. They are important. Please, my dear friend, don't just keep reading notes, because notes are not asked in exam. In exam, they ask objective question and they are testing that under pressure can you recall or not. So if you practice 200 question per day, at the same time when your exam is there, then this 200 question per day practice will improve. And which question? Only PYQ, because exam setter will not take question bank new question. So 200 PYQ question with topic, if you practice every day, then your score will improve by 20 to 30% in just last 10 days which you have. 10 days, around 10 days you have, you can improve your score by 20-30 marks minimum if you do 200 question per day, because your recalling ability will be good, your smartness will improve, and if you do 200 question every day, there will be no anxiety in the exam because you are doing it every day. Okay, so thank you so much. Hasta la vista, dasvidania. If you have any doubt, any question other than that, feel free and let me know it. Okay, chalo, bye bye, thank you so much, bye.
Hello guys. So hope you have done well with your SPM ka marathon. So let's start orthopedics. Okay. Before that, can somebody confirm just the audio and video visuals are clear? Good evening, Shiva Prasad. Yeah. Audio is clear? Should I start? Yes. Thank you, Shiva, for that. So guys, so this is our marathon series. We are done with the SPM, that is community medicine, and now we are in the orthopedics. Tomorrow you will have biochemistry and obs and gynae. Okay. So as this is like the marathon, I will teach you everything, not everything in detail. We'll just rush through the topics so that we can cover maximum in the time allotted for us. Okay. Good evening, Nishu. A small request. I have been suffering from cold, so maybe sometimes my voice will go low. Just mention in the comments if my voice is going low. Okay. Chalo, let's start the class without wasting further time. So first and foremost thing in ortho is related to trauma, right? So usually they will ask you questions related to trauma. And before that, you have to understand that so whenever we talk about the trauma, it is mainly about the fractures. So these fractures are of two types, right? So there is an open type of fracture and closed type of fracture. I don't think that this is the time for you to, tell me that. Okay, Neetu, we'll do that. Whenever we come to that area, no, we'll make sure that it is understood in detail. Perthes, Skiffy, and TB. Okay, done. Noted. Right. So coming to the fractures. Yeah, I'll get well soon. Don't worry. Thank you. So fractures, there are two types of fractures, open and closed. I know, I am pretty sure that you all know what is open type of fracture, where there is exposed to the exterior environment, right? And closed fracture, there is no connection between the fracture and the environment, right? And similarly, we have other type of fracture, right? So this is pathological fracture. And then we have our stress fracture. Hope you're all well versed with all these type of fractures, like open, closed, pathological, and stress fracture. So just quickly an example, open fractures are mainly seen in tibia, right? And all generally there are closed fractures, and pathological fractures is mainly related to tumors and metabolic disorders. So whenever they're asking a question related to your pathological fracture, that means they are testing your tumor knowledge and metabolic disorders knowledge, okay? And then stress fracture. Stress fracture is, what is the major difference between pathological and stress fracture? In pathological fracture, what happens is the bone is abnormal. Here, the bone is abnormal, right? And stress fracture, the bone is normal. The bone is normal, right? And stress fracture, what is the most important example you have to remember? Your March fracture, especially in the second metatarsal. Right, so this is basically about the fractures. There are two types, open, closed, pathological, and stress fracture, right? And pathological fracture, what is the scoring system you have to remember? It is the Merrill's criteria, Merrill's scoring system, right? Just remember the name, Merrill's scoring system. Okay, is that clear? And now coming to the most important open type of fracture. So what is this important classification which you have to remember? This is your Gustello-Anderson's classification, right? So this is your Gustello-Anderson's classification. What is so important about this? This is very, very important classification, and questions have been asked based upon this classification itself, right? So coming back to the classification, so here if you see, this classification basically is dividing this into three types: type 1 or grade 1, grade 2, and grade 3. Again, grade 3 is divided into grade A, grade B, and grade C. And very, very easy one is grade C, where you have an vascular injury associated with the fracture. So whenever there is a vascular injury, directly it falls into the grade 3 factor. Okay, grade 3C. Right? And what is the difference between A and B? So difference between A and B is, here there is an involvement of soft tissue repair. So basically we'll take help of the plastic surgery, right? And then in A, it is no requirement of the plastic surgery, no requirement of the soft tissue repair or the plastic surgery repair. Okay. Shivani, Mandeep. So just wanted to make it clear that this class is very important for people who are preparing for NEET. Okay. So if you want to ask some generalized questions, no, we have various sessions where we can just talk about all these things. But now let us concentrate on the important workbook here. Okay. If you have any questions you ask related to that particular topic, I can clear. Okay. Okay, now what are the other important things you have to understand in the Gustello-Anderson's classification, right? So here I have told you the mechanism of injury is high velocity. Whenever grade 3, there is a high velocity injury which is happening here. So, and what you have to remember is the contamination. The contamination is also very, very severe. Contamination is also severe in case of grade 3, right? So that is what you have to remember here. Okay, good afternoon, Abhishek. Good afternoon, Toledo Blue. Okay, and soft tissue coverage, so it requires reconstructive procedures. I have told you that in 3B, and here it is the vascular injury. So vascular injury is 3C directly. Whenever they require a reconstructive procedure, that means there is no soft tissue coverage. So that is 3B, and in all this you have the soft tissue coverage through it. So 3 important things you have to remember. First is the energy, mechanism of energy, that is based upon the velocity. So is it a high velocity injury or low velocity injury? So high velocity is grade 3, low velocity is grade 1. And you know that Gustello-Anderson classification is mainly depending upon the wound size. So if it is less than 1 centimeter, it is 1, more than 1 centimeter is 2, and more than 10 centimeters, it is 3. Right? I think this is very clear for you. What you have to remember here is the contamination. They talk about the contamination as well, that is severe contamination in grade 3, and soft tissue coverage. So soft tissue coverage is not there from grade 3B, and grade 3C, it is vascular injury. Okay, hope this clears everything. So this is a pictorial representation of your open fracture. So here what happens is, see, in grade 1 there is only less than 1 centimeter wound. So there is only 1 centimeter wound, there is no much contamination, there is no toxic complexity of the fracture. In grade 2, what happens is it is between 1 to 10 centimeters, 1 centimeters to 10 centimeters, right? And grade 3, it is more than 10 centimeters. Right? In grade 3B, what we require is the soft tissue repair, reconstruction, where the soft tissue coverage is not there, and grade 3C is vascular. Okay, yes, that completes the classification. So here what is very important for us is the classification system. So classification system, why do you think it is very important for us? So first, telling the patient regarding the prognosis. So you will tell the patient the prognosis based upon the classification system, and you will start your treatment based upon the classification. So the importance of these two is you will explain prognosis and the treatment. So if it is grade 3C, so based upon your observation, you think that the particular patient has come with grade 3C. That means you will tell there is a vascular injury, you need vascular repair, and you will counsel the patient that this might land up in amputation as well because of the vascular injury, right? So you will explain the prognosis. It is easy for us to understand the treatment as well based upon the classification. But what is important is, in case of your Gustello-Anderson classification, they usually don't tell you about the soft tissue injury. So the importance of soft tissue injury is not mentioned anywhere, right? So importance of soft tissue injury is not mentioned anywhere. So that is one of the drawback of Gustello-Anderson's classification. So now we have various Cherny classification for soft tissue injury. So Cherny's is for soft tissue injury. So you want to in detail understand about what is the type of soft tissue injury, you have to use the Cherny's classification. And now, not to forget, there is one more scoring system which is called as the Mangel's Extremity Severity Score. This is MES, right? So this is MES, Mangel's Extremity Severity Score. In this, they usually teach you in the general surgery as well. So here what is mainly important is they are telling you about the energy, the skeletal and the soft tissue energy. Again, they'll talk about the limb ischemia, the shock, and the age. So this is what you have to remember. There are 4 components in MS. So first one is skeletal injury, then they talk about the limb ischemia, then they talk about the vascular injury, that is shock, and then they talk about the age. Okay? So everything has 3 components here. Okay, everything has 3 components here. So this is the Mangel's Extremity Severity Score, you have to remember. And soft tissue injury, there is 4. starting from 1 2 3 4, that is what you have to concentrate. So here it starts from 1 2 3 4, and limb ischemia it is 1 2 3, and shock it is 0, age it is 0. So less than 30 years it is 0, and shock if the systolic blood pressure is more than 90 it is 0. So shock and age you have to start with 0 1 2, and limb ischemia it is 1 2 3. So you remember that we usually arbitrarily take the 6 hours as the limit. You know, if the patient comes to you after 6 hours, we usually tell them there is the delayed, the prognosis is not very good. So arbitrary we fix it as 6 hours. That is the limb ischemia time. If the patient comes before 6 hours, then we can tell the patient that, you know, we can treat him in a better way. Okay, and again in the skeletal of soft tissue injury, that is again low, medium, high and very high injuries. That is 1 2 3 4. Okay, so this is about the Mangel's extremity severity score. And what is more important for us, why are we actually falling for this mess, is if the score is 14 or below, we can salvage the limb. So here the treatment mainly depends on whether you can salvage the limb or whether you have to amputate the limb. Okay, so initially, before maybe some 6 to 7 years back, there was no much plastic surgery approach, right? So plastic surgeons were minimal, and usually they would decide between salvage and amputation. Now because of lot of plastic surgeons are available, now the treatment is shifting towards the orthoplastic approach. So usually we are trying to salvage the limb, so approach is orthoplastic approach. So we are taking the help of the plastic surgeons and we are trying to salvage the limb as much as we can. But this mess is mainly regarding that. So whether you have to salvage or whether you have to go into amputation, or it is a gray zone. So for this, so here this scoring system is mainly for Ganga Hospital Open Injury Score. So never they have been asked a question regarding this. So I am anticipating they might ask, because this has been developed by our own South India. In Coimbatore, there is Ganga Hospital, if you know, people from Coimbatore or from Tamil Nadu. So this Ganga Hospital have done this extensive research on open injuries fracture. So based upon that, they have given certain scoring systems, so soft tissue injury. So based upon that, we will decide if the scoring is 14 or below, we go for salvage, 17 or above, we go for amputation. Right. So what are the advantages of this? This advantages is mainly for 3B fractures. So in open fractures, 3B if you do, in Gustilo Anderson, they have simply told us that 3B there is no soft tissue coverage. But what is that soft tissue? What is it tendons? Is it ligaments? Is it muscles? So Ganga Hospital has done extensive research. So they have specifically designed for type 3B. Right, and they will tell you whether you can salvage the limb or you can go for an amputation. For Gustilo, you can't usually decide whether to go for salvage or amputation, and it is better and intra and inter observer. That means it is usually, there are a lot of things which you have to consider giving the Ganga scoring. So what happens is the chances of you going wrong are less. So Gustilo Anderson is a broad, you know, so for Ganga you have various other sectors not necessarily important for you. So there are certain 5 boxes and you have to tick each box and count the score. So if it is 14, then you can go for salvaging. If it is 17, you go for amputation, right? So this, just remember there are 3 important scoring systems. So first is Gustilo Anderson. I know you are all very thorough with it. Then MES, Mangle Extremity Severity Score. It is mainly for the crush syndromes usually. And then the new one, what you have to remember is your Ganga Hospital Open Injury Score. Okay. Yes, that is about the classification. Now coming to the complications of fractures. So once you are dealing with the fractures, the most important thing you have to remember is the complications of the fracture, right? So once you have understood that the fracture has happened, whether it is an open and all, open, closed, you have to even know what are the complications of the fracture. Right. So coming to the non-union and the malunion. So first and foremost is union. So fracture usually unites. So whenever it is uniting, it is called as union. Right. So whenever it is not uniting, non-union is no union. Malunion is union is there, no alignment. Union is there, but there is no alignment. Right. Are you following, guys? Am I going fast? Yes, Kumar, Nishu, Tolidin, Blue, Shiva Prasad, am I going fast or? Okay, good. So now we are talking about non-union and malunion. So as I mentioned, you know, there is various stages of healing of the fracture, right? So it has gone, yes, thank you, thank you. So now you have to imagine going back to the healing stages of healing. So you know there is a hematoma, stage of hematoma, then there is stage of granulation, then there is stage of soft callus, then the stage of hard callus, then there is a remodeling. So these are the stages. So usually they have surpassed asking questions from the stages of healing. Now the questions are shifted towards your non-union and malunion. So right, there is a problem in the union. So what could be the problem in the union? So what do you think is basic necessity for union? So you have to imagine that the vascular supply, so the blood supply has to be good, and then stabilization. So these two are very important things which you have to remember. These are very, very important for a fracture to unite. So there should be a vascular supply and the fracture should be stabilized. If the fracture is moving here and there, if it is not properly stabilized, then it will not unite. Okay, and based upon this, we have three types. So hypertrophic non-union, and then we have atrophic non-union. Right, and in between what we have is oligotrophic, not very, very important for us because it is in between. There is no specification of this, but you have to understand whether this is an hypertrophic or atrophic non-union. Problem in hearing? Yes, can somebody confirm? Parth, as I've told, आवाज नहीं आ रही. Okay, thank you. So hypertrophic and atrophic non-union. So whenever we tell hypertrophic non-union, the only thing what you have to remember is hypertrophic. Trophic means any growth, right? Hypertrophy is growth, right? So hypertrophic means excessive growth. So what you have to remember, you have to remember that vascular supply is very good, but there is a problem in stabilization. So there is a problem in stabilization. So here the stabilization is not proper. So you will reconsider the surgery. So treatment here would be reconsideration of the surgery. For example, you have put the plate or nails, then you will put additional plate to it. So you will increase the stabilization. So vascularity is good, but stabilization is not good. Hence it is called as hypertrophic non-union. What is atrophic? You are very smart and I know you will understand. Atrophic is where there is absence of vascular supply. So here the vascular supply is absent and stabilization may or may not be a problem. So once the vascularity itself is not there, so it goes into atrophic non-union, right? So yes, callus is present in hypertrophic, and in atrophic callus is absent because it is the vascular supply, it is the blood supply which produces the callus, right? So yes, Nitu has made it very clear for us. So callus is present in hypertrophic, callus is absent in atrophic, right? Good. Then here, what is the treatment? So they will ask you what is the treatment for such atrophic. So here you go. Treatment would again be a surgery, but you have to add the bone grafting as well. So surgery plus bone grafting. So vascularity is the problem. So you will put new bone. So then it will increase the formation of excessive bone. So that is bone grafting. So treatment here is just stabilization in hypertrophic, and here it is bone grafting in atrophic, right? And now can you tell me what are the malunion? See, whenever we are talking about malunion, if this is your fracture site and this is your fracture site, so it should heal nicely, but what happens is the healing is something like this. So here the alignment of this and this is not proper. So this is malunion. Can you quote me a few examples of non-union and malunion, guys? Yes, examples of non-union and examples of malunion. So this is what they will ask you in the exam. Yes, very good. IT fracture. Yes, supracondylar fracture humerus. Then your Colles and clavicle. Very good. So you have to note down all this. So Colles fracture, clavicle fracture, supracondylar fracture, IT fracture. So these are all examples of malunion. Then non-union. Yes, the first and foremost is your neck of femur. Yes, very good. Neck of femur fracture. Then neck of femur fracture, then very, very important, talus, then your scaphoid. Again, if you remember the talus and scaphoid and neck of humerus, again this is all because of your vascular supply. So vascular supply is different in these all three conditions where the supply is from distal to proximal, right? So the supply is from distal to proximal. Yes, very good. Ecophyma, talus, and scaphoid. Okay, so this is about the non-union. Yes, these are all the examples of avian also. So whenever there is a problem in the vascularity, all this might also result in your avascular necrosis. Okay. Yes, is that clear? Yes. That is about non-union and malunion. Next, coming to the compartment syndrome. So once we are done with the one of the important complications, then we are dealing about the compartment syndrome. So as you all know, this is one of the most important clinical diagnosis. So there is no test for this. You have to depend only upon your knowledge, clinical diagnosis. So what is actually a compartment syndrome? So in case of compartment syndrome, hypertrophic non-union surgery is needed. You have to stabilize it, right? You have to stabilize, otherwise it will not heal. So the basic definition of non-union is itself surgical intervention is needed. Otherwise, it is delayed union. Without surgery, if it unites but not in the proper time, that is called as delayed union. But if you require surgical intervention for union of that particular bone, then it is called as non-union. So first we will understand about compartment syndrome, and then we'll see what is Sudeck's osteodystrophy. Okay, then coming to the compartment syndrome. So compartment syndrome, as you all know, this is because of your tight cast, okay, or post-surgery, or certain fractures of forearm, or because of your vascular injuries. Okay, so this is all the basic of your compartment syndrome. So the patient may have tight casts, so casing may be different. Yes, casing may be different. Post-surgery, the patient may have pain, fractures of forearm, usually in children, and then vascular injury. So what actually happens in compartment syndrome is whenever there is this inciting problem. So there is some problem in it, and what happens to this? Because of the osseofacial compartments. What do you mean by osseofacial compartments? That means the muscles are enclosed in the compartments, and now these muscles are enclosed by a tight fascia. Understood? So there is a tight fascia which is enclosing each compartment. So the culprit here is fascia. So because of the tight fascia, will end up in the problem. So what is that actually problem? So here what happens is, so first there will be some problem. So it could be tight cast, or it could be burns, or it could be vascular injury. Now what happens to this? So there will be an edema which is happening. So this will result in, whatever there is a problem, it will result in edema. So whenever there is an edema, there is decreased vascular flow. Right, so there is decreased vascular flow. Why there is decreased vascular flow? So there is an increase in the pressure. So whenever there is edema, there is increase in the pressure. So as you know, the fluid mechanics, usually they flow from high pressure to low pressure. But because of this high pressures here, they will be decreased in the vascular flow. So because of the decrease in the vascular flow, again there will be edema. So because of edema, there will be again increase in pressure. So there will be decrease in the vascular flow. Yes. So this is your vicious cycle which is happening. So usually they won't ask you this vicious cycle. What they will ask you is, what is the pressure? If it is more than 30 mm of Hg, then that is called as compartment syndrome, right? And then they will ask you, what are the signs and symptoms? So first and foremost, most important is your pain. So you have to remember that pain is the most important thing. And what is the sign? Stretch. Pain on stretch. So there will be pain on stretch. So there will be pain, and this pain is very, very important sign or symptom which is not coming down even with adequate doses of analgesics. Okay, not coming down even with the adequate doses of analgesics, right? So pain on passive, yes, the scavenger, you're right. Pain on passive stretch is the most important sign, and the compartment pressure is more than 30 mm of Hg. And the first and foremost thing what you have to remember is the pain. So you're giving analgesics and the patient is still complaining about the pain, then please make sure that you're not dealing with compartment syndrome. So first you have to exclude that. Then again, how do you confirm it? You will stretch. So you stretch stretch in the opposite direction. So for example, if there is a flexor compartment syndrome, then you will extend the wrist. So that what happens, there's a stretch in the flexors and patient will have severe pain. So that is pain on stretch in the opposite direction. And then all your P's, that is palar, paresthesias, paralysis and all are there. But what is the last one to occur? So this was asked in the exam. So last one is your pulselessness. So never look for pulselessness or never wait for pulselessness. This is the last and most worst sign and not at all important for us, and it will not help you in any way. Just to remember theory part. So we have pain, paresthesias because again nerves are involved in it. So pain, paresthesias maybe sometimes they occur, and then you have your palar and then paralysis and pulselessness. The last one is your pulselessness. Okay. So that is about your compartment syndrome. And what is the thing you do? So this is an absolute emergency. So this is an absolute emergency. And what is the treatment we proceed to? Proceed to fasciotomy. So this is an absolute treatment, that is fasciotomy, and you do in all compartments. So fasciotomy is done in all compartments, right? Yes, very good. The fasciotomy is done in all compartments. So this is about the compartment syndrome, right? So what are the reasons for compartment syndrome? What is the pathology of compartment syndrome? What are the signs and symptoms? And then what is the treatment? So first and foremost, you are going to remove the tight cast which is present, or you are going to make patient free with all the casing. If there is a cast which is present, first you will remove that casing, and then ultimately the treatment is your fasciotomy. Yes, scavenger, that's a very good question. Even open fractures might end up with compartment syndrome. Yes. Oh, what is deglobing injury? Deglobing injury is only that soft superficial tissue. So the skin and the superficial tissue, that is what is involved. So there will be inflammation of that skin and the soft tissue. It is not going into the bone, right? Only the upper layer about the fascia is involved. That is called deglobing injury. Moral laval lesion, that is called the moral laval lesion, where the skin, the soft tissue injuries above the fascia are involved. Compartment syndrome is below the fascia. The muscles are involved here. Okay. Now I think that clears Neetu Pathak doubt. Scavenger, yes. So even open fracture might result in compartment syndrome. Yes. Okay. Now next. Okay. Now next, one most important exam based question is, most important complication regarding your exam based question is this, the fat embolism. So what happened actually in the fat embolism? So you're all aware that whenever there is a long bone fracture, so this long bone fracture, what usually it contains fat globules in the marrow. It contains the fat globules in the marrow, right? So here what happens, the question usually it starts as a young male patient with femur fracture, right? With femur fracture, and usually this occurs 24 to 48 or 72 hours. It is not usually, so okay, just remember this as it occurs 48 to 72 hours after. So usually they tell you that on the third day, the patient will land up in certain symptoms. What are those important symptoms? Yes. So he will have petechial rash, confusion, neurology is affected, and then respiratory depression. Right? So this is the triad you have to look for. So patient, now how does he complain of? He complains of decreased in SOB, right? So SpO2. So there will be shortness of breath and decrease in the SpO2 levels, and then he will have confusion, he will have delirium, and then he will have rashes. This is the petechial rashes which are present. So that's the petechial rashes, and then confusion, and the neurological, all three. This is the triad. So these are all the symptoms which the patient will tell you about, and now they will ask you what is the diagnosis. So the diagnosis here is fat embolism syndrome. So whenever there is a long bone fracture because of the escape of these fat globules from the marrow, and what do? These fat globules, they will cause inflammatory reaction. They will cause inflammatory reaction to the small vessels or capillaries. right? So there is an inflammatory reaction which causes in the small vessels or capillaries, which are resulting in this petechial rash, confusion, and respiratory depression. So that is about your fat embolism syndrome. And now what is the treatment for it? So treatment is usually symptomatic treatment. So before that, what is the diagnosis? So here diagnosis, how you do? So you have the GERDS criteria, right? So there are GERDS criteria. So major criteria and minor criteria, it is again the same thing. In GERDS criteria, major is again your rash, your confusion, respiratory depression, and minor criteria, you have fever and rest, all the things, right? And now based upon this, there is a fat globules in the urine and the sputum. Sometimes you can identify, right? Urine and the sputum. And the D-dimer levels. The D-dimer levels also will help you. And ultimately, we'll go for CT angiography. Right? So this is how the diagnosis is made. And how do you treat it? So the treatment here would be symptomatic, hydration. So a lot of hydration. Yes. Fasciotomy up to subcutaneous layer. Fasciotomy is the thing where you will have to cut the fascia. This is not about subcutaneous layer or that layer. Only the fascia you have to cut. Okay. So you will go for hydration and you will go for anticoagulants. So heparin, right? And nebulization is the treatment, right? So that is about the fat embolism. So this is the fat embolism. So usually the question asked is about the young male. So this is what you have to remember, right? Yes, is that clear? Yes, good. That is about the fat embolism syndrome. Then coming to the crush syndrome. So crush syndrome is one again an important complication which we usually see. This is usually seen during the earthquakes or mainly during the mass casualties. So what actually happens in the crush syndrome? This is a combination. The crush syndrome is a combination of again your compartment syndrome plus your fat embolism. Right? So what happens in the crush syndrome? So because of the crush syndrome, there will be crushing of the limb, and what you have to remember is here there is the crushing of the limb which will result in the crushing of the muscles especially, right? So this crushing of the muscles, so two important things, one is myoglobin and the second one is potassium, because muscles are rich in myoglobin and potassium, so these two are released into the circulation. So this is what you have to remember in regarding your crush syndrome. So fat embolism, what you will remember? Fat embolism, you will remember that there is triad, right? In crush syndrome, what you have to remember is two important things. One is myoglobin and the second is the potassium. So because of the myoglobin which enters into the kidney, and now it will damage your acute tubular necrosis. So this will result in your acute tubular necrosis, right? And again, because of there is increased potassium, there are changes of hyperkalemia. Yes, you will treat the patient as acute kidney injury, ARF, or acute renal failure. Acute renal failure, you treat the patient, usually what we do, we go for dialysis, right? So now here, whenever it is in the circulation, acute tubular necrosis is one important thing you have to look for. And then there is hyperkalemia because of the increase in the potassium, right? Yes, you go for again hydration or you will go for dialysis. So that is about your crush syndrome. Okay, that is about your crush syndrome. Okay, the question here, what they have asked you is, which of the following electrolyte is not decreased in case of crush syndrome? So the answer was potassium. So the answer was potassium because usually what we see is, we see hyperkalemia. So because of the hyperkalemia, again, there is a chances of your ventricular arrhythmias, right? So there is a chances of your ventricular arrhythmia. So this is also you have to bear in mind. Yeah, yes, rhabdomyolysis is also seen, and because of the rhabdomyolysis only, crushing of the muscles is rhabdomyolysis, right? So that will result in the increase in myoglobin and your potassium. So this myoglobin will enter into the kidney and that will cause acute tubular necrosis. And the treatment here is, you treat it as your acute renal failure. So you treat this condition as your acute renal failure. Yes, Ved Guru, Tanuj Sharma, clear? So those are important complications. So first I have completed those two because those require a little bit of attention, and usually they keep confusing you whenever they are asked as clinical questions. So once you complete that, these are all little easy for you. So they're just like mugging up important fractures and all. Okay. Okay, now let's deal with the important fractures. So coming to the fracture clavicle. Fracture clavicle is supposed to be one of the most common fracture because this is one of the most subcutaneously present. So this is most common fracture, and usually treatment here, what is the treatment? You can go for conservative treatment. And what is the bandage you put? Figure of 8. So figure of 8 is the bandage what we use, right? And now they have been treating with the clavicular plating as well. Right, clavicular plating as well. And what is the important complication of fracture clavicle? It is malunion. This is malunion. And what is the vessel injury which might occur whenever there is a fracture clavicle? So there is a subclavian injury which can occur, which is just below the clavicle. So subclavian vessel injury, it may result in subclavian vessel injury. Okay, so that is about your fracture clavicle. Then coming to shoulder dislocation. So shoulder dislocation, what is the mechanism of injury in shoulder dislocation? What happens to the patient? The patient will fall in abduction and external rotation. So there is abduction and external rotation. So this is the mechanism of injury. So there is an abduction and there is an external rotation, which will result in what? It will result in your anterior shoulder dislocation. And which is the most common form of dislocation? That is your anterior shoulder dislocation. This is the most common, right? So this is the most common. Yes, very good, Aber. And this is the most common one. And what is the position? Attitude. Attitude, the patient will hold the limb in the opposite hand, right? And again, he cannot adduct. So there will be an abduction and external rotation, and he will hold the limb with the opposite hand. Yes, so that is about your shoulder dislocation. And now what is this x-ray? So there are multiple x-rays have been put up here. So quickly let's go through the first one. The first one, what is it? The first one, yes, this is a normal x-ray. Yes, and the first one here is your anterior shoulder dislocation. So here we already know this is the most common and mechanism of abduction, external rotation, right? And what are the tests? What is the test? Dugas? Yes, Dugas test. Hamilton ruler, Callaway. Light bulb is next, posterior one. Okay, now we are dealing about the anterior. So this is the anterior shoulder dislocation. So what are the various tests we have to remember? So what is Dugas? Dugas is touching the opposite hand, right? So this is what is the problem. So you cannot adduct. So you will have the limb in abduction and external rotation, right? You cannot adduct. So that is the basis of your Dugas test, touching the opposite shoulder. Hamilton ruler is Callaway's is not very, very important. So what is Hamilton ruler is just touching your bony point. So usually whenever there is dislocation, the bony points get disrupted, right? So that is Hamilton ruler. And Callaway's is nothing but your axillary circumference. So usually there will be an increase in the axillary circumference, right? So this is what theoretical, but the main thing you have to remember is the Dugas test, right? And what is the treatment for it? Immediate reduction. You have to go for immediate reduction of the dislocation, and then it is usually done under anesthesia, right? So usually done under anesthesia. So what is the mechanism? You will give traction, yes, external rotation, adduction, and internal rotation, right? So this is the medial rotation or internal rotation. So team is better. So we as a team, both ortho and anesthesia, they do traction. So there will be traction, external rotation, right? And then they will do adduction and medial rotation, right? So whenever you complete this maneuver, what happens is your hand goes and touches the opposite shoulder. So that is how you confirm that the shoulder dislocation has been reduced. So that is a treatment of this, okay? And then what is this? So the second one is here, this is your posterior shoulder dislocation. So what are the important points we have to remember regarding your posterior dislocation? So the first one has already been told. So there is a sign which is called as a light bulb sign, and this is an X-ray finding, right? So this is an X-ray finding on light bulb sign. It's an X-ray finding. And then what is exactly opposite to it? So there is an adduction and internal rotation, right? And here usually in cases of epilepsy and current shocks. So whenever there is a dislocation, you can see whether there is a history of seizures or there is a history of current shock. Usually this patient land up with posterior dislocation. This is not very common. So there is an adduction internal rotation. That is the mechanism. Right, so this is about the posterior dislocation, that is the shoulder dislocation. So mostly what they ask you is the signs, the light bulb sign on the x-ray. And what is this? So this is your inferior. So inferior shoulder dislocation, one most important point is hyperabduction injuries. That's it. Very, very rare. And whenever this happens, this is an hyperabduction injury, right? Okay. Is that clear? So this is an inferior shoulder dislocation. So if you see, there is an hyperabduction. So the head has gone, the humeral head has gone down, right? So you can see that there is an inferior movement of the head. So this is the inferior shoulder dislocation, right? Yes. Yeah, your luxatio erecta is your inferior shoulder dislocation, right? Yes, so this is about the various shoulder dislocations which you have to read and remember. So before going to one more thing, so recently what they have asked you is about AC joint. So now you see this is the shoulder, right? And this is your acromion, right? So this is your acromion and this is the clavicle. So this is your AC joint. So please be careful that they have asked question regarding this. So there is an AC joint disruption. So whenever you get a shoulder x-ray, what you have to see for the fractures. So first you have to comment upon the glenoid, then you will comment upon the head of the shoulder, then this is the shaft of the shoulder, right? And this is your acromion process and this is the clavicle. So this is the AC joint. So whenever there is an AC joint problem, so usually what happens is whenever the patient is having fall on outstretched hand or there is a problem in the adduction forces, so they will have pain in the AC joint. Yes, this is very clear. No, anteriorly it is dislocated. So this is the glenoid. So actually it has to touch, now this has come anteriorly. And here you don't see it has come anteriorly, right? So here you see the same in the glenoid, but it is like the light bulb sign. Okay? So here the head will become wider. So you will see the head towards you, more increase in size. So head here will become smaller. And you can see that there is an attachment between those two, but it is on the posterior aspect. Right? The shape of the head, you have to look about the shape of the head. And guys, don't forget about the AC joint, okay? AC joint disruption. So there are three types, 1, 2 and 3. 2 and 3 you will go for surgery and 1 you can go for conservative treatment. So last time they have asked about your AC joint, okay? Yes. Now what is this? So once we are done with the shoulder dislocation, then we are coming to the shaft. So this is the humerus shaft fracture. Yes, humerus shaft fracture. And now what is this? The second one. This you have to answer quickly. Quicker. Very good. This is the Holstein-Lewis fracture. So this is your Holstein-Lewis fracture. So what is so special about the Holstein-Lewis fracture? So Holstein-Lewis fracture, you will see humerus shaft fracture with the radial nerve injury. So you will see humerus shaft fracture with the radial nerve injury. That means the patient present with what? So the patient is present with the wrist drop. So there will be presence of the wrist drop with humerus shaft fracture. So that is your Holstein-Lewis fracture, especially in the distal. So this is the, so if you divide, this is your proximal, right? This is your middle and this is your distal. So exactly junction between this middle and distal, you will have this fracture, and because of the lateral intermuscular septum. So there is a lateral intermuscular septum where the radial nerve pierces through it. So this pierce is usually what happens is the radial nerve gets attached to there. So this, whenever it is piercing the lateral intermuscular septum, the radial nerve gets attached there and it cannot move. So because it cannot move, it gets crushed between the fracture fragments and resulting in radial nerve injury. This is called wrist drop, Holstein-Lewis fracture. This is an example of, again, a neuropraxia. right? And then coming to the humerus shaft fractures. So nothing much about humerus shaft fractures. So what they will ask you is the treatment. So treatment, usually we go for humerus plating. Okay, humerus plating, open reduction and internal fixation with humerus plating, right? So that is what you have to remember about the humerus shaft fracture, right? Next, then what is this? Yes, what is terrible triad of injury of the elbow? Very, very important again, terrible triad injury. So whenever there is a posterior dislocation of elbow with radial head fracture, yes, and coronoid fracture. So that is your terrible triad of injury. So now let me help you to understand. So this is the dislocation. So now this is your olecranon process and this is your humeral distal end, right? So they are not in contact. So whenever they are not in contact, that means there is a dislocation. And with the dislocation, whenever there is a radial head fracture, and coronoid is this particular chip. So what is a coronoid? Coronoid is, this is the olecranon you have. So this particular area on the anterior aspect is called the coronoid. So whenever there is a fracture of this coronoid, it will leads into stability. So posterior dislocation with radial head fracture with coronoid fracture, this is called terrible triad of the elbow. And what is this? So whenever there is radial head fracture with DRUJ, distal radial head injury, and this is through the interosseous membrane. So this is called as 𝐒𝐿-Lopresetti. Very good, 𝐒𝐿-Lopresetti fracture. Okay, so what is the main thing about it? This is because of there is a passage of the force of mechanism through the interosseous membrane. So this is the interosseous membrane. So first there will be violent injury here, and this has split the interosseous membrane and resulted in DRUJ injury. So this is called as the 𝐒𝐿-Lopresetti injury. And similarly in the leg we have ankle fracture with, what is that called? Similarly, like the 𝐒𝐿-Lopresetti, we have ankle fracture associated with the fibular head or neck fracture. That is also through the interosseous membrane. What is this called? This is called as the Mason-Davies fracture. So this is also through the interosseous membrane of the leg. Yes, very good way. That is Mason-Davies fracture. So Mason-Davies fracture is in the limb, lower limb, and 𝐒𝐿-Lopresetti fracture is in the upper limb. And don't get confused between the 𝐿-Lopresetti and 𝐒𝐿-Lopresetti. 𝐿-Lopresetti is radial shaft. So there is a fracture of the radius associated with the DRUJ. Here radius head with the DRUJ and in between the interosseous membrane. So terrible triad of injury, and then your 𝐒𝐿-Lopresetti and your Mason-Davies fracture, right? And then coming to the forearm fracture. So forearm fractures, we have two important fractures. So one is your Monteggia. The second one is your 𝐿-Lopresetti. I hope you're all very versed with these two. So let me just quickly refer. So what is Monteggia? Fracture ulna with the PRUJ, right, or radial head. Yes. And what is your 𝐿-Lopresetti? 𝐿-Lopresetti, I have told you, fracture radius with the DRUJ. Okay. Yes, ulnar fracture is Monteggia, radial fracture is your 𝐿-Lopresetti. Very good. So in this DRUJ, what usually we'll see is DRUJ, distal radio-ulnar joint. So distal radio-ulnar joint is where the ulna is, combined. There is a so there is a radial fossa, ulnar fossa here, and now this ulna gets to sit into here. And in this DRUJ, there is one more component which is called as TFCC. Triangular fibrocartilage. So this is the triangular fibrocartilage which is present in the distal radio-ulnar joint. So the examiner has asked the TFCC is injured in case of which. So TFCC is the structure which is present in the distal radio-ulnar joint. So this much if you remember, it is fine. So TFCC is triangular fibrocartilage complex which is present in the distal radio-ulnar joint. So they might ask you, there is a fracture and this fracture has resulted in the damage of TFCC. So what type of fracture is this? So TFCC injured in 𝐿-Lopresetti. Very good. That is what I wanted to tell. Yes, that completes your forearm fractures. Then coming to your metacarpal. So there are two important fractures, Bennett's and Rolando. So what is Bennett's? Bennett's is bi. So bi, there are two fractures. So there is a two fragment fracture. And both of them are intra-articular, not to confused with this. And this is a comminuted Rolando. They will just ask you the name. What is Bennett's? What is Rolando? So this is a 2-part fracture and this is a 3-part fracture, right? And because the small fragment, there is a tendon pull. So that is why you have to, yes, this is a base of first metacarpal. Base of first metacarpal, we have 2, Bennett's and Rolando. Bennett's is 2-part, Rolando is 3-part, right? So which one you will fix? So this is surgical fixation, because you remember there is a tendon pull over it. So this larger fragment, they have a tendon pull. So that is why you have to fix this. So this is comminuted, hence it can be treated conservatively as well. So because this is intra-articular, so this is the intra-articular, this is also intra-articular. But here what happens, because of the pull, of the tendon at the base of the first metacarpal, then it requires surgical fixation, and this is comminuted 3-part fracture in the shape of Y, right? In the shape of Y. So this is the Rolando's. So Bennett's is bi, right? This much you remember, this is enough, okay? And then what is this? This is scapholunate dislocation. And what is this sign called? This is just asked as an IBQ. This is called as the Terry-Thomas sign. So Terry-Thomas sign is the Thomas who has the gap between the 2 teeth. So this was his teeth and there is a gap between 2 teeth. And this teeth has been compared to this scapholunate. This is called as Terry-Thomas sign. Yes, Ved Guru correct. Terry-Thomas sign. So just IBQ, Terry-Thomas sign, where it is seen in scapholunate dislocation. That's it. Okay. And before that, one more important thing is scaphoid fractures. So scaphoid fractures, what you have to remember, 3 important points. So first you have to remember the anatomical snuff box. They will ask you, there is a problem in the anatomical snuff box and now the x-ray is normal. What is the view you have to take? You have to take the oblique view of the scaphoid, right? And this scaphoid is more prone for avascular necrosis and hence non-union, right? So one is the view they will ask, second they will ask the clinical information, that is anatomical snuff box, and then they will ask you if the patient has been come with the injury, right? And now there is a diagnosis of scaphoid, but not very sure. So there is a tenderness in the anatomical snuff box, but the x-ray is not showing anything. Still, you will treat the patient with the cast and tell him to come back after 2 weeks. So always remember treatment. Treatment is over treating the patient. So you have to treat the patient. You should not neglect the fracture. So casing, again, you will do the glass holding fashion, right? And again, you review after 2 weeks. And if there is an AVN or avascular necrosis, what you have to do, the investigation of choice is MRI. So you go for an MRI in case of AVN or non-union. And if you want to treat this, there is a special screw which is called as your Herbert screw. So this is called as your Herbert screw, right? So this is about your scaphoid fracture. So this is about your scaphoid fracture and intra-articular, that is the base of the first metacarpal. So now that completes. And one more I forgot, that is your boxer's fracture. So neck of the 5th metacarpal. So these 3 has been asked as a match the following. So Bennett's, Rolando's and boxers. So these 3 are very, very important. You have to just remember the names. Bennett's is by, Rolando's 3-part and boxers is neck of the 5th metacarpal. Not metacarpal, yes. Yes. Now going to the lower limb. So lower limb, you know pelvis and the acetabulum. The classification name of pelvis is tile classification. And the acetabulum, Letournel and Judet. So names of the classification is again been asked, right? So in pelvis it is the tiles classification, and this acetabulum it is Letournel and Judet classification. And what is Duvernay's fracture? Duvernay's is isolated wing. So this is isolated iliac wing fracture. So this is isolated iliac wing fracture, that is Duvernay's fracture. And then we have 2, that is the straddle fracture. So mostly you have to remember the straddle fracture. What is straddle fracture? So straddle, remember there are 2 O's, right? So superior and the inferior pubic rami bilaterally. So if you see, this is your obturator foramen, right? Superior and inferior. So this is your straddles fracture. So straddles, there are 2 O's like this. So remember the straddles fracture, you have superior, this is superior pubic rami and inferior pubic rami. So there is ultimately involvement or obturator foramen. And now what is this? There is a problem anteriorly and there is a problem posteriorly, but this problem is on the anterior and the posterior, but on the same side, that is ipsilateral side. So what do you mean by ipsi? Same side. So this is an example of your Malgagne's fracture. So this is Malgagne's fracture, that is your ipsilateral, same side, anterior and posterior. So this is your Duvernay's isolated wing fracture, vertical shear wherever there is an involvement of anterior, superior pubic rami and posterior, sacroiliac, right? Why, Ved, you're crying? What happened? See, Duvernay's is isolated wing. Duvernay is isolated wing, okay? And then whenever we talk about Malgagne's fracture, it is ipsilateral, same side, okay? And straddle fracture, okay, these are important pelvic fractures. Difficult. Okay. Let it make it clear for you. Don't worry. Okay, first, whenever they talk about pelvis and acetabulum, remember there is a classification, that is pelvis, it's a tile classification, and acetabulum, it is liternal and Judet classification, right? So there are certain eponyms like your Montigia, Gellezi. There are 3 important things which you have to remember. You have to remember, right? So first is the Duvernay's fracture. Duvernay's fracture is isolated iliac wing. So there is no problem in the stability. So whenever you talk about the pelvis, so pelvis is, we consider this as a ring-like structure. So ring-like structure, there is pubic symphysis, right, in the anterior aspect, right? And posteriorly we have sacrum and the iliac, right? So this is the sacroiliac joints, right? And this is the iliac wing here. This is iliac wing here, right? So whenever they talk about pelvis, you have to tell whether it is a stable fracture or an unstable fracture. So this is the sacroiliac joint, and this is the pubic symphysis anteriorly, what I was telling about. And now so pubic diastasis. So what is pubic diastasis? So pubic diastasis. So pubic diastasis is a condition where both the pubis, so this is your pubic symphysis, this is your pubic symphysis. Now there is a gap between these 2 pubic symphysis because of the trauma. So there is a trauma and there is a gap between the pubic diastasis. If it is more than 2 centimeters gap, so there is some problem. So there is some ligament tear or some injury to the pelvis that is resulting in the pubic diastasis. So that is one thing you have to remember. And then isolated iliac wing fracture. So whenever there is only one fracture, so now there is a fracture in this. So if there is a iliac wing fracture, do you think there is a disturbance in the pelvic ring? Do you think there will be a disturbance in the pelvic ring? No, right? So it is only iliac wing that is getting fractured. So there is no disturbance. So this is a Duvernay's is a stable fracture. Right, Duvernay's is a stable fracture. And then now coming to this. So if you think there is a problem in the pubic symphysis here and there is a problem in the iliac wing, right? So here there is a problem. So in the complete ring, 2 points have been injured. So now this becomes an unstable fracture. So this becomes an unstable fracture. So the name of the unstable fracture where there is an involvement of the anterior and the posterior column is called as the Malgagne's fracture. This is called as Malgagne's fracture. And coming to the straddle fracture, just remember this is the obturator foramen. This is the obturator foramen, right? So superior pubic, bilateral superior pubic, inferior pubic, bilateral inferior pubic. So there is a fracture of bilateral superior pubic, bilateral inferior pubic. Right? So that is your straddle fracture. So that is your straddle fracture. Just remember, straddle mein you have 2 O's like this. So I was talking about this. Right? So that will help you identifying the obturator foramen. So that is your straddle's fracture. Okay, got it? Okay, thank you. Yeah, pubic diastasis is also clear, Neetu? So that is about your pelvic fractures, right? And this is your favorite. What is this? This is your posterior hip dislocation. So this is what they will put as an example. What is the attitude of the limb? Wait, the IT fracture. This is posterior. Yes, okay. There is a flexion adduction, internal rotation, right? Father. So this is your posterior hip dislocation. So this is an example of posterior hip dislocation. Okay, now this is the limb, not this. This is the limb. Okay, so flexion, adduction, internal rotation, posterior hip dislocation. And on the x-ray, what you see? X-ray, you see there is an increase in the, or there is an absence of the lesser trochanter, right? There is an absence of the lesser trochanter, right? Yes, the sciatic nerve injury is one more thing, the sciatic nerve injury. So most common injury is your sciatic nerve injury. And how the patient presents whenever there is a sciatic nerve injury, it is the foot drop, right? So what is the treatment? So whenever you see posterior hip dislocation, flexion, adduction in internal rotation, you have to check for the foot drop, and now you will go for reduction under anesthesia. It is an emergency, again you will go for reduction under anesthesia, right? So again you give traction, external rotation, and then you do internal rotation of the limb. Okay, so that is dislocation of the posterior hip dislocation. And first and foremost thing what they will ask you is about the attitude of the limb. So this is the attitude of the limb, and then they will ask you about the x-ray. So x-ray, what you will see? You will see that the head has been dislocated and there is an absence of the lesser trochanter. And then they will ask you what is the complication. So complication is sciatic nerve injury, and what is the outcome of this complication? It is the foot drop, right? So what is the treatment? Finally you go for reduction under anesthesia. Okay. Yes, what is this? Yes, this you have to answer. Yes, this I am expecting you to answer. So there is a fracture of the ankle, and then you will see so here what I'm trying to tell you is this is the ankle fracture, or at least there is an ankle. So this is the medial malleolus, right? And this is the lateral malleolus, and there is an increase in the space, right? So there is some problem in the ankle, and then there is a fracture in the fibula here. So what is this fracture? I'm not asking you something which is not taught. Hey, what you should have fracture? There is only ankle dislocation here. Can you see any fracture here? This is ankle dislocation, right? Ankle dislocation with the fibular neck fracture. We have just discussed. Yes, mesonevis fracture. Right, this is a mesonevis fracture. Yes, so this they will put this x-ray and they will ask you what is this. So this is a mesonevis fracture. Right, okay. Then what is this? So these are certain angles, and these angles are drawn in the calcaneum. So before that, calcaneum fracture. So whenever you have a calcaneum fracture, it is usually whenever the patient lands from a height. Okay, so lands from a height, it jumps from the tree or jumps from a wall and lands from a height onto the floor, there will be calcaneum fracture. And usually there is bilateral calcaneum fracture, and you should always check for dorsolumbar spine as well. So dorsolumbar spine fractures also you should check. So whenever there is a calcaneum fracture, usually the history would be patient is jumping from a height and he's landing on the floor, and usually it is bilateral. And when this is, yeah, so you have to even check for your DL spine. So whenever we treat the calcaneum fracture, we have to be pretty sure that we are going to restore two important angles in the calcaneum. So one is your Bowler's angle. The second one is your Gissane's angle. Bowler's and Gissane. So what is Bowler's and what is Gissane? So before that, just imagine. So this is the calcaneum highest point, okay, posteriorly. And this is the fossette. So this is the end anterior fossette, posterior fossette. So there is a line which is drawn along this anterior and posterior fossette, and there is a line which is drawn on the posterior aspect. So this is called your Bowler's line. And two lines drawn along the fossettes like this is called the Gissane's line. So once we have treating the calcaneum fractures, so what happens in the fractures? Bowler's fracture angle decreases, right? Ghissens increases. So how do you remember? Ghissens is gains, right? So there is an increase. Yeah, lowers. Bowlers is lowers. So these are the two important, yes, very good. So these are two important angles. Usually they will ask you what is Bowlers and what is Ghissens, right? And what is Kite's angle? Yes, what is Kite's angle? Kite's angle is between talus and the calcaneum. So Kite's angle is between the talocalcaneum, and this is mostly seen in which condition? Yes, very good, Nitu. It is seen in the CTEV. So CTEV, there is a talus and there is a calcaneum, and you see there is the angle between them is 0 degrees. So this is called as parallelism. This is called as parallelism. So this is the CTV Kite's angle, and this is called as parallelism. And this is Bowlers and Ghissens. Where is alpha and beta angle seen? Alpha and beta angles. So these two are important angles which are seen on the ultrasound and mainly used for which condition? Alpha and beta angles? Yes, DDH. Very good. So alpha and beta are used for ultrasound, that is DDH, diagnosing the DDH. Kite's angle is for CTV, Bowlers and Ghissens is for the calcaneum. So these are certain angles which you have to remember. And there was an exam question which was asked in the tabular form. Okay. What is this? What is this? Now you can see there is a complete damage to all these parts. And that is the torso metatarsal. So all torso and metatarsal fractures have been occurred. What is this called? This is called as the Lisfranc injury. No, this is Lisfranc. Yes, Lisfranc. What is Chopard's? So Lisfranc is torso metatarsal. So there is a gap between the dorsal. So this mainly what you have to look for is this. So there is a gap between first and the second metatarsal. So that is the torso metatarsal, which is the Lisfranc. Chopard's is? Chopard fracture is, yeah, mid-tarsal or the intertarsal. It is mid-tarsal fracture or the intertarsal fracture. Right, so these two are important in the foot. So one is Lisfranc's fracture. So the first one is Lisfranc, the second one is your Chopard's. Lisfranc's fracture dislocation and Chopard's fracture dislocation, right? Yes. And now fifth metatarsal base. What is this fracture? Fifth metatarsal base. This is your Jones fracture, right? And second metatarsal neck. This is your stress fracture. So these are various fractures in the foot. So one is your Lisfranc's, Chopard's, Jones and stress. So usually what they will ask you is the name of the fractures in case of your foot. Okay, so now that completes. And talus fracture, they have asked you what is the classification name. It's called the Hawkins classification, right? It is also called as the aviator's fracture. What is runner's fracture? Yes. What is bumper's fracture? There are various, again, you have to learn. Bumpers is lateral condylar. So bumper is that bumper of the car will, you know, come and dash to your leg. So usually on the medial side will not have anything. So we'll have problem on the lateral condyle because the bumper can hit only on the lateral condyle, right? So that is your bumper's fracture. What is runners? Runners is again a stress fracture type. So usually we'll see in the tibia whenever there is excessive running. That is called a runner's fracture. Yes, that are certain important fractures. And now let's go to the spine trauma. So these are So these are the various spine trauma injuries. So we are done with the upper limb, lower limb, and now we have come to the spine. So now what is this? So before talking about the spine, you should know what is the classification which is used for this. The classification is, yes. So in the spine, what we have is this, like this and this, right? Then is 3-column. So then is 3-column concept. So this is what you have to remember in case of your spine. So this is called a Dennis 3-column. So what is that Dennis 3-column? It is the anterior, middle, and the posterior. So this is the anterior along with their anterior longitudinal ligament, middle, and posterior along with your posterior longitudinal ligament. Right? So that is your Dennis 3-column concept in case of this spine. And now we have various spine names as well as the upper limb and lower limb we have seen. So what is the burst fracture? So this is the burst fracture. So whenever there is a complete damage to the particular vertebra like this, so if there is a complete damage to the vertebra, like they burst out, so there is involvement of the middle and the posterior usually. So usually it will result in a burst fracture. So the complete vertebra is involved. So burst fracture. Next comes the chance fracture. So chance or the seat belt fracture, it is usually flexion and distraction injury. What you have to remember is only one thing, where you see there is a horizontal line like this. So the fracture is horizontal. So whenever you see a horizontal fracture, so that is called a chance fracture, and this is a previous year question. So what is chance fracture? It's a previous year question. So one is your burst fracture, then is your chance fracture. And what is this? So this is a spinous process fracture. Spinous process fracture, what do you call it? Yes, Clash overlays fracture, right? So Clash overlays fracture is the spinous process. Spinous process fracture, avulsion of the spinous process, usually C7 or T1. Lower thoracic or upper T1 is your Clash overlays fracture. And dense fracture is the odontoid. Yes, C7. So odontoid fracture, odontoid is nothing but there is a C2 vertebra. C2 vertebra, there is an odontoid like this. So whenever you talk about the, so this is this, the dense. Okay, whenever there is a fracture of this is called as dense fracture. And what is hangman's fracture? Hangman is traumatic spondylolisthesis. So this is C2 and this is C3. So there is a slippage of C2 over C3 which is called as traumatic spondylolisthesis. So what is listhesis? Forward protrusion of the upper vertebrae, right? Similarly, whenever it is happening with the C2, that is called as hangman's fracture. Hangman, because there are two, remember it is C2. Jefferson, so there is F in it, so remember it is C1, vertebral cervical vertebrae fracture. So C1 is Jefferson's. Hangman, it is C2. And then whiplash injury. Whiplash is nothing but there is no absolute fracture in the bone, it is a soft tissue injury. So what happens is whenever you are driving the car like this and sudden jerk of the car, if you go and hit somebody or somebody is hitting you from the back, you go like this and then come like this. So if there is a hyperextension with flexion like this will result in damage to your soft tissues. So patient will have severe pain, but there is no proper things you can see on the MRI or the X-ray. So you can conclude that as a soft tissue injury, which is called as a whiplash injury. And then coming to the undertaker's fracture. Undertaker's fracture is usually the fracture of the lower cervical spine. That is C6 and C7. It is mainly postpartum. Not postpartum, it is postmortem. So after the patient dies, they will shift to the postmortem, right? So during that, there is a fracture happening in the lower cervical spine, which is called as undertaker's fracture. Okay, is this clear? Yes, guys? Sleeping, everybody? Okay, is that clear? Any problem with my voice? Okay, done. So that is about your spine, and now you're going to write all this by your own. Okay? Yes. And now, what is this? Classification name, right? So there are certain names we have already So we have already dealt with it. So classification names. So here the proximal humerus, what I have told you, we have learned about the tile classification and laternal and Judet classification of acetabulum, right? So similarly we have proximal humerus. So proximal humerus needs 4-part fracture. So usually Neer has divided the proximal humerus into 4 parts, and now he has given a classification. So proximal humerus, it is Neer's classification, and then femoral head, it is Pitkin's classification, and Montigia, it is Bedos, and acetabulum, laternal and Judet. Supracondylar, it is Gartland's classification. Calcaneum, we have Essex Lopticity classification, and for the CT scan we have Sanders classification. So whenever there is a calcaneum fracture and you're going to CT scan, there is a Sanders classification for that. And femoral neck, we have Gardens and Powell's classification. The lateral condyle, we have Milch and Jacob's classification. Is that clear? So just you have to remember all this classification names. So what is important for you is, so first is proximal humerus is very, very important, and supracondylar has been asked. So Gartland classification, most common type is extension, right? Extension injury or the posterior injury. Right, so that is what this is, just you have to remember. So proximal humerus has been asked, that is Need's classification. Supracondylar has been asked, that is Gartland's classification. I think femoral neck you are very pretty sure, Gardens and Bowles, and lateral condyle also, this is fracture humerus. So that is your Milch classification, right? Here, yes. Now again you're going to fill up this in your workbook after finish of this class. Okay, after the end of the class you're going to write it. Okay, next, coming to the pediatric orthopedics. Now it has been time for, somebody has asked about the Perthes, Skiffy and all, no? So just take a deep breath for 2 minutes, and then we'll start with the Salter-Harris classification. Okay, now coming to the pediatric orthopedics. So first and foremost thing is, in case of pediatric orthopedics, what they will ask you is about the Salter-Harris classification. So what actually is this classification? So whenever there is a growth plate injury, so whenever there is growth plate injuries, so what is a growth plate? So growth plate is nothing but the physis. So whenever you look at the long bone, so this is your epiphysis, this is your meta and diaphysis, and this is again your epiphysis. So this is epi, meta, dia, meta and epi. Right, so now here we have this important structure here and here. For long bone especially, this is called as physis. So this is called as physis or your growth plate. So as the name suggests, growth plate, that means the longitudinal growth of the bone is mainly depending upon this particular physis. And coming to the physis, this is the structure. So epi, meta and dia, and in between you have physis. So there are various layers in it. So towards the epiphysis we have the germinal zone. And then we have the proliferative zone, then we have hypertrophic zone, and finally we have zone of enchondral classification. So this is nearing the epiphysis, we have the germinal zone. What is this germinal zone? This is called as a reserve cell. Okay, so the stem cells are all present in this germinal zone. Once the cells has been present, they get differentiated, and now they get increase in the number. So that is called as the proliferation. Proliferation means increase in the number, and hypertrophy is where they increase in the size of the cell. So this is the weakest area. So weakest area in case of your physis is the hypertrophic zone. So weakest area is the hypertrophic zone of calcification, right? And finally, near the metaphysis, we have zone of enchondral classification. So here we have enchondral ossification. So ossification is nothing but usually the calcium and the phosphorus gets deposits here. So that is why in case of rickets, the metaphyseal changes are more. So in case of rickets, what happens? You will see the changes are more towards the metaphysis, because the zone of enchondral ossification is mainly towards the metaphysis, right? So towards the physis is the reserve cell or the germinal zone where the stem cells are present, right? And the weakest area is the hypertrophic zone. Understood? This is very, very important. And now I'm coming to this Salter-Harris classification. So why again the classification? So we have to always remember the classification is mainly for the treatment part. So the treatment can be based upon this classification and mainly the prognosis. So now if you have a patient who has come with the physeal injury, now you see the x-ray and decide which type of an injury it is. So whenever it is type 1 Salter-Harris classification, type 1 S, A, L, T, E and R. So this is 5 types. 5 types are there in Salter-Harris classification. And coming to the type 1 S, that is straight. So straight is through the physis. So through the physis without involving meta and epiphysis. So the example here is it is going to zone of hypertrophy. Why zone of hypertrophy? Because that is the most weakest area. So here it is directly going through the physis. So this is the hypertrophic zone where the first one occurs. So example here is the skiffy. Right? Skiffy. And then coming to the type 2. Type 2, if you see, this is involving the physis and it is going above. So type 2 involving the physis and it is going above. So what is above the physis? Above the physis is the metaphysis here. Right? Just remember this is the meta and this is the epi. Don't get confused in the opposite way. So this is meta and this is epi. So here involvement of metaphysis and you can see Thurston-Holland fragment. So there is a small fragment which is called as the Thurston-Holland fragment. And usually the example here could be the supracondylar fracture humerus. Right? So this is about the metaphysis. So involving the physis and the meta. Right? To some extent. Then comes the L. L means lower. So lower is involving the epiphysis. So lower is involving the epiphysis. Right? So involving the epiphysis. So whenever there is an involvement of the epiphysis and this is T is through. So through the physis. So involves the meta, involves the physis and involving the epiphysis. So all the three are involved and ER is a crush injury. So here type 3 you can take the example of lateral condylar fracture. Humerus. Right? Yes. So these are the various things which you have to remember. So these are all the questions. So what is type 1? It is Salter-Harris type 1 is through the physis. So that is straight, which is involving the zone of hypertrophy, right? And above is involving the metaphysis, below is involving the epiphysis, T is through and through, that is through the physis, epi, meta and the epimeta and the physis. Type 5 is the ER, that is crush injury. So completely there is a damage to it, right? Yes. Now tell me, in which particular types the growth is disturbed? So mainly why are we concerned about this? We are concerned because there is a problem to the growth, right? So the physis is damaged, there will be problem to the growth. Skiffy is type 1. Skiffy, you don't know what is Skiffy? Slipped capital femoral epiphysis. So where do you think the growth is disturbed? Whether it is in type 1, 2, 3, 4, 5. Yes, come on. You have to answer this. Yeah, T-lox is also type of type 3. That is seen in the ankle fracture, okay? Yes, very good, Nitu. The answer here is 3, 4, 5. Why it is 3, 4, 5? Because the involvement of the epiphysis. So epiphysis is the one where the reserve cells are involved. So that is why the growth disturbances are seen in the 3, 4 and 5. So growth disturbances are usually seen in 3, 4 and 5. Okay? Yes. Answer is 3, 4 and 5 because the involvement of the epiphysis. So that is about your Salter-Harris classification, right? Then what is this? This is a supracondylar fracture humerus, right? So usually seen in 4 to 8 years of age, right? And here Gatland classification we have already discussed. Yes. Yes. And what is the most important thing here? It goes into malunion. So malunion means there is a alignment problem. So alignment will result in deformity. So this deformity is called as the gun-stock deformity, right? Gun-stock deformity, yes, or cubitus varus. Okay, what is the treatment for any deformity? It is osteotomy. right? And here the name is French osteotomy. And what are the various complications which we can expect? So here the patient might land up with damage to the brachial artery, right? So that will result in pulseless hand. You have to check for the pulses, and then there will be damage to the nerve. Yes, nerve amro, right? So anterior introitious, median, radial, and ulnar nerve. So this is about your supracondylar fracture. So usually seen in 4 to 8 years. Gatland classification, Malurine is one of the most important classification, right? So this is the supracondylar fracture. So this is above the condyle. So the question here asked is the 3-point bony relationship. What is the thing about 3-point bony relationship? Is it maintained or is it disturbed? Yes, maintained or disturbed? It is maintained. Why? Because it is above the condyle. So usually the 3-point bony relationship is maintained in case of supracondylar fracture, but in case of lateral condylar fracture, it is disturbed. So coming to the lateral condylar fracture, so here what happens is there is cubitus valgus. So there is a cubitus valgus, and now because of cubitus valgus, there is a ulnar nerve stretching, which is called as tardy ulnar nerve palsy. So these are the important things which you have to remember about lateral condylar fracture, right? So that is the supracondylar fracture, and this is your lateral condylar fracture. Lateral condylar fracture is the deformity is cubitus valgus, and that will result in tardy ulnar nerve palsy. So whenever you see a patient with the claw hand, and now in the history he has some trauma, so what could be the trauma? The trauma could be a lateral condylar fracture humerus, right? So this is cubitus varus and Gunstock deformity. What is this? So if you see, there is a buckling of the cortex, which is called as the what fracture? Which is called as the torus fracture. So this is called as the torus fracture, buckling of the cortex. So this you can see there is a buckle here. So this is called as the torus fracture. And then you have green stick fracture. So what do you mean by green stick fracture? So green stick fracture is nothing but there is a, so here there will be break in one cortex and there will be bend in other cortex, right? So there will be a break in one cortex and there will be a bend in other cortex. So usually we know that the bone has 4 cortices, right? On the AP view you can see 2 cortices. So this is one cortex, for example, and this is other cortex. So whenever there is a fracture, so here there will be break of the fracture, and this particular part, no, it will result in bend. So there will be only bending, there is no break. So such fractures are called as the green stick fracture or the unicortical fracture. Yes, it is also a pediatric type of fracture, right? And now dealing with the deformity. So what is this deformity? Yes, very, very important, your CTEV, right? So what is CTEV? So congenital DDH. Where you can see DDH? CTEV, congenital talipes equinovarus. So you all know that is congenital is nothing but to the birth, tali is ankle, pes is foot, and you can see the 2 important deformities. One is plantar flexion and the second one is varus. So inward rotation, right? So you can see that there is a varus. So this is the varus. So usually, oh, typo, okay, no problem. Right, so there is a congenital talipes equinovarus. And what are the questions they will ask you in CTEV? So the first one, what are the deformities? So what are the deformities? The deformities remembered in the name of cave. So what is C? C is for cavus, A is for adduction, V is for varus, E is for equinus, right? So cavus, adduction, varus, equinus. So these are the deformities. So this has been asked. So what are all the deformities which we see? And cavus, where you see cavus in the midfoot, increase in the arch. So whenever there is an increase in the arch, it is called as cavus, right? And adduction in the forefoot. So forefoot, the metatarsals are adducted, right? Varus in the hind foot. So calcaneum. So whenever they're talking about the varus, that is about the calcaneum or the hind foot. And equinus in the ankle because of the tendo-Achilles contracture. So why actually this is happening? This is happening because there is a soft tissue contractures on the posterior and the medial. So posterior and medial aspect, you will see there are soft tissue contractures, right? So that is what you have to remember. And now they will ask you when is the treatment. So treatment part, so treatment is what you do ASAP. So as soon as possible, even in the first week you will try it. And what is the technique which we use? We use the Ponseti's technique. So we use the Ponseti's technique, and again order of the correction of the deformity is again K. So this is the order of the deformity correction. So order of the deformity correction is again K. And weekly we change the cast. So which cast we are using? We are using the above knee cast. So weekly we change. So manipulate and casing. Yes, very good. The treatment is manipulation and casing. So that we change weekly. And once the correction is done, we go for splint. So this is the maintenance. So maintenance is by splint. What is the name of the splint? Yes. Name of the splint is DB splint. So what is the splint? Yes, this is called the Dennis Brown splint. So this is again an IBQ. And once the baby starts walking, what are the shoes we recommend? We go for 𝐒𝐻 shoes. We go for 𝐒𝐻 shoes. Not Von Rosen. This is Dennis Brown. Von Rosen is for DDH. Okay. 𝐒𝐻 shoes. There are three important characteristics of 𝐒𝐻 shoes, where the outer side is raised, no heel, and there is a straight inner border. So these are the, yes, no heel, inner border is straight and outer side is raised, right? So 𝐒𝐻, there are three specifications. Inner border is straight. So that is to accommodate the cavus, right? And then outer is raised. So again to overcome the adduction or the varus, and no heel for equinus, right? So these are the 𝐒𝐻 shoe specifications, right? And then if you're not happy with the treatment with this, then we go for surgical, that is PMSTR, that is posterior medial soft tissue release. So that is the surgical procedures. And then we have triple arthrodesis at the end. So this is finally, okay, if nothing is working, then we go for triple arthrodesis. The question here asked was, what are the joints fused? So one is the subtalar 𝐒𝐂𝐝𝐄 talonavicular. So because there are three options are there, the fourth one is the wrong options, right? So this is the and there are certain other procedures also, Dwyer's procedures, right? Dwyer-Evans procedure. So these are all where they increase the, yes, that is the, between this, we do what is called as the medial side lengthening and lateral side shortening. Okay, between these, between the posterior medial soft tissue release and triple arthrodesis, we have this thing. So usually what happens is cavus is like this, right? So this is the 𝐒𝐻 shoe. I mean, this is the 𝐒𝐻. Now what happens is, now you want to lengthen the medial side, shorten the lateral side, right? Wait. So this is the 𝐒𝐻. So here what we do, we may lengthen the medial side and shorten the lateral side. So those are all the procedures. So that is all the procedures. Dwyer's procedure, Evans procedure, all those are medial side lengthening and lateral side shortening. Yes, what is the scoring system which we use here is the Pirani scoring system to know between the rigid or supple 𝐒𝐻. So whether it is rigid 𝐒𝐻 or supple 𝐒𝐻. So there is a scoring system which is called as the Pirani scoring system. That is called the Pirani scoring system for evaluation, right? So this is mainly about the 𝐒𝐻. Most important thing, clinical questions they ask you is, what are the deformities? What is the treatment? What is the treatment? And then what are the IBQs? Dennis Brown splint and CTEV shoes. Okay. Okay. Now coming to the next thing. What is this? What is this? What you see on the X-ray? Yes, this is DDH. This is the DDH. So how do you identify that this is a DDH? So we are going to draw two lines. So one along the triradiate cartilage. So that is called as the triradiate cartilage. So this is your triradiate cartilage. And the second one is, and the second one here is H line. So first one we are drawing H line, that is called Hillingren's line, and the second line is called the P line, which is called as the Perkins line. So Perkins line on the lateral border of the acetabulum, like this. So now if you see the head, which is usually present normally on the, where it should be present normally, it should be present on the inferior. So this is the inferior and the inner, right? So whenever it is present in the outer and superior, so this is the DDH. So this is the DDH. So the two important lines, one is Hillingren's line, the second one is the P line, right? And then here DDH, how do you evaluate? So usually we evaluate during the newborn. What are the two important tests? One is the Otterloni and the second one is the Barlow's. So two important things, one is Otterloni and second one is the Barlow's. Otterloni and Barlow. So these are the screening tests which we do for the newborn. So whom do we do the screening test? We do the screening test for people who are at the risk. So the firstborn, breech presentation, like twins, and then if the patient is having any other problem during the antenatal stages where we can suspect the DDH. So we do two screening tests which is called as the Otterloni's and Barlow's, right? Otterloni's and Barlow. So these are the risk factors where there is a first breech presentation, female, twins, right? So these are the risk factors. And the two important lines, Hillingren's line and the Perkins line, right? And then on the ultrasound, we have two important alpha and beta angles. So these are the two important angles. And now if the patient comes to you below 6 months, right? If the patient comes to you below 6 months, so what is the treatment you give? So now we'll identify at the age of newborn only, right? We identify at the newborn level only, right? So once if the patient comes below 6 months, we give this. What is this called? What is this called? This is called as the Pavlik harness. So this is called as the Pavlik harness. So this is the splint. So this is called the abduction splint. Yeah, my kid. So this is called as the abduction splint, and now this is used for below age of 6 months for the DDH. And now what are the things which you have to remember in case of DDH? So first is Ali's test or the Galeazzi's test. So what is Ali's test or the Galeazzi's test? Yes. And whenever there is increased lumbar lordosis, so this was also a question which was asked whenever a patient comes with the DDH walking stage. So walking stage, you see there is an increased lumbar lordosis, and this is Ali's and the Galeazzi's test where you see the knee joint. So knee joint, you see there is the level of the knee joint is lower. So this is called the Ali's or the Galeazzi's test. Okay, and here for the months old babies, you can see there is an increase in the thigh fold. So there will be increase in the thigh fold. So these are certain things which you have to remember. So one is the Ali's or Galeazzi's test, increase in the thigh fold. And once they start walking, what you can see is there is an increase in the lumbar lordosis. And one more test, what you can see is the telescopy test is also positive. Telescopy test is positive. And what is the important test for hip abductors? So hip abductors are also weakened here. So what is the test for hip abductors? Yes? Treatment for hip abductors. I mean test name. It is? Yes guys? Test name for testing your hip abductors. Trendelenburg test, right? So that is your Trendelenburg test. Yes, yes. That's correct. That is your Trendelenburg test. So that is also positive in case of your DDH. So this is all as the age grows. As the age grows, if you test the patient, you will see that there is a telescopy positive, increased lumbar lordosis and hip abductus test. So this is how you diagnose the DDH, right? So once you have diagnosed, you have to come to the treatment part. So treatment part, we all know that whenever it is less than 6 months, it is Pavlik harness, directly we go for splint, right? But if the patient comes after 6 months, it is close reduction. So you have to reduce the head. So this head is somewhere outside, right? So you're going to put the head inside and now you're going to maintain it by hip spica. So what is a spica? Hip spica. So what is a spica? Spica is something where the limb is involved and then there is an involvement of the abdomen as well. So there is an abdomen. Casing is done for limb and abdomen, right? So that is called the spica. So whenever the patient is more than 6 months, what you do is you do close reduction with hip spica, right? And then if it is more than 18 months, 18 months is the age where the patient usually starts walking, right? So here what you do, there you go for open reduction and again you maintain with the hip spica. This is for up to 3 years. So 3 years is where the head is completely formed. So acetabulum and head are completely formed. So if it is after 3 years, then you go for osteotomies. Right? And finally, whenever the patient enters into the teenage, neglected, then you go for total hip replacement. So these are the treatments. 6 months, it is Pavlik harness. Then if it is 18 months, up to 18 months, you can go for hip spica. Then if it is 3 years, up to 3 years, you go for open reduction and hip spica. And then more than 3 years, you go for osteotomies. And finally, total hip replacement. So this is the treatment chart you have to remember for DDH. So I hope this is clear for DDH. So this is CTV for foot and ankle. This is DDH for the hip, right? And now coming to your Perthes disease. So what is a Perthes disease? Yes, guys. So what is a Perthes disease? Perthes disease is again a vascular abnormality. It is again a problem of vascular abnormality. It is usually seen in the age group of 4 to 8 years, right? 4 to 8 years. And males usually are prone, males more than females, right? Yes, this is nothing but avascular necrosis of the femoral head. So there is a problem in the blood supply, hence it results in femoral avascular necrosis, right? So that is called as Perthes disease. And how the patient presents with? Usually the patient presents with painless limp. So usually there will be limping, but pain is not that severe in case of Perthes disease. So painless limp, and on examination what you see is there is a restriction of adduction and internal rotation, right? So the adduction, internal rotation are restricted. So Perthes disease, usually it is seen in 4 to 8 years of age, and usually it is seen in the femoral head itself. Whereas it comes to TB hip is a joint involvement where there is an involvement of acetabulum and the femoral head as well. Right, and in TB hip you have certain CB-NAT, you have to test for CB-NAT, right? So this test is positive. So that is infection. This is a avascular necrosis. So usually in TB you will have painful TB, right? And here the pain is not there, but there is a restriction of adduction and internal rotation, right? Okay, and then what we have to do is treatment. So treatment here is again osteotomy. So treatment, how do? You do a containment surgery. So you do a containment surgery. What do you mean by containment surgery? Containment surgery is you try to put the head into the acetabulum. That's it. So trying to put, this is a self-limiting disease again. This is a self-limiting disease. So once you just put the head inside the acetabulum, it itself resolves. So that is called a self-limiting disease. That is the Perthes disease. So whenever they ask you about Perthes, they will tell you that there is only involvement of femoral head. Right, and then there will be usually it is seen in males, and there is restriction of the movements are present, and patient complains with the limp. Right, so this is about the Perthes disease. So this is about the Perthes disease, and now there are various things which you have to learn about other osteonecrosis. So these are some osteonecrosis. So other parts osteonecrosis. So whenever it is Kienbock's, key and lock. So Kienbock's is lunate, Panner's is capitulum, Sievers is calcaneum, Perthes is again femoral head. Mnemonics. So how I remember is key and lock, right? Lunate is L and this is Kienbock, right? Kienbock is lunate and Panner's is capitulum. It is like PAN card, right? Panner's is capitulum. Severs is usually what we prescribe for calcium is Shelcal, right? So Shelcal is the drug which we give. So that is the Severs. So S for calcaneum, right? And Perth is usually we already know that it is femoral head, and Kolar is navicular. So remember Virat Kohli, right? Kolar's is navicular. Virat Kohli, you can remember. Okay, and then Iceland's and Freeburg. So Iceland's and Freeburg usually there is no mnemonic for it. Just remember Iceland's is fifth. Both are metatarsals only. Base of fifth is Iceland's, similarly to your Jones, right? And Freeburg is second metatarsal head, right? Not much of useful, I think. Iceland's and Freeburg, I'm not pretty sure about the mnemonic, but the others, that is the way. Kolar's is navicular. Severs is calcaneum, Panus is capitulum, and Kienbock is lunate. Okay? So that is about your Perthes disease. Okay? So that is about your Perthes disease. So now we are going to fill up this tabular column. And now there are certain classification names. So the classification name is Ketteral's classification, right? So Ketteral's classification and head at risk sign. Head at risk sign. So whenever you see certain heads where there is a lateral involvement of the head, so that are certain signs which are called a head at risk signs, and there is a classification which is called as Ketteral's classification, right? So that is about your Perthes disease. Okay, and now coming to this. What is this? Yes, what is this? So this is your slipped capital femoral epiphysis. This is your SCIFI. So how do you know this is a SCIFI? So if you see, this is a normal epiphysis, right? So epiphysis is sitting nicely over the metaphysis like this. But here, if you see, there is a slip. So this is the slip I'm talking about. So here, what happens is the slip. So how did I know that there is a slip here? So help of this Kleene line. So what is this line called? This is called the Kleene line. So what is this line? Kleene line is mainly about drawing a line which is on the lateral aspect, the lateral aspect of the femoral neck. So whenever you draw this line, it should pierce or pass through the epiphysis, at least little bit of epiphysis. But here, whenever there is epiphysis, so if this is normal, and this see, there is a in the epiphysis, right? So here it will not pass through the epiphysis. So whenever it is not passing through the epiphysis, that means there is a slip of epiphysis, and this is called the Trethowens sign. This is called the Trethowens sign. Okay, so this is called the Kleene line, a line drawn on the femoral neck. So whenever you have draw a line, it passes through the epiphysis. So this is the epiphysis, normal one. So here you draw and epiphysis is not that much present. So there is a slip of that particular epiphysis. So this is called Kleene line, and this is called the Trethowens sign. And where we usually see the SCIFI is usually seen in males, and it is usually seen in adolescents, right? And what are the special characteristics? So these males, adolescents, or usually they suffer with endocrinopathies, so such as your diabetes mellitus, hypogonadism, right? And then they usually have obesity, right? And they will be complaining about pain, which is with trivial fall. Trivial fall is very minimal fall. So usually that doesn't result in a trauma. But this people, because of the endocrinopathies and obesity, this will result in fracture, which is type 1 Salter-Harris, right? We have discussed Salter-Harris type 1. So that is your SCIFI. So there is zone of hypertrophy which is weakest. From that weakest zone, there is a fracture which is called as the SCIFI, right? And because these patients usually complain pain in the knee. So there is a referred pain. This is also a catch. So sometimes they come only with the pain in the knee because of the referred pain. And usually whenever we examine the knee joint and we take the x-rays and MRI of the knee joint completely, it is normal. Completely is normal. So always in ortho, what you have to remember is you have to always check for one joint above and one joint below. So whenever you're checking for the knee joint, you should always check for the hip joint as well. So if that is there in your mind and you check the hip movements in these patients, what happens? Again, there is a decrease in the adduction and the internal rotation, and the limb is in abduction and external rotation. This is the attitude. So usually the limb is in external rotation. Remember, not exactly abduction, it is in the external rotation. So that is, you have to remember. So here there will be decrease in adduction and internal rotation. So the hip movements are decreased, and then the attitude is ER, that is external rotation, and then you go for an X-ray. X-ray, you will see that there is a slip, right? And then you know there is a Kleensland and Tretoven sign for your SCFE. And what is the treatment? So treatment, you go for pinning. And sometimes there is a slip in the opposite hip, which is called as a metachronous slip. So here we go for prophylactic pinning as well. If there is a so because this is a general condition, the patient again may land up with other side of the hip, right? So that is why we do prophylactic pinning. Prophylactic pinning is done. So the treatment is pinning here. That is about the SCFE. Is this clear? SCFE and Perthes? Yes, guys, SCFE and Perthes clear? So whenever there is a slip, it is called as metachronous slip. But in before that only we go for prophylactic pinning. That is, we do pinning in the opposite hip as well. So this is about your SCFE and this is about your Perthes. Yes. Yes, we are coming to the sports medicine now. Is that clear? All your doubts has been clarified? For SCFE, Perthes, TB, hip? Quicker? Yes, guys, I'm waiting for your reply. Yeah, in TB hip also there are various stages. So if they come in the stage 1, it is a synovitis stage where everything is difficult. When they come in stage 2, it is farther again. So flexion, adduction, internal rotation, that is the deformity which they present with. So that is the time where they have these difficulties. And when they come in the advanced stage, again the head is completely collapsed, the acetabulum is, has grown big, so they can do everything possible. It will go into like excessive of external rotation. So movements are excessive there. Okay, now let's enter into the sports medicine. So coming to the sports medicine, what is important here is, first we have 6 important structures. So this is everything about the knee joint, and they have cruciates, we have meniscus, and we have collaterals. That's it. This is the what you have to remember. So in cruciate we have 2 ACL and PCL. In meniscus, we have 2 medial meniscus and lateral meniscus. In collaterals, we have medial collateral ligament and lateral collateral ligament. So now what is the clinical diagnosis? So whenever it is cruciate, what the patient complains about is pain in the knee plus effusion. Okay, and severe pain. Okay, and whenever it is meniscus, the effusion is delayed little later. Again, there is pain in the knee. And collaterals, severe pain, no effusion, because this is outside the knee joint, right? So this is outside the knee joint, right? So this is about your sports medicine. So first one you have to do, these are the ACL, anterior cruciate ligament, and this is the PCL, and this is the meniscus, lateral meniscus and medial meniscus. So for medial meniscus. Medial meniscus, you know, this is the highly damaged structure because it is fixed, cannot move. So something which cannot move gets crushed here, and this is your collateral. So this is your collaterals, right? These are your collaterals. So what you have to remember in case of your sports medicine is, first they may ask you a theory question. So what is a theory? The patient has come with pain in the knee and there is a twisting injury. So whenever they talk about the twisting injury, it is mainly meniscus. And whenever they talk about extension, hyperextension injuries, it is mainly about the cruciates, right? So here it is mainly the valgus and the varus injuries. Okay, so that is how they tell you the question. And now whenever it is about the meniscus, this was asked, so what you do? Treatment of the meniscus. So you have to remember that meniscus, we can treat it or we can remove it. So there is removal and there is repair. But both are done through arthroscopy only. So both are done through arthroscopy only. So removal and repair. So when will you remove, when will you repair? So whenever you have to tell about the meniscus, you have to know that meniscus is divided into 3 regions. So the first one is called the red zone, and between is called the red-white zone, and finally it is the white zone. So why it is important? So this is highly vascular area. So whenever something is highly vascular, this is avascular, right? So white is avascular, red is vascular. So whenever something is avascular, then you go for removal. So white zone, if there is an injury, you go for removal of the meniscus, and red zone, if there is an injury, you go for repair of the meniscus. So this was asked in the exam. So this is the thing. So in case of meniscal damage, whenever the damage is present in the outer aspect, that is out red zone, you go for your repair, that is arthroscopic repair of the meniscus. Whenever it is in the white zone, you go for removal, right? So this is called the meniscectomy. This is called the meniscectomy. And here there is an injury which is happening. So this injury is again a twist or a hyperextension injury where there is a damage to the cruciate ligaments, right? Usually this is seen in football players, right? Football players, usually we see this, right? And this is what the confirmation of investigation of choice for ACL tear is MRI. So we see the MRI and the absence of ACL is considered as ACL tear. So this is the absence of ACL. So there is no ACL which is seen. So that is called as an absence of, investigation is MRI, and MRI you see absence of the ACL. So that is called the complete tear of the ACL, right? And then what are the tests? How do you confirm clinically? What is this? It is the anterior drawers test. So anterior drawers test, Latchman's test, and then we have the pivot shift test. So how do you remember these three? So pivot shift test, what we do, we only do under anesthesia, right? So we do under anesthesia. And this is the most specific, right? And anterior drawers test, usually we do at 90 degrees, and whenever the patient is in acute condition with the pain. So usually we can't do the ADT, right? We can't flex the knee. So that time we go for Latchman's, which is only 15 degrees of flexion. And here this is the most sensitive test. So these are the 3 important tests which you have to remember for ACL. So one is your ADT, anterior drawers, Latchman's, and pivot shift. And investigation of choice is MRI. You go for an MRI, right? And then coming to the rotator cuff. So that is about the knee joint. Some glitch I'm just trying to solve. Yeah. Yeah, dial test is for posterior lateral complex. That is called PLC. The posterior lateral complex is dial test. Not PCL, PLC. That is for dial test, where you have, the posterior cruciate ligament along with your other ligaments such as popliteus tendon and all those things which are present on the posterior lateral complex. Okay, so that is dial test for PLC. Okay, and now, so just complete this. So these are certain test names. This is the main important thing which you have to remember for the sports medicine. That is, this is the screen. This is the main thing, and I wish you all should be very clear with this. And this is the usually asked questions from the sports medicine. So test names are very, very important. So I have prepared a tabular form. You can write the names of it and then you can remember. So we already learned that anterior drawers, Latchmans and pivot shift is for ACL. We know that the Apley's grinding McMurray's is for your meniscus, right? And the valgus and the varus test is for LCL and MCL, right? So valgus and the varus. So we do valgus and the varus, that is for your collateral ligaments. And meniscus, and the meniscus is you go for Apley's, which is prone, and McMurray's test is for again internal rotation and external rotation. So this is the thing. And now coming to the shoulder. So once we have finished the knee joint, then we have the shoulder. So shoulder what we have is the rotator cuff. So what are the rotator cuff muscles? So rotator cuff muscles are again 4 muscles, the sit muscles, right? So supraspinatus, infraspinatus, right? Teres minor and subscapularis. So this is very, very important because these are also at risk. So whenever we are coming to supraspinatus, is mainly the action of this is abduction, right? So action of this is abduction. And infraspinatus and teres minor, it is external rotation, and subscapularis, it is internal rotation. So very easy. So again, the tests are based upon this only. So whenever you try to test the supraspinatus, it is abduction. So mt-can test, the Job's test is all suprakinetus. So you are going to do the mt-can and then you are going to abduct it. So that is supraspinatus. And then whenever you are unable to do it, so it is called as the drop arm sign. So you are unable to hold the limb in abduction, it is called as the drop arm sign. And then infraspinatus and teres minor is external rotation. So this is the external rotation. So whenever there is a lag in that, then you call for external rotation lag, which is infra and the teres minor. And subscapularis is internal rotation. So we have belly press test, right? And Gerber's lift off. So you are going to put your hand at the back and trying to lift the hand. So this is again internal rotation, and belly press is putting the 2 hands on the belly and going to press it inside like this. So again it is internal rotation. So that is your belly press test and your Gerber's lift off test. So these are the 2 important tests for subscapularis, and the mt-can test for supraspinatus you have to remember. And again, whenever there is a recurrent shoulder dislocation, so whenever there is a recurrent shoulder dislocation, so in case of recurrent shoulder dislocation, what happens is there are 2 important things which you have to remember. So one is called the Bankhart's lesion, the second one is called the Hill-Sachs lesion. So Bankhart's and Hill-Sachs. So nothing more to get confused here. Just remember Bankhart's is for labrum. So whenever you see the shoulder joint, it is again, this is the glenoid and this is the humeral head. So this glenoid has an extra cover. So this is the glenoid. So this is the glenoid I'm talking about. There is an extra covering to this glenoid which is called as the labrum. So there is a tear in this labrum because of recurrent shoulder dislocations, and this is mainly present in the anterior and the inferior area. So whenever you see anterior inferior area, there is a labrum defect. It is called as Bankhart's. And similarly, whenever there is some problem in the humerus, H for humerus, Hill-Sachs humerus. So humerus, where you see it is seen in the posterior lateral. So posterior and the lateral aspect, you see a defect which is called as the Hill-Sachs defect. So both are these conditions are treated arthroscopically. So shoulder arthroscopy is gaining popularity nowadays, and this has been treated with the arthroscopy. So wherever it is Bankhart's lesions or Hill-Sachs lesions, you have to think about the recurrent shoulder dislocation. Okay. What is AI? Right, guys? Yes. And now, just to refresh, these are some important PYQs which was asked in the previous exam. So what is the first one? This was given in the exam. What is this? The first one? So this is usually done in pediatric cases. Okay, so this was the anterior inferior dislocation. No, recurrent shoulder. Yeah, anterior dislocation only. In case of anterior shoulder dislocation only, you will have anterior inferior tear of the labrum. Yes. Okay, this is intraosseous infusion. This is just an IBQ. And what is this? This is pelvic binder. So this was also asked in the exam. So patient has come with this one, so pelvic injury. So you can see there is a lot of yes, last year question, intraosseous infusion, and pelvic binder, it was also asked. Yeah, bony Bankert's is what? Bony Bankert's is a condition where instead of labrum, a small chip of bone is also avulsed. So small chip of bone is also avulsed. Right? So in labrum plus bone, that is called as bony Bankert's. Okay? Clear? Yeah, this is called the pelvic binder. So this is your pelvic binder. So what is this pelvic binder? Whenever a patient is having pelvic fracture, so this patient is at risk of developing shock because important vessels which are present there. So you go for pelvic binder which is available, or you go for using of the bed sheets which are there in the casualty, and you tie at this level of greater trochanter. At the level of greater trochanter, right? This is what you have to remember. At the level of greater trochanter, you're going to tie. So that is the pelvic binder. And what is this? Yes, tie on the pelvis at the level of greater trochanter. That is what I said. And what is this? Yes, faster. So this is the VAC. This is vacuum assisted closure. So whenever you have, yeah, DEXA for compartment. No, this is vacuum, VAC. This is VAC. So you will have a formation of, if there is an infected wound. Infected wound, yes, it is VAC. So infected wound, you can use this vacuum assisted closure. So here what happens is there will be formation of granulation tissue. So granulation tissue bed is formed. So this was also asked in the exam. So that is VAC, vacuum assisted closure, and this is intraosseous infusion, and this is your pelvic binder. These are the important IBQs. And then the implants and instruments have been asked. So what are these? These are the prosthesis. So what is the prosthesis? Whenever you replace a part of the anatomical part, so that is called as your prosthesis. So there are two important prostheses. So this is called your Moore's, and this is called your Thompson's. But we are not using these two, we are shifting towards the bipolar prosthesis. Okay, how do I identify both these? Austin Moore's, there are two holes here. So this is your Austin Moore's, and Thompson, there is a collar. So this is the collar which I would. So this is your Thompson's, right? So this is for hemiarthroplasty. Hemiarthroplasty is replacement of the head. So whenever you replace the head, that is called as the prosthesis. So hemiarthroplasty is the surgery which we do. Yeah, hip replacement, total hip replacement is again where you replace the acetabulum as well. And what is this instrument? This is a osteotome, sharp edge, right? Both you can see curved or straight. Useful for, yes, breaking the bone, right? So for bone grafting, osteoclasis, we use this bone grafting and osteoclasis, right? So that is your osteotome. Yes, and this is your prosthesis. And a few instruments and implants. So what is the treatment of IT fracture? So treatment of IT fracture is very, very important. So whenever there is an IT fracture, because the head is not involved, it is the intertrochanteric fracture, the treatment is either DHS or PFN, right? So this is the DHS. So this is the DHS and this is the PFN, right? So that is a treatment for your intertrochanteric fracture. And whenever there is a patella fracture and especially your transverse patella fracture, the treatment is tension band wiring. Okay, so the principle here is converting the distraction forces into compression forces, right? So that is the TBW. And where all you can use TBW, you can use in case of the medial malleolus as well. So wherever the tendons are present, so olecranon and greater trochanter, and sometimes even in the greater tuberosity. So these are the areas where you can use your tension band wiring. So DHS and PFN, please remember this was asked in the exam. And treatment of IC fracture. So treatment of IC fracture is your hemiarthroplasty. So this is your hemiarthroplasty, IC fracture. So again, IC fracture, remember, if there is a young individual of less than 40 years, you go for CC screws. Okay. And if it is more than 60, you go for hemi. This was also been asked in the exam. So this is the IC fracture. This is the IT fracture, PFN and DHS. And this was asked in the exam, that is TBW, tension band wiring. And what is this? What is this? This is your BB splint, right? So this is your Bowler's-Brown splint. This was also asked in the exam. It was asked in the FMGE. So Bowler's-Brown splint is mainly, yes, it is used for your skeletal traction. Yes, very good. It is used for skeletal traction. So what they do, they put the limb here like this. So this is the limb. And for this, what you have to use is this is the knee joint and this is the tibia. So they will put the pin, which is the Dunham's pin or the Steeman's pin. And then they will add a weight to it. So this weight, they will hang like this. Okay. So for the stirrup, so you need a pin, stirrup, and a BB splint. So all these things you need for BB splint apparatus. So this is for your skeletal traction. And what is this? This is your Thomas splint. Thomas splint is again for your immobilization, right? So what are the things you have to remember? There are one ring and two bars. So this is a ring and this is a bar. So inner bar makes an angle of 120. Outer bar has a curve for accommodating the greater trochanter, and those two are connected by W-shaped notch. So that is your Thomas splint. This is your BB splint, and this is your tension band wiring for the treatment of the patella. And IT fracture treatment is DHS. This is dynamic hip screw. DHS is dynamic hip screw. So you can see one screw in the hip head, femoral head, right? And then there are PFN, that is proximal femoral layering. So there is a nail and this is a plate. DHS is a plate and this is proximal femoral nail. So this is the treatment of IT fracture, right? Yes. Now these are certain orthotics. So orthotics mainly used for scoliosis. So these are the scoliosis which we use. So the first one is called the Milwaukee brace cervical, and this is the Boston for lumbar. Right, this is Milwaukee, this is Boston, and most important thing they ask you is this Taylor's brace. Taylor's brace is again for DL spine and mainly used for your tuberculosis and fracture spine. Okay, these are IBQs, Milwaukee and Boston's brace, and this is your Taylor's brace. And coming to the nerve injuries, what is this? This is an Erb's palsy. Right, Erb's palsy is mainly seen in the pediatrics, right, newborn. So this is a condition of brachial plexus injury, and usually the upper trunk is involved where there is an involvement of deltoid, right, and musculocutaneous nerve, right? I mean, not the deltoid, the axillary. So axillary and the musculocutaneous. So axillary nerve supplies the deltoid and the teres minor. Musculocutaneous supplies the flexors and the supinators. So as these are damaged, the deformity what we see is here, we see here adduction, right? Internal rotation, like extension of elbow with the pronation. Okay, so why is this deformity actually happening? This is because, what is the meaning of orthotics? Orthotics is which supports the body part. So for example, you are having a foot drop and now you are using a foot drop splint. So this splint is called an orthotic, right? So this is called as an orthotic, okay, which supports the body part. And this brachial plexus, you have to remember that this upper trunk is damaged. This upper trunk has the involvement of axillary and the musculocutaneous, and this axillary supplies the deltoid and the teres minor. So what is the action of deltoid? It is abduction. So here the deformity we see is adduction. And then teres minor is external rotation. Here the deformity we see is internal rotation. And musculocutaneous, this applies flexors and supinators. So here what you are seeing, extension of the elbow with pronation. So this is called as the policeman tip deformity or waiter's deformity. Okay, so that is about your Erb's palsy. And sometimes Klumpke's palsies. Klumpke's is lower trunk. Okay, lower trunk mainly involvement of C8 and T1. So that is your ulnar nerve. So what you see? You see the claw hand. So that is the two important brachial plexus injury. One is your Erb's palsy. The second one is Klumpke's palsy. Okay, and what is this? So this is your claw hand. So this has been asked in the exam. Claw hand, mainly involvement of the ulnar nerve. This is just an IBQ. Okay, now talking about the three important nerves. Yeah, Klumpke's, you can also see the Horner's syndrome. So yes, this is associated with the Horner's syndrome as well. So in the three important nerves, the median nerve, the ulnar nerve, and the radial nerve. So coming to the median nerve, you know, it supplies the flexors, right? Except, so flexor carpi ulnaris and half of FTP, which is supplied by the ulnar nerve, right? And then it supplies the thenar, again except adductor pollicis, which is supplied by your ulnar nerve, right? And radial nerve, it supplies all the extensors. And your ulnar nerve supplies the hypothenar and your palmar interossei, dorsal interossei, and the lumbricals 3 and 4. Here it supplies the lumbricals 1 and 2. Okay, so you know the answers. So this is called as the ape thumb deformity, right? And what is this? This is called the pen test, right? Again, opponent's pollicis, which is testing. That is, ape thumb deformity is your thumb is gone in line with your four fingers. That is your ape thumb deformity. And then this is your benediction sign. And this is your pointing index. So again, because of loss of flexors. And whenever there is AIN involved, this is called OK sign or O sign or 𝐒𝐿 sign. Yes, hand of benediction might get connected. What is that? And here we have card test and book test. Okay, and book test for adductor pollicis, right? And whenever you use flexor, that is called as the Fromen's sign. Clear? And card test for your palmar interossei, right? And this is your knuckle blender splint. Knuckle blender splint for your ulnar nerve palsy, right? And now coming to the radial nerve. This is your Saturday night palsy. And this is your Holstein-Lewis fracture. We have already discussed about this. So whenever there is a Saturday night palsy or Holstein-Lewis fracture, what happens is there is a neuropraxia which will result in wrist drop. So this is the outcome. So this is the wrist drop, and the treatment of the wrist drop is your cock-up splint. So cock-up splint, there are two types of cock-up splint. So one is your static, the second one is your dynamic. Right, so dynamic, we have springs attached to it, so hence there is a movement in the finger, so that is called dynamic. And then the static is just holding the position, right? So that is your cock-up splint. Okay, yes. And coming to the infections, we have very, very important acute osteomyelitis, chronic osteomyelitis, and then we have septic arthritis. So very important. Clinically, they'll ask you, coming to the acute, it is less than 2 weeks, sudden, right, fever, pain, raised ESR, raised CRP, raised WBC, right? X-ray, usually there are no changes, which is seen. Whereas in chronic, more than 2 weeks, intermittent, there is a pain and fever, discharge which is present, and that discharge is white spicules, right? On the X-ray, you see what is called as sequestrum, right? So here, what is the treatment? Antibiotics, rest. Okay, here surgical. So you have to remove the sequestrum, which is called as sequestrectomy, right? So this is the X-ray where you see sequestrum. What is a sequestrum? It is a dense sclerotic bone, right? And surrounded by granulation tissue, that is lucency. Lucency, that is your granulation tissue. Okay, I'm going a little bit fast because we are running short of time. So don't think that I'm just rushing. So finally, septic arthritis. So septic arthritis is mainly for the joints and usually seen in children. They come with severe pain, fever, pseudo paralysis, where the patient will not allow you to touch, right? Pseudo paralysis, and the movements are lost. Joint movements are lost, right? So you go for an MRI where you identify the septic arthritis, and then your treatment is joint wash. So you open the joint and you clean the whatever thing is present here. That is joint wash. Okay, so that is about septic arthritis, acute and chronic osteomyelitis. Anything you want me to add, or any doubts? Yes, yes. Now your favorite, TB. So tuberculosis, this was the MRI which was asked. Tuberculosis, Pott's spine. So involvement of spine in TB is called Pott's spine. So usually DL spine, which is most commonly involved. Patient complains with night cries. Okay, and involvement of 1, 2, 3, 1 vertebra, this is called as knuckle, 2 vertebra gibbous, 3 vertebra kyphosis. Okay, so that is how investigation of choice is MRI. And on X-ray, you see bird nest appearance of the pus. And the treatment, you have to remember, that is the middle path regime. That means we treat with conservative management, right? So we treat with the conservative management, right? So that is the TB spine. Investigation of choices MRI, and patient usually complains with the mild fever, loss of weight, and loss of appetite. Loss of weight and loss of appetite is usually seen in case of tuberculosis. And next comes TB hip. I have told you TB hip and TB knee, there are 4 stages. So first is stage of synovitis, stage of early arthritis, late arthritis, advanced arthritis. So how do you know the difference? So in stage of synovitis, the patient comes with Faber. So there is an effusion in the joint and there is a flexion abduction position. And here they goes into Fadir. So this is an early arthritis. And this is also Fadir. And finally, this is the advanced where there is a dislocation or subluxations. So here there are two important X-ray findings which you have to remember. So one is the wandering acetabulum and next is the motor and pestle appearance. So these two are seen in TB hip. And investigation of choice, they have asked CB-NAT. Okay, the bacteria is Mycobacterium tuberculosis. CB-NAT is the investigation which is used in identifying your TB. Okay. Yes, clear, everybody? And coming to the TB knee, what you have to remember is just remember triple deformity of the knee. So there is a flexion of the knee, there is abduction and external rotation. This is for the knee, right? So such triple deformity is usually seen in other conditions, remember, as triple itself. So tuberculosis, rheumatoid arthritis, tiliotibial contracture, polio, and then your hemophilia. So these two combined, it is hemophilia. So you have to remember that triple deformity is seen in so and so condition. So what is triple deformity? So there is a triple deformity of the knee where you see there is a flexion of the knee and there is a adduction, that is inward movement, and internal rotation. Sorry, I've written it reverse. So flexion of the knee, adduction, and internal rotation of the knee. Okay? Yes? So you have to be very sure that this triple deformity is usually seen in the tuberculosis and then your rheumatoid arthritis as well. So these two are very, very important. Polio is usually eradicated now, but it was seen in polio and IT band contractures. Okay, so these are the conditions where we usually see the triple deformity of the knee. And what is a triple deformity? It is flexion of the knee, adduction, and internal rotation. Okay? Yes, clear? Yes, coming to the spine part. So what is this? So coming to the spine part. So this is called the shopping cart sign. What is the shopping cart sign? Which is seen in the lumbar canal stenosis, right? Lumbar canal stenosis. So there is a lumbar canal which is present, all the nerves pass through it, and whenever there is a stenosis, that means the canal has been narrowed. So there is a narrowing of the canal. So because of the narrowing of the canal, what happens is the patient will have pain on extension. So they will, whenever we extend the spine, there is a pain, and pain relieved on flexion. Pain is relieved on flexion. So this flexion relief of the pain is usually seen in case of your shopping cart. So whenever you push the shopping cart, you slightly flex the spine, right? So that is the shopping cart sign seen in your lumbar canal stenosis. Yes, guys, you're present, everybody? You're following? Comment. Okay, good. Yes, okay, thank you. And what is this? This is straight leg raising test. So when is this used? This is straight leg raising test. If you see, the surgeon is lifting the leg, which is straight. That is, the knee is extended. So there is no flexion of the knee, and straightly we are lifting the leg, which is usually seen in prolapse intervertebral disc. That is PIVD. So this test is mainly used in identifying the prolapse intervertebral disc disease. And here what we do, if it is less than 60 degrees, it is confirmation. Okay, so we will tell the patient that we are going to lift the limb, and whenever we are trying to lift the limb and the angle is less than 60, patient is having pain, that means he is suffering from PIVD. And now we confirm it by Alekhya's test. What is Alekhya's test? So now what we do, we lift the limb, that is straight leg raising test, and then we do sudden flexion of the ankle. So this will again reproduce the pain. So that is the Alekhya's test. Yeah, I have. So that is the Alekhya's test. So this is SLRT and that is your shopping cart sign. So these are two important things which are usually used in your spine. And what is this? This is again a previous year question. This is a Cobb's angle. So what is this? This is Cobb's angle. So how do you draw this? You identify the scoliosis curve and you identify the apex vertebra. So this is the apex vertebra. This is the apex vertebra. And now you draw a line along the superior end plate, this along the inferior end plate. And then you draw perpendiculars along this. So this is called as the Cobb's line, Cobb's angle. And here if it is less than 20 degrees, what we do, we use the conservative technique. So scoliosis we conservatively treat it. So if it is 20 to 40 degrees, we go for orthotics. So orthotics, what are the two orthotics which we use? The Milwaukee and the Boston sprays. And if it is more than 40 degrees, we go for surgical treatment, right? So that is the importance of your Cobb's angle, and this is mainly used in your scoliosis. So this is the Cobb's angle and used in your scoliosis. Clear? Yes. Now comes the joint. So joint inflammation, we have two. One is your rheumatoid arthritis, then second one is your degeneration. So coming to the rheumatoid, and this is your osteoarthritis. So now, so just pay little attention, okay? Rheumatoid arthritis is usually seen in young individuals, females. It is a type of autoimmune disorder where there is an involvement of your joints, especially your hand and the wrist joints, right? Okay, and osteoarthritis is usually seen in elderly, right? It is a wear and tear mechanism. So here both the ends, the cartilage is damaged. So to have your osteoarthritis or rheumatoid arthritis, cartilage damage is there. But here the cartilage damage is through wear and tear mechanism. So usually it is the medial meniscus which is damaged. So weight bearing area is the medial side, right? So that is the damage. So hence it will result in varus deformity. So here there's a formation of pannus. So here the cartilage, there is a lot of inflammation that is occurring in the joint and this will damage the cartilage. Here it is bilateral. So it will result in varus or valgus. Okay, here there is an involvement of DIP, PIP, no MCP, no wrist. Here it is DIP, here it is more of MCP and PIP, wrist. So both it is knee is common in both knee and hip. Okay. So this is your involvement of your rheumatoid and the osteoarthritis. So what you have to remember is in case of your rheumatoid, the X-ray findings. So X-ray findings, it is usually bilateral, symmetrical, right? And what is the main important thing in rheumatoid? Bilateral, symmetrical, and it is periarticular erosions, right? It is periarticular erosions. Right, and here in the osteoarthritis, what mainly we see is medial compartment is mainly involved, and you will see osteophytes. So decreased joint space is seen in both sides. So decreased joint space, decreased joint space. So here what is main thing? The main thing here is osteophytes, the presence of osteophytes, and these may present as loose bodies. And here we see the periarticular erosion. So we see the periarticular erosions in case of your. So usually here patient complains about morning stiffness here at the end of the day. Is this clear? Rheumatoid and your osteoarthritis, somebody was asking. Shivani, I think. Shivani was asking about what is the difference between rheumatoid and osteo. So after learning so much things, what they usually ask in the exam is two deformities. So one is Bottignius swan neck. So first let us understand what is swan neck deformity. because it is a little bit easy. So swan neck is this. So swan neck is what is happening here. Whenever there is involvement of DIP, it goes into flexion, and PIP is going into extension, right? So this is about your swan neck deformity, and exactly opposite is your hypotenuse. And in case of your degenerative, that is osteoarthritis, there are certain nodes which you have to remember, that is BP, HD. HD is Herberdens node in DIP, and BP is your Bouchard's nodes in PIP. Is that clear? So this is about your joints. Yes, correct. DIP flexion and PIP extension. Okay. So osteoarthritis, now the treatment is joint preservatives. So here the treatment is DMR days. So this they will discuss in pharmacology, but both of them, they are treated with total knee replacement. Okay. Yes. Now coming to this, your very important ankylosing spondylitis. So usually seen in young patient, male, HLA-B27 positive, right? And now complaints of back pain, SI joint involvement, and then you have other systems, that is enthesitis, where there will be heel pain. Don't forget, they will have also other problems, heel pain, pulmonary problems, cardiac, and uveitis, that is eye. So not to forget all these things, okay? Yes, Schober's test is for your ankylosing spondylitis, okay, the decreased flexion. Okay, and these are the things which they will ask you in the exam. And now they will give you IBQ. One is your dagger sign. So ossification of your PLL will result as a dagger sign. And then the second one is your bamboo spine. So dagger sign and the bamboo spine. So these two are important things which you have to remember in. Please ask questions. Yeah, I'm asking. Okay, what is the complaint of these people with ankylosing spondylitis? What they present with? Yes. Yes, they present because this is also an inflammatory disorder, right? Yes, inflammatory, and they will have morning stiffness. Back pain, especially in the morning. So because pain decreases on activity. Yes, that is again a sign of inflammation. So inflammation is whenever you rest, you will have pain, and the pain decreases on activity. Yes, that is the main thing of symptom or your... why is the bamboo spine occurring? What are the osteophytes called here? These osteophytes, they are called as syndesmophytes. So they are called syndesmophytes, where they cause fusion of the vertebra. So this fusion of the vertebra will result in the bamboo spine. Okay, so that is your ankylosing spondylitis. And then what is this? Yes, quick. Yeah, spine osteophytes. When bone, you in vertebral bodies, you will have osteophytes. Those are called syndesmophytes, bony osteophytes. What is this? Yeah, this is a codfish and seen in... So this is again imaged base codfish vertebrae, where you can also see a wedge fracture as well. Yes, this is seen in your osteoporosis. Yes, very good. What is osteoporosis? So there is a decrease in the bone mineral density. And what are the important things you have to remember? All the biochemical markers are... Yes, are they normal or abnormal? All the biochemical markers are normal or abnormal? Quick. They are normal. So whenever you take, yes, whenever you take calcium, phosphorus, alkaline phosphatase, vitamin D, everything is normal. But what happens here? There is a decreased bone mineral density. So this is a quality which is defective. Right now the quantity, the quality which is defective. And osteoporosis, what the question in INI-CET they have asked is FRAX. What is FRAX? FRAX is fracture risk assessment. Okay, so these are a set of questionnaire where we have, which is developed by UK people. So this is the questionnaire, and now what happens is they will predict the fracture. So they will predict the fractures by this. So this is the fracs. Okay, so that is what they have asked you. And here this osteoporosis is mainly seen in your distal radii, such as Colles fracture, and then it is seen in the spine, right? And then your femoral neck. So these are the areas which you have to look for your osteoporosis, right? And what is the important investigations we use in your osteoporosis? It is your, yes, quick. Yes, it is your which scan, or which, what is the test? It is your DEXA scan, right? So DEXA scan is the one, yes, DEXA scan is the one which is used for, identifying your osteoporosis. If it is less than 2.5, it is called as the osteoporosis. Okay, and what is the treatment for osteoporosis? Bisphosphonates. Okay, bisphosphonates are the treatment, usually first line treatment, which is given for your osteoporosis. So the codfish vertebra is usually seen, and what is the thing here? We see there is a decreased bone mineral density. So that is about your osteoporosis. And then what is this? What is this? Quicker. Yeah. That depends upon the severity of the osteoporosis. We can just not tell it is 10 years or 12 years. Yes, it is Ruger-Jersey spine. So this Ruger-Jersey spine, it is usually seen in which condition? Yeah, it is seen in osteopetrosis. It is seen in hyperparathyroidism as well. Okay. What is hypoparathyroidism? There is an increase in the parath hormone, right? What is osteopetrosis? There is a defective osteoclast resorption, right? Defective osteoclast resorption. Okay, Ruger-Jersey spine is seen in both the condition. So one is your osteoclast defect, that is resorption is problem, that is osteopetrosis, and hyperparathyroidism, where there is an increase in the PTH, right? And then what is this? This is a picture frame vertebrae, right? And this is your ivory vertebrae. So seen in which condition? Yes, picture frame vertebrae and ivory vertebrae seen in which condition? Yes. Seen in your Paget's disease, right? Seen in your Paget's disease. So what is a Paget's disease? Again, there is a problem in the resorption. So there are phases in this. So there is, because of the parvovirus or because of genetic mutation, the patient will have problem in the resorption. So the bone is not resorpting properly. And here, because of the increased sclerosis, the patient might land up with deafness, lumbar canal stenosis, right? So they can present with these conditions also. So this is a Paget's disease. So usually these are IBQ. So they will put up this X-ray and they will ask you which condition is this. Yeah, yes, it is in the skull. So cotton wool spots is seen in the skull. That is again Paget's disease. Causes of back pain in pregnant ladies. The first one is physiological pain, usually because of the ligament stretch. And then what is this? So we have loser's zone. And then we have protrusio acetabuli. So what are these two conditions representing which condition? Yeah, cranial nerve compressions are also seen because of the sclerosis in Paget's disease. So loser's zone, protrusio, these two are seen in a condition which is called as osteomalacia. So osteomalacia, what is the problem? There is a decrease in vitamin D, hence there is a decrease in the calcium as well, and this is usually seen in the adult. So what we see is the loser's zone, and this is called as the protrusio acetabuli. So you can see that the head is protruding through the acetabulum. So this is called the protrusio acetabuli, and loser's zone is the fractures, multiple pseudo fractures which we see. Okay, so that is in case of your osteomalacia. Then what is this? This is your Brown's tumor. Yes, in which condition we see this Brown's tumor? Quicker. Yes, faster. We are done. Only 15 minutes. Quick, quick. Keep answering. What is this Brown's tumor seen in which condition? Yes, very good. It is seen in hyperparathyroidism. Very good. And what is the thing in hyperparathyroidism? You all know that there is an increase in the parathyroid hormone, because parathyroid likes calcium, so there will be increase in the calcium. But this increase in the calcium is mainly from the bones, right? So it will cause increase in the resorption of the bones. So this resorption is seen in the fingers, especially on the radial side. And there is a soft tissue which is seen as the brown tumor. So this is a soft tissue seen in the bone. It is called as the osteitis fibrosa cystica, right? Osteitis fibrosa cystica. So that is your, yeah, subperiosteal resorption. So this is the increase in the resorption mainly in the subperiosteal, mainly in the phalanges. So this is in the fingers, mainly on the radial side. And then, yeah, this is a soft tissue seen in the, this is called the Brown's tumor. So this you have to be careful with your ABC, that is your aneurysmal bone cyst. Okay. No, osteoma is different. Now coming to soft tissue disorders. I think this you all know. What is this? What condition is this? This is tennis elbow. And tennis elbow, this is mainly that test is your Cosen's test, right? Cosen's test. Yes, it is Cosen's test seen in tennis elbow, on which tendon is targeted here, extensor carpi radialis brevis. Yes, tennis elbow and the Cosen's test. What we do is we do extension of the wrist. So it is the lateral epicondyle, right? It is the lateral epicondylitis. So what happens in lateral epicondyle? There is a chief extensor origin, right? It is a CEO. So here, because of the extensors, we directly do the extension. So whenever we do extension of the wrist under stress, so a patient will have pain in the lateral epicondyle. So this is called as the Cosen's test. Okay, that tendon which we target here for the treatment is extensor carpi radialis brevis, right? And then what is this? This is first extensor compartment involvement. So what are the two tendons? APL and EPB. Right? Yes, ERCB. Very good. APL and EBB. What is the test here? What test we are using here? What is the test name? Quick. It is 𝐒𝐿-Curvain's tenosynovitis, right? It is 𝐒𝐿-Curvain's tenosynovitis. Where, how do we do that? We flex this thumb inside and then we form a fist and then we try to extend the wrist like this. So this extension will cause the stretching of the tenosynovium of these two tendons. So these tendons, no phalanx, this is 𝐒𝐿-Curvain's tenosynovitis. Okay, for the APL and EPB. Okay, first compartment extensor. So extensors, you remember there are 6 compartments. The first compartment is APL and EPB. Yes, correct. It is 𝐒𝐿-Curvain's tenosynovitis. Yes, then what is this? This is Dupuytren's contracture. What is Dupuytren's contracture? It is nothing but the palmar fascia, involvement of the palmar fascia. This is again could be a genetics. So palmar fascia gets contracted and it will result in a cord-like structure. So usually seen in patients with alcohol, diabetes, right? And the middle finger is usually affected, middle and the ring finger. So that is your Dupuytren's contracture. So this is the cord-like structure in the palmar fascia. And similarly in the penis we have Peyronie's fascia. There is also contraction of that condition. Okay. Yes, and liver cirrhosis as well. Yes, very good. Liver cirrhosis. Very good. And what is this? This is called the trigger finger. This is called the trigger finger. So what is the triggering here? So here what happens is the pulley. the pulley becomes narrow. So this is the A1 pulley which we are talking about. So there are A1, A2, A3, C1, C2 pulleys in the hand, and this tendon will pass through the pulley like this. So if this is a pulley, the tendon pass through it for flexion of the fingers. So whenever there is some stenosis in the pulley, the tendon can't pass through it. So there is a nodule here, if you can see. So because of the nodule or because of the inflammation of the tendon, so there is a problem in the passage of the tendon through that pulley. So this is called a trigger. So whenever you try to extend the finger like this, so you will have a snapping sound. So this is done with the snapping sound. So this is called your trigger finger, right? Yes. Last and most important topic. This is last topic because I thought maybe radiology you will learn it more. But just a quick review. So for all those who want tumors also to be included here. So what is the first one? Osteochondroma, right? So osteochondroma is also called as exostosis. Okay, multiple exostosis is called diaphyseal achalasia. Okay, diaphyseal achalasia. Say osteochondroma multiple. So what is the most important thing that you have to see in the exam? So first thing is the cortex and the marrow. Both are continuous. So this is the word you have to search for. So the cortex and marrow continuous, right? So this is the clue. And now against the joint. So that is about your osteochondroma, right? Multiple exostosis is diaphyseal achalasia. Multiple enchondromatosis is Maffucci's syndrome, Sailesh. Get it right, okay? And what is this? Yes, somebody was asking about this. This is called the osteoid osteoma. This is called the osteoid osteoma, right? So in osteoid osteoma, what is this? It is the formation of the bone here. So here there will be a lesion which is less than 2 centimeters. And because this is the cortex involvement, so the investigation of choice in osteoid osteoma is CT scan. So on the X-ray, you can only see that there is an increase in the periosteal reaction. So this is what usually they keep the X-ray and you can't find anything in that. So here what you have to do when the patient is complaining about pain, and what is the most important thing? NSAIDs. They will tell you that relieved night pains and relieved by aspirin, that is NSAID. Okay, so this is the thing which you have to look for. Night pains relieved by NSAIDs, and then they will ask you what is the investigation of choice. The investigation becomes CT scan and you have to look for the lesion inside it. Okay, and then what is this? This is fibrous dysplasia. So this is a fibrous dysplasia. So Shepherd-Crook deformity, right? Yeah, inside usually we concentrate on the lysis. Okay, lysis surrounded by sclerosis, but what we are main concentrating is about the lytic lesion in the center. So this is Shepherd-Crook deformity, and what is the important syndrome? This is the McCune-Albright syndrome. So this was asked again. So McCune-Albright syndrome is multiple fibrous dysplasia, polyostotic, precocious puberty. Yes, and what is the third one? Yeah. What is the third one? Polyostotic, precocious puberty, and cafe lid spots. Okay, pigmentation. Yes. Yes, Chinese pattern is seen on the biopsy. So fibrous dysplasia is nothing but the cortex and the marrow is completely replaced by your fibrous tissue. And this is Chinese pattern which is seen on the biopsy. Chinese letter pattern. Okay. Yes. Yeah. And what is this? So this is a simple bone cyst. So simple bone cyst, what are the two conditions? So it might result in a pathological fracture. So what is the sign? Pathological fracture, X-ray finding. Yes. Not ABC. This is SBC, simple bone cyst or unicameral bone cyst, not ABC. X-ray you find fallen leaf sign. So how do you differentiate between your ABC and SBC? So here simple bone cyst, you see the width of the cyst is in line with your cortex. But when you see ABC, you see this is aggressive. That means the cortex is only this much. It has increased. So this is expansile and this is aggressive. So this is expansile and this is aggressive. And usually it is seen in the metaphysis. But similarly, the expansile and aggressive, if you see in the epiphysis, that means it is GCT. Right? Again, if you see, this is the length of the cortex and this is the length of the cortex. So this is SBC, where the cyst formation is within the limits of the bone. Okay, and ABC and GCT are the conditions where you see there is an expansive and aggressive tumors. So this you have to go for an MRI where you see multiple fluid levels. So you see multiple fluid levels, right? And in epiphysis, this is GCT. You see that there is a soap bubble appearance on the X-ray. Right, so there is a soap bubble appearance on the X-ray and it is epiphysis and usually seen in the adults. That is after the closure of the physis. So there is a closure of the physis, then you see the development of the GCT. Right, and what is this? Lesions in hands and feet. So small lesions in hands and feet, this is called as osteoclastoma is giant cell tumor. Yes. What is this? Lesions in hands and feet. Yes, very good. This is enchondroma. And multiple enchondromatosis is Olliers disease, right? Multiple enchondromatosis with cutaneous hemangioma is Maffucci's. Just multiple enchondromatosis is Olliers. Multiple enchondromatosis plus cutaneous hemangiomas. Very good. That is Maffucci's. Very good. Okay, so that is how you differentiate between SBC, so fallen leaf sign or trapdoor sign, which we usually see in simple bone cyst, and aneurysmal bone cyst, that is MRI, we go for multiple fluid levels. So these are the multiple fluid levels which we see. And GCT is seen in the epiphysis, and the treatment of the GCT, they will ask you, the treatment is extended curettage. So extended curettage is nothing but they will take entire scraping of the cavity. So this is the cavity, they will use the curettage. So curettage is something like this, they'll scrape and then they will put bone cement or liquid nitrogen in it, right? Fallen leaf sign is seen in the SBC. Fallen leaf sign is nothing but this is the SBC, simple bone cyst, and whenever there is a pathological fracture, the bone falls into this cavity, and this is called as the fallen leaf sign. So small amount of bone piece which is there, it is seen there. Okay. So that is your fallen leaf sign. You want to tell about the rind sign? It is not the dead bone, it is the pathologic, the part of the small bone. We can't tell it is dead completely. It is a fractured bone. It is not a normal bone, it's a pathological bone. Rind sign is something which is, which is seen as a lytic surrounded by sclerosis. It is mainly seen in your fibrous dysplasia. So this rind sign is mainly seen in your fibrous dysplasia, okay? And then we have most malignant forms. So what is the malignant here? So this is what? What is teardrop sign? Yes, this is Ewing's sarcoma. So how do you see that Ewing sarcoma? Ewing sarcoma is, you can see hair on end appearance, the first image, or you can see onion peel appearance. But what you have to remember about this is it is similarly to that of your infections. So here, whenever we talk about Ewing sarcoma, the patient will come with fever, raised ESR, raised CRP. Okay, and then they will have fever. So we get confused between the infection and the tumor. So hence biopsy you have to send, and what you see on the biopsy, small rounded blue cells, right? Completely small rounded blue cells. Yeah, yes, on children. So usually seen in children and first decade. And this is the thing which we see in the diaphysis. Ewing sarcoma is diaphysis. Yes. And then this is your osteosarcoma. This is second decade. Yeah, that is all you can read in your pathology, the glycogen positive, your past positive and all. CD99 was also right. This is in the second decade, the osteosarcoma, right? And here what you see, two important things, the Codman's and then sun ray. Okay. And on the biopsy, what you see is osteoid formation. So this is a bone forming tumor. So this is an osteoid formation. Okay, so this is osteoid formation, and treatment here they start with chemo, surgery, right? So this is a neoadjuvant chemo, and then there is an adjuvant chemo. So there are 3 stages where we treat it. Okay, and then what is this? Multiple spots. So this is one of the most important things. Yeah, ABC and GCT usually we get confused, but what you have to remember is bubble appearance in epiphysis. It is encroaching on the joint. So whenever you see the X-ray, you will see that the joint is encroached. ABC, it is metaphysis. So anyways, we go for MRI. So in MRI, it will be very clear. Yes, this is multiple myeloma. I think you all know better than me the multiple myeloma, right? Your CRAB criteria, your immunoglobulins, your plasmacytomas. Okay. So there is involvement of the plasma cells where they produce abnormal immunoglobulins. So the patient will have increased infections, hypercalcemia features, and usually seen one of the most common tumor in the adults. And you will have this. And you will have this spots which are called as punched out lesions. This is called as multiple myeloma. Called as multiple myeloma. Yes, M band. It's M band. There's again problem with the iPad. I think that is the last slide. Oh, there's a continuous charging. But just give me a minute. After revising last 2 weeks, so this book, I mean your workbook, you keep revising the workbook whenever you have time. and keep asking your friends. Right? So, hi Guram. So that is it. We are done with the workbook. I'm happy that I have completed in time this time. So it is 9 and we are done. So that is it from the orthopedics end. Any questions you have? So have to revise in the last 2 weeks. So this is what we have come up with the workbook. So this workbook you have to put handy and keep revising the workbook. If you find anything was missing and you want to add, you can add it then and there itself and you keep revising. Okay? Anything else? Any topic we have forgot? Yes? Are we done? PYQs are included in this. Okay? There's no separate section called PYQ. Every topic what we have given is a PYQ itself. So it is an integrated PYQ. Okay? Class over, yes. Reset, restart and refocus. The class is done. So if you want anything else, we will add. Yes, this will be available in the YouTube. Anytime you can go get back and see. PDF will be available in the Telegram group. So you can join the Telegram group and you can take the PDF from there. Okay? Whole ortho in short time, Ajit. So see you all. Bye. Take care. Thank you. Thank you. Bye. Anything you can ask in the DM, that is Dr. Alekhya Ortho on the Instagram or the PW Meded. Okay. See you all. Bye. All the best. Do well. Get back to us with the questions what they have